amagama ayethunyelwe yisektayo ayethunyelwe ngubani amagama athunyelwe yisektayo athunyelwe ngubani amagama athunyelwe yisektayo ayethunyelwe ngubani amagama ayethunyelwe nguTAC mandla 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 awethu siyabonga maqabane. We are going to start now the meeting, but before we start the meeting maqabane, we have couple of requests. Izicelo ezifew. One, we've got colleagues who have joined us online, and there is a camera which is supporting the live feed. So these colleagues are asking us, ukuthi thina people who are here, can we put our phones, one, on silent, so that we do not disturb people who are watching from line. And two, we are being requested, ukuthi, when the meeting is proceeding, we don't take our phones and take our pictures, because it will be disturbing there. Like Maukibeli flight. Before the flight takes off, they tell you put your phone on flight mode so that you do not interrupt signal and all what have you. The same thing is going to happen if we continue taking pictures whilst the camera is on. And we can find our videos on YouTube. You just go to YouTube and write Ritshidze. You will see everything there. And our comrade and all of us who are being requested that when someone is talking, let's not have our own conversations here, because us talking when someone is on the floor, it is going to make noise and all of us will be disturbed. And then 3, colleagues and comrades who want tea, you can go around quietly, so grab a cup of tea, come and sit down and continue with the meeting. And also, can we please make sure that when we go out and in, we do not disturb the camera, we just take another side. So, colleagues, my name is Anele Yawa. I am the General Secretary of Treatment Action Campaign, as well as the Chief Accounting Officer of the Ritshidze Project. Ritshidze Project is a consortium of 5 organizations of people living with HIV, which is NAPWA, Sanarela, Positive Women's Network, Positive Action Campaign, and Treatment Action Campaign. Ritshidze is working in 400 clinics in 8 provinces and 28 districts, and all these facilities are the ones that are funded by PEPFAR. As Ritshidze, we are not doing a research or whatever. Our duty as Ritshidze and people living with HIV, we took it upon our shoulders to monitor the quality of services that are rendered for people living with HIV, TB, key populations, as well as the general public, to assess whether the services that are given to them are of a good quality or not, in order for the majority of people living with HIV and TB to be able to remain on treatment. And also, through that process, as Ritshidze, it opened some opportunities for us to be able to engage with the duty bearers, facility managers, pharmacists at facility level, district chief directors of health, HODs of health, DDGs, MECs, and ministers. That's why even today we are expecting to be joined by MECs and others will join us online. And we're expecting, if possible, the minister to join us today. We have not yet heard any changes. But also, through this Ritshidze, colleagues and comrades, Ritshidze, it is on the side of people living with HIV. It is on the side of gays, lesbians, transgender, sex workers, people who are using drugs, MSMs, and the general public. Because in South Africa, we've got a constitution, and Section 27 of the constitution gives us a right and a guarantee to access quality healthcare services. And the worst part of it, yesterday, the National Council of Provinces approved the NHI bill. The NHI bill, it is all about universal health coverage and quality of services. But through the work that we have been doing, we have seen, we have heard, we have witnessed majority of the people who are disengaging on care coming forward to these meetings, giving personal testimonials as to say what made them to disengage from care. What made them not to use that clinic anymore and decide to transfer themselves to another clinic. We have yet people living with HIV and key populations coming here telling us how they feel undermined and disrespected in some of our clinics. Sorry. Where their status is disclosed by some of the nurses without their consent. Where people are stigmatized and discriminated based on their gender orientation. We have heard how people who miss an appointment to collect their treatment, and when they go to their facility the following day, how are they punished in our clinics and made to stand right at the back of the queue because they have missed appointments. We have heard when people are relocating from this community to this community, when they go to the clinic in the new community, and they are asked to produce a transfer letter. And if they don't have a transfer letter, they will be denied antiretroviral treatment on that particular day. Yet, we are being told that we must adhere on treatment. And then, if you are to adhere on treatment, you must have treatment available. And then when you are denied the treatment because you do not have a transfer letter, it therefore means your rights as a patient are violated by those who are not giving you what? Your treatment. And those ones are making us to default. We have yet, colleagues and comrades, the Minister of Health telling us in Durban this year in June to say the government has signed the policy of multi-month dispensing of medication. But when we go down to our clinics, you find out that people are still given sometimes 1 month treatment. If there is a shortage of medicines, you will be given a 1 week treatment and be told to come back again. Here today, we have this meeting. This meeting is a first of its kind, organized by Ritshidze. We have been organizing provincial community accountability meetings. We have been organizing district accountability meetings. But for the first time, we are organizing a national accountability meeting, where now we are not issuing a report based on a specific province, but we are issuing a report which gives reflections on what is happening in the country with regards to our response to HIV, with the hope that these continuous engagements are going to yield positive results that will benefit the majority of the people. I can proudly say here now, as I'm standing here, the advent or the arrival of Ritshidze has saved many lives. The department can attest to this. Facility managers can attest to this. And majority of the people in our communities can attest to this. Where, when people were denied treatment, we made sure that they are given treatment. where people were chased away from facilities because either they missed appointment and all that stuff. We had to intervene to make sure that those individuals get treatment. I am told, but Comrade Shandu is here. You know, we had a problem, Comrade Masilo, when we had a district camp of Ritshidze, Comrade Eric in Pietermaritzburg, where one comrade from the key population sector who is accessing a treatment at East Boom Clinic, which is one of the centers of excellence in Pietermaritzburg. When this comrade told us that how she was ill-treated because she was a sex worker, how she was discriminated. The good thing, in that meeting, there was a district chief director. And we made sure that on that day, the matter is brought to the attention of the district chief director. And I can safely say, all those problems that were raised in Pietermaritzburg, the district chief director of Pietermaritzburg is working on them. And I'm told that some of the colleagues from Ritshidze and TAC got calls from facility managers to say, how can we get the conduct of this person who gave testimony on this? And colleagues assisted to get those contacts, and those people, all of them, are back to care. And also, on the 30th, last week, Thursday, we had a meeting in Durban, which was honored by the Minister of Health. And the Minister of Health promised us many things, including 2 days back, the minister was having a meeting with all MECs of health in the National Health Council Forum or whatever, but it's a National Health Council, where the minister presented to the MECs the Ritshidze reports, findings, and all what have you, in order for MECs of various provinces, Director Generals and HODs to start working with the minister in trying to attend to the challenges our people are faced with. Because if these problems are not attended to, it therefore means the NHI, which was passed by the NCOP yesterday, it will be like a dream that has been deferred. Because you cannot talk about NHI, yet you still have nurses, some of them who are ill-treating people in our health establishments. Yet you still have nurses who are violating the rights of the people as enshrined in the Constitution. So we are saying fixing the state of HIV response and TB in South Africa cannot be done in isolation to the implementation of the NHI. The only way as people living with HIV we can see that NHI is working is only when services that are meant for HIV, TB are improving. And people are not disengaging from care due to staff attitude. People are not turned away from clinics because they don't have transfer letters. People are not sent at the back of the queue because they missed appointments. We want to see a society and healthcare users who, when they wake up and go to the clinic, they wake up with a smile. And when they come back with a smile again. But as it stands, in some clinics, on the day that you are supposed to go to the clinic, you wake up with a lot of stress because you do not know what to expect in the clinic. Either you will be shouted, you will be done this and that and that. And at times, people are made to wake up as early as 4 a.m. queue in those clinics, walk out of the gate at 3 p.m. without getting any food. So that's why we are saying, when we're talking about Section 27 of the Constitution, we must talking about Section 27, A, B, and C. Because there, within Section 27, we are told about our right to access healthcare services. We are told about our right on sexual reproductive health rights. We are told about our rights to access to water. We are told about our rights to food security. We cannot wake up as poor people, queue there in the clinic at 4 a.m. The clinic is opened at 8. Nurses walks to tea at 9, you are sitting there. At 1 o'clock, they go to lunch, you are sitting there. We, as people living with HIV, TB, we must demand that we need to be given food parcels. because it is within our right, within Section 27. If politicians are able to take food parcels and give them to people in our communities in order for them to get votes in return, therefore we must stand up and demand that we cannot take ARVs on an empty stomach, yet we've got Section 27 that gives us rights to food security. We need to stand together. We need to stand together and fight for our rights. That is the only way we are going to fix the problems that we have as people living with HIV, because majority of people living with HIV and TB are poor and unemployed. Yet they are expected to adhere on treatment, take treatment on an empty stomach. Yet we've got politicians who will dish out food parcels to people who are well off, and we leave the impoverished and needy communities to fend for themselves. It is up to us to stand up as one man to say no and stand up for our rights. To stand up for our rights, it also talks to the responsibility of the government, but also to our responsibility. So that's why we have this meeting. We have people from different provinces here, because we have been having community accountability meetings in various provinces. So we said, let's bring people from various provinces to come to this meeting and be able to give their personal testimonials in order for all these issues to be attended to by those in authority. It is our wish that every time we have these meetings and after these meetings, whatever that is being promised to us in these meetings is delivered, so that our people can be able to see improvement in our clinics. Because Tina, we are poor. And as poor people, we've got rights that are protected in the Constitution. Therefore, I cannot be made to feel as if when I go to a clinic, someone is doing me a favor. There is no doctor or a nurse that is doing us favor, colleagues. They are doing what they are hired to do and what they are supposed to be doing. And they are being paid by the state after that. Therefore, this element of us being ill-treated and reduced into third-class citizens when we go to clinics and we are made to beg nurses in order for us to be able to save our lives must come to an end. This thing of when people living with HIV, TB, and other illnesses miss appointment dates, and when they go to the clinic the following day, they are made to stand right at the back of the queue. The Minister of Health promised us that this is going to be abolished. That's why when we go back to our clinics and our communities, when we see a nurse either telling you or someone else that you missed your appointment, go right at the back of the queue. Immediately report that matter. If it means you must give call back to the colleagues of Ritshidze and others from the PHIV sector so that we can report that nurse, let it be. But you, as an individual, you've got a responsibility to tell a nurse that if you say, I must go right at the back of the queue because I missed my appointment, rather all these people don't get treatment. I'm not moving here until you give me my treatment. We need to use our anger in order for us to improve the quality of services. If we're going to go there and be complacent and listen to these people when they ill-treat us and take it as if it is normal, therefore we are failing ourselves and generations to come. So that's why when a nurse is telling you that you missed your appointment, go right at the back of the queue, tell the nurse that I'm going nowhere. You rather call police, call security, and let me be arrested. We rather be arrested for fighting for our rights. So, even this thing of letters, transfer letters, it is upon us to make sure that it is being abolished, because it violates our right to access healthcare services. It violates our rights that are enshrined in the National Health Act, because the National Health Act says no one may be refused medical healthcare services in a health establishment. But when you are being turned away because of not having a transfer letter, it means you are being denied services. Therefore, we must stand up and fight and say, with transfer letter or no transfer letter, I'm going nowhere. And also this issue of our medical files keep on missing in these clinics. It's another problem that we need to work with the minister, MECs and officials to make sure that we fight it. Because when your medical file is missing, it therefore means your medical record is missing as well. So, my apologies for making State of the Nation address, but I was trying to bring all of us together to understand Uguti, where we are and why we are here. So now I will hand over to, hey, I even forgot to introduce the comrade. Comrade is going to introduce herself and then give James to us introduce and then you proceed.
Thank you, GS. Sanmanan. Igama lami nguMary. I'm one of the project officers esebenza no Ritshidze.
Good morning, comrades. My name is James. I am a senior researcher with Ritshidze in charge of the Key Populations Program and also a member of TAC.
Today's presentation uses data collected through Ritshidze community-led monitoring and through branches of the Treatment Action Campaign. Ritshidze monitoring takes place on a quarterly basis in 400 facilities across 8 provinces. Today, we will be deep diving into both the progress and challenges across the country and hear directly from people living with HIV, people who use drugs, sex workers, the LGBTQIA+ community members, and other public healthcare users to the real experience using our clinics. Data is collected through observations as well as interviews with healthcare users, public healthcare users, people living with HIV, key populations, and healthcare service providers, which are, for example, facility managers and pharmacists. TAC also collects additional data in information through more than 250 branches across the country. Our members are the people who need the public healthcare system to work, so they are the first to notice when it doesn't. The data in this report was collected between October and November 2023. Interviews took place with 418 facility managers. Observation took place at 419 facilities. Interviews took place with 22,543 public healthcare users, 51% of which identify as people living with HIV, and 15% identify as people who are under 25 years of age. Additional data was collected between July and September 2023 among communities of the key populations. Interviews took place with 2,616 gay, bisexual, and other men who have sex with men. 6,106 people who use drugs, 3,721 sex workers, 1,425 people identifying as trans. We will present some of our preliminary analysis today, and our full report will be launched early next year. The first group of issues is going to speak to staffing and waiting times. The shortage of healthcare workers in public healthcare sector remains a crisis. Ensuring that clinics and hospitals can provide quality and reliable health services depends on having enough qualified and committed staff in place. Yet, while this has improved marginally from last year, Ritshidze data reveals that 44% thought there were always enough staff to meet the needs of public healthcare users in clinics. From the perspective of the facility, only 25% of facilities monitored reported that there were enough clinical and non-clinical staff to meet the demand. There remains a long way to go to fill the human resource gap in South Africa's clinics, as 75% of facilities monitored remain with too few staff to meet the demand. 29% of facilities blamed staff shortages on there not being enough open positions. According to facility managers, the most commonly understaffed cadres were professional nurses, and enrolled nurse assistants. In the last round of monitoring, 1,334 vacancies were reported across 225 primary health facilities, and 37% of facilities blamed staff shortages on one or more unfilled vacancy. The highest number of vacancies by cadre are by far professional nurses with 558 vacancies. This was followed by 192 enrolled nurse vacancies and 116 enrolled nurse assistant vacancies. 59% of facilities were calling on US donor PEPFAR to provide additional clinical staff, but PEPFAR's funding for critical human resource posts has only reduced in recent years. The knock-on effect on the staffing crisis is for people to wait many hours to be seen at a public health facility. Positively, average waiting times have reduced by just over an hour in the last year in facilities monitored, down from 4 hours 10 minutes on average to 3 hours 7 minutes waiting time at the facility. This includes the time before the facility opens. Waiting times after the facility open have also reduced from 3 hours 59 minutes to an average of 2 hours 52 minutes after the facility has opened. However, waiting times vary dramatically across districts, while King Qetshwayo in Zululand, Uthukela and Mopani all had waiting times under 2 hours. Other districts, including Alfred Nzo, Cape Town, Thabo Mofokeng, Lejwe-Leputswa, Bojanala Platinum, all had an average waiting times over 4 hours. While there has been improvement since we began collecting data through Ritshidze, waiting all day at the clinic remains an exhausting and frustrating reality for too many people. 50% of people still complained that waiting times were too long. 49% of public healthcare users blamed long waiting times on shortages of staff. 33% blame the staff not working or working too slowly, and 40% blame the fact that it takes too long for their files to be found or the filing system is messy. 90% of public healthcare users were aware of a clinical appointment system. However, only 19% reported getting both a date and a time. 76% reported getting just the date. This means people arrive early in a cluster in order to get seen at the clinic's This means people arrive early in a cluster in order to get seen at the clinics before the afternoon. Appointments could be spaced out throughout the day to ease congestion. Instead, we hear reports of people being turned away if they arrive after midday. Ritshidze data also reveals that only 49% of people reported getting an appointment reminder ahead of their appointment. The average earliest arrival time has improved slightly from 5:43 a.m. last year to 6:02 a.m. this year. However, again, this varies widely across districts, with average waiting arrival times of before 5:30 a.m. in Dr. Kenneth Kaunda, Bojanala, and Tshwane. When we look into specific facilities, the average arrival time can be much earlier. People begin queuing early in the morning in the attempt to get seen more quickly. Of the people who arrived before the facility opened, 17% reported feeling unsafe or very unsafe while waiting for the facility to open. While the circular was issued in May 2019 by the National Department of Health calling on facilities to open by 5 a.m. on weekdays, this has not happened, and people are forced to wait outside the clinic grounds in unsafe conditions in order to get health care or just to pick up a medicine refill. Commonly, facilities tell us that they are unable to extend opening hours due to insufficient staffing to cover this time. Yet, only 62% of public healthcare users think that the facility opened for long enough, and 49% think that the facility opening times should be extended. Delays at the clinic are only exacerbated by chaotic paper filing systems where staff struggle to locate people's medical files or lose them altogether. Filing systems were observed to be in a bad condition in 30% of the sites, mostly due to filing rooms being too small to maintain the filing system or the filing system being messy. 40% of people who thought the waiting times were long blamed messy and disorganized filing systems. This only adds to the delays and forces people to open new files and lose their medical records. Some public healthcare users are even blamed as if they had lost their own file or told to go into the filing room to find the file themselves. Others report being denied services entirely if the file cannot be found. We are going to have the community stories.
and then exile I do.
I don't know the
It's a
details,
pretty
but-
sick high. I'm the get you want to file high, I told her. What give you like a police? You know, to the police, the ARV. I require that they long one has to get a manta. You have to put some chain, or to the fish level saying, how fish are saying, but whoever which you bana le batho ba bona banka khatitsa batho ba ba tsebang ke tsetetse clinic se mo se fetseng one hands ke ntse to file ya ka hae ho bileng sister la ba botsa ka mjwetsa a rena ho bane ga file hao ke le sio ba sa etsetse file eo ka re sister ke tsebe a re mosane mo tseba di number hao ka re ya sister ka re ke tsebe ke mono ntho no ntse re han bo bane ke a bona ke a fokola mmeleng hobane le dijo hae a ke sa dija ke gore se ke ja hanyane and ke la ka tsa go khutlela clinicing ke thola go thola medication wa ka ke be hantle bophelong ha ke ile clinicing ha ke di thotse ke ikukwa happy ha ke sa di thola ha ke mona me ke nyahama hobane ke nahanela moa ka ke nahanela le bana le di khutsana tsa moa ka setseng le tsona
Zama treatment ya HIV. Ke tswa ka ke rata treatment ke ya ka 5 o'clock ka tswa ka mo hae ke ya stanza. E ke fitla ka mo stanza o tla emela file o tswa ka 11 or 12. Maro ile fru. Re late manager lena o no tshwana le batho ba berekang le bona ka mo. O tswa ka 6 after that o tswa ka 6 the treatment o a wa ikry. Ba tsa di file tsela ba di bia ona na ka mo. Ba re o tla ba ka boshiro. Ba no tšheleta o namela hape ke boela morago go ikira ka go re tshwantse ke tloe ka maoto ka ntlhela ke boe ke be ke tswele hape ke ntho e ntsotisa ngwisisa a ke hane gore ke tleliniki mara deo ba re tshwarang ka teng she's very poor madi ke a tsere ka kgwedi ya bo 5 gore ko ya go tleliniking after 3 months ke ona mo ba tlo nlokelela pampiri gore nna ka titšhekela gore madi a ka a bja fela ra titšhekela a zanga utlwa motho a re ba o mmotsa gore o tsamaile shapo le nna selfasheng ke bampotse go shapo ro bja
ndihamba iklinia lapha kuyo ndihamba ekuseni ngosisi sifika phaa ke siyihoye eklinia okanye singahoyi sibuye emalanga ngo-5 siye sikhwele imoto ibhatala i-R30 nobuya i-R30 i-R60 siboleke loo mali kwaye mhlawumbi singabinakwa imali yokhweza siboleke loo mali yoya eklinini sihambe ngalo hlobo kodwa eklinini singahoywa sihlale phaa silamba singanakwa imali yeklinini singanakwa imali yothenga iapile sihlamba njalo koko side kube sihambe sibe ku-5 wasemalanga bahlale kaloku abantu baninji ubhekwa ngapha nangapha abantu baninji ngoku singahoyi elo xesha uba ilayini inde sesifole elayini ibe inde kakhulu ilayini abantu baninji apho
ngisebenzisa izolo ekliniki ngihamba yona because I live vele eduze kwayo ikliniki engisebenzisa but guarantee angithathe as 100% sure clinic because bani attitude abonesi and kuba ne-disaster la ngoba nama-line sometimes you queue for a long time makufika ekuseni phuma wona ngo-5 6 have so na abana care nje la clinic ne-treatment sometimes awuyitholi exact bakutshela ukuthi hambe sithengela okunye nama-file this thing yama-file ayingiphathi kahle nokuzuza ukuthi ngise-clinic you come to clinic then bazolahla i-file kanjani but they put i-blame kuwo bona abayithathi i-blame bayachika bakutshela ukuthi okay ifile yakho uyilahlile hamba police station like abonesi nabo bazi ukuthi whenever i-attitude angathi ukuthi makazosebenza uza ne-attitude ayishiye endlini azi ukuthi ngizodila nama-patient lana njengoba kumele kube njalo.
We are going to have community stories.
Sanibona.
Greetings.
Mina ngiqhamuka eKZN, ngisebenzisa Nothing Clinic.
I come from KZN and I access services from Snatting Clinic.
So ngiphila negciwane lengculaza.
I'm a person living with HIV.
Mina ngumuntu obamba amatoho. So uma ngabe kuyi-date yami yokulanda amaphilisi ngike ngihambe ekuseni ngo-4.
I have part-time work that I do. So if it's my appointment date for my ARV collection, I leave early at about 4 a.m. in the morning.
Isizathu esenza ngihambe ngo-4 ngisuke ngenzela ukuthi mhlambe nginethemba lokuthi ngingashaya unani sengiqedile ukuze ngikwazi ukuthi ngihambe ngemsebenzini since ngitohoza.
The reason I get to the facility that early is with the hope that by 9 a.m. I would have completed my collection and I can leave for work.
Kodwa ke akwenzeki kanjalo since isinonesi esiphila nabo. Sifika ekuseni ngo-4 isango livulwe ngo-8 noma ngo-7.
So it does not happen as I have anticipated. We get there very early while the gate is still locked and we wait outside.
Uma ngabe sesivuliwe ke gate ngo-7 noma ngo-8 singene ngaphakathi baqale bathi bane morning prayer. After morning prayer bathi ba clinic meeting.
After they have opened the gate at about 7 a.m., we get inside and they tell us that they have to go for their morning prayer. And after the morning prayer, they will then proceed to their morning meeting.
Emva walokho i-meeting iqale mhlambe ize iphele ngabo 9 2:09 nihambe mengabe ufike eadmin uthi uyobhalisa ikhadi lakho ufike kuthiwe ifile yakho ayitholakali.
The meeting will then end around 9 a.m. You will then proceed to the registry where your file needs to be retrieved. And when you get there, you will sometimes get told that your file cannot be located or it's missing.
Uma ngabe usuchaza ke bese bethetho sister ukuchaza ukuthi bengithi ngizolanda amagazi ne-treatment so fanele ngifike ekuseni because amagazi athathwe ekuseni. Bathi ayikho into abazoyenza phela nabo ababona uNkulunkulu ukuthi bazobuyisa ifile.
So the nursing staff would then shout at you because apparently there's an allocated time where when you have to come and draw your bloods for viral load test. And when you explain to them that it's because of you were delayed by your file, they say they are not saviors and they cannot do anything to assist you.
So ugcine ungasayitholanga ifile kanjalo awutholi treatment awuthathi magazi kufanele ukuthi ubuyele ekhaya.
You end up not getting your file and you end up not getting the assistance that you require, and you go back at home not getting the treatment and taking your viral load test.
So into esesiyenzile ke sesizenzele igroup yabantu abathathu yokuthi sikwazi ukuthi sibolekisane ngamaphilisi.
What we did in our community, we formed a group of 3 people that we borrow each other treatment.
Ukuze sikwazi ukuthi siphuze so omunye mengabe nawo siyahlukaniselana mase ukuthi the following date naye lozothola wakhe sihlukaniselane kanjalo sesiphila kanjalo nje.
So that is how we live. If one does not have treatment, we share the treatment amongst ourselves, and when you finally go to the facility and get your treatment, then you would have to replace to those that have shared with you.
So sicela uRitshidze bandla angenelele nje kakhulu.
We appeal that Ritshidze should intervene to correct this. Thank you.
Sorry, Simpiwe. Can I get a clarity to which clinic is the comrade using?
Snatting Clinic.
In which district?
It's Umgondlovu district in KZN.
Tatushando, yourself, Simpiwe, and Mzam must attend to that matter. Next week, Monday, that comrade, or Monday is too far. Next week or this week, next week because we'll be here, comrade must get a treatment by Monday. If it means we must assist comrade with a taxi fare, take comrade to the clinic, let it be like that. If comrade is refused, immediately call the MEC and the district chief director and tell them that you are not leaving there until the comrade gets the treatment that she needs. Thank you. You may proceed, Simpiwe.
Thank you, Jess.
Morning, everyone.
Greetings.
Mina ndisuka Eastern Cape,
I come from the Eastern Cape.
OR Tambo district. Bendisebenzisa iStandford Terrace Clinic. Ekliniki ifile bengayifumani yalahleka sekuluthuba elide.
I come from OR Tambo district and I used to access services from Stanford Clinic. From the clinic, my file was lost for a very long time.
And xa yalahleka bebangunamapilisi ayi-2 okanye amathathu kuthiwa uphinde ubuye.
Since my file was lost, I would be given 2 or 3 pills and I would be told to return to the facility.
Then that decided uba mandiye kwenye facility esedutywa iNywarha Clinic.
I then decided to transfer to another facility in Dutwa area.
Apho ke bekufanele ube ndispende i-300 i-return.
I was spending 200 Rand return taxi fare.
Ndiye ndaphatheka kakuhle ke khona, but due to imali ingekho ndaphinda back ndacela i-transfer to Entaphane enye iclinic eseMthatha.
I was satisfied with the service there, but because I was spending so much, I then requested another transfer to another clinic named Entaphane Clinic.
Nakhona ifile ilahlekile. Iye ibonwa ngoMeyi kuphela xa nditsala amagazi.
Even at Entaphane Clinic, my file is lost again. The only time they can get access to my file is when I'm due for viral load testing.
Then xa sendibuya for uzothatha i-results andizinikwa, instead bandiprintela iphepha.
When I return after having taken the bloods for viral load test, I cannot see my results and I'm not told about my results.
I think i-solution kule nto ye-files ezilahlekayo eziklinik, ii-files maziyekho. Kusetyenziswe i-system, yonke into ifakwe ekhompyutheni so that xa useKapa noba uya kweyiphi indawo, yonke information yakho ibe phaa ekhompyutheni, i-file down. Because
my suggestion was that since they cannot manage the hard copies of files, that they must use a digital system so that if I enter a facility, they can just put in my details and see all my information. Thank you.
Good morning, everyone.
Greetings.
My name is Angela Chavani from Letlhabile.
Igama lami Angela Chavani, ngiphumela eTlhabile.
Today I'm going to talk about when I go to the clinic in the morning, I have to wake up around 4 to queue the line at the clinic, even though the clinic opens at 8.
Namhlanje ngizoshare story sami sokuthi mangiya eclinic funeka ukuthi ngifike khona ngo4 noma ngabe ngazi ukuthi iclinic ivula ngo8.
When I arrive at the clinic, you had to queue so that the lady at the reception window must take out, we must register our names.
Masifika eclinic funeka sibambe iqueue so that the lady o registeryo noma iclerk ithathe amagama wethu namafile wethu.
After doing that, they'll tell you that they are going at the meeting. They'll come back around 8.
Mabaqeda ukwenza lokho bazohamba baye meetingini bese babuya around 8.
After 30 minutes, the lady will come and collect the cards and tell you that we're going to take out the files.
After about 30 minutes, uzobuya lo sisi antshela ukuthi uzonikeza ama files bese bayahamba futhi.
To my surprise, I had to wait more than 2 hours to get my file for the first time.
Ngamangazwa ukuthi kwadingeka ukuthi ngilinde for 2 hours ukuze ngikwazi ukuthi ngithole ifile yami kwakuqala ukwenzeka lokho.
When I asked where is my file, they told me that I must tell the lady at the file room to look for the file. And then when I can't find it, they said my file is lost.
Makwenzeka lokho bathi ngitshele usisi lo osebenza ku file room ukuthi angibhekele ifile lami mangakwazi ukwenza lokho ngiye ku filing room yebo.
To my surprise, my file has been lost for 3 times. I had to go back home without getting my medication because I'm diabetic.
Okwangimangaza ukuthi ifile lami lahleke ihlandla ezintathu and lokho kwenza ukuthi ufune ngibuyele ekhaya ngingayitholanga umshanguzo engudingayo and mina ngomuntu ophila nesifo soshukela.
After a month, I had to go back to the clinic, and when I asked, where's my file? They said, my sister, we told you that the file, we can't find it. We don't know where are we going to write your information. We had to use a page.
After emva kwenyanga ngabuyela ekliniki bangitshela lokho ukuthi abakwazi ukuyithola ifile yami manje into abayenzile bangibhalele yonke imininingwane yami ephepheni.
I had to go back home to go and buy a 72-page book to take that page and paste it on my book so that they could write every information.
Ngize ngathatha isinqumo sokuthi ngiyithengele mina incwadi ye-72-page book so that ngizokwazi ukufaka le phepha abangenzele lona ukuze lingaduki.
And I'm happy doing that because I'm taking that 72 pages home every month when I'm getting my medication because I can't leave at the clinic, it's gonna get lost. Every time I wake up, I take it home and it's safe with me.
Lokho kuyangithokozisa kakhulu ngoba njalo uma ngiqedile ngalo lencwadi yami eclinic ngiyahamba nayo ekhaya mangibuye eclinic ngibuye nayo lokho kungenza ukuthi ngizizwe ngijabulile ngoba uma ngabe ikimi ikhuselekile futhi angeke izilahleke.
My only plea to the department and Ritshidze, I'm pleading, let us help the facility to make sure that our files are safe at the clinic and they must put it in order.
Engikucelayo ku Ritshidze na ku Department of Health ukuthi silekelele kakhulu emaclinic wethu ukuthi amafile wethu akhuseleke angalahleki.
I'll be much happy if everyone must having their files and every information is posted on their files because if we can't do that, our lives will be in danger.
Okungangithokozisa uma ngabe ngibona isimo lapho wonke umuntu angalahlekelwa ifile information yakhe yonke ihlale isafe ku file yakhe.
Ngiyabonga.
Thank you.
Comrade Simpiwe, khayba bekancane. Siswam, kukho la sisu unxiba izipecs pha kuthiwa ngunoloyiso. She's from Northwest? Where are you coming from, sis?
Itlhabile Northwest.
So, Siswam, here is Lutik and Mary. And Lutik, I'm going to give you the contact number of MEC Matota Sambata to report the matter. Tonight, before we sleep, you need to give me a feedback as to say, what is the response of the MEC? I think even the HOD, this matter must be brought to the attention of the HOD so that we can bring an end to this thing of missing files of patients. We cannot take it anymore. And if we do not stand up and fight for our rights, our files will get missing every time and again. So this case must be reported to the HOD and the MEC. I will assist you in reporting it to the MEC after this meeting, but you need to consult the HOD. We are going to recommendations, colleagues. 1, we want sufficient numbers of healthcare workers, including doctors, nurses, pharmacists, pharmacy assistants, communal care workers, lay counselors, peer educators, and even security guards and cleaners in our health establishments. All vacant posts to be filled and new positions established where demand is high. PEPFAR to support additional human resources through district support partners. 2, waiting times brought down under 2 hours across all sites. Appointment days and times used to spread out appointments throughout the day and ease congestion at clinics. Open clinic grounds by 5 a.m. so that people can wait safely in the morning. Facility pickup points that are a one-stop, very quick ART collection only. Visit under 30 minutes. No need to go to the registry. Collect folders. See clinicians. More external pickup points set up for people established on ART to be referred to closer to their homes. 3, filing system to be maintained in an organized manner to reduce lost files. No one blamed if their file is missing or told to find their own file in the filing room. This is a violation of confidentiality. infrastructural renovations to ensure that all clinics have sufficient space to maintain a functional filing room. The establishment of an effective confidential electronic medical record. We're going to James.
Thank you, GS. The next set of issues are on infrastructure and load shedding. Load shedding only intensifies problems at the clinic and can often lead to people waiting much longer to get their files, collect medicines, or consult with the clinicians. 61% of facilities struggled with finding files during load shedding, meaning people have to even wait longer to get seen. 33% of sites struggled with medicine getting spoiled during load shedding, while 73% of sites says data capturers cannot work when the power is off. Generators at each facilities or even load shedding bulbs could improve the situation, but only 55% of facilities monitored had a generator that was working and had fuel. Here we can see the availability of generators across provinces, with only 28% of sites monitored in Limpopo having a functional generator and only 5% of sites in the Free State. On top of this, some buildings in the public healthcare system are old and falling apart. 28% of facilities monitored were observed to be in a bad condition. The most common reason for poor clinic conditions were due to buildings being old and in need of renovation, or broken or cracked roof, floors and walls. Further, due to challenges with space, people are sometimes forced to queue outside in rain or shine, or wait inside overcrowded waiting rooms. Overall, 79% of facilities reported needing more space for something across the country, with many provinces above the national average. For example, 90% of sites monitored in the Free State needed more space. Waiting space, filing space, rooms for medical care, and rooms for private HIV testing and counseling were given as the most common things that facilities needed extra space for. This impacts negatively on congestion, TB infection control, waiting time, and the privacy at the clinic. On overall cleanliness, 72% of public healthcare users reported that the facilities were very clean or clean, while 5% reported the facilities were very dirty or dirty. Again, this varied across districts, with public healthcare users in Nkangala, Lejueleputua, Buffalo City, and Bojanala Platinum reporting the dirtiest facilities. 47% of Ritshidze observation found that toilets were in bad conditions. Most commonly, because clinics could not provide basic hygiene supplies like soap or toilet paper, but also often because they were out of order, dirty, or had no light. We now move to recorded stories.
Erin Clinic. Sing more than 5 years in Izalai Clinic. Umpumendlini was 7 o'clock. Ngizofika la 7:30. Ufika la 8 o'clock exactly umsebenzi awuqala. Sometimes bezibeqala ngabo 10. Sihleli ngaphandle la kuyabanda sibulawa ngamakhaza. Imvula iyanetha sinethwa imvula, as you guys can see. There is no shelter. And how many people are there? Less than 50. But it will take for the whole day to service all those people. People are fainting, especially like elderly people sitting on the sun. I will be happy if they can make a shelter here so that we can be under the shade. We are always complaining also about the shortages of nurses. We don't understand why in South Africa we've got the shortages of nurses. And some people are sitting at home with qualifications. We just need better service. Better service. That's the only thing I can say, a better service. And it should be quicker.
Ke sebedisa clinic ya Thabong Clinic. Ke ne ke na le mathata ka tsamaya clinic ya ba dutse ba ntse ba nkgutlisa ba re metsi hayo, nne motlakase ha uyo, nne ba mpolella go bo sister ba short. No. Nna le ya di-ARV no.
Ungamisa khona la ekliniki nenini lo shading yacima igesi sebacosha abantu bacosha ama-patient yebo bathi safety yabo ngaze ngababuza ngathi impilo yomntwana shuthi ayibalekanga ukudlula isafety ababizi ambulance system generator isebenzi.
Into endinothisileyo xa ndifika futhi again phaya kwii-toilets zakhona akukho manzi. Fumanisa uba akukho kwamanzi ezizinkini. Ndachama andifumani manzi akuhlamba zandla ndafumana intwanyana yayincinci yesephu ndazosula njengayo ndahamba naloo khontena injalo ndingayanayo ne-toilet paper uba ndosule loo khontena. Naso ke isitori sam. Indiphethe kakubi as a patient, especially ungabikho kwamanzi, especially amanzi nje nokungcola kwakhona. Into endayifumanisa kukungcola namanzi awekho kukwisa kula sasibhedlela sase-Blackstaff, because kaloku fanele kube toilet kube khona amanzi kube clean futhi. Sasisokola zonke phaa sizipatient sibaninzi, abanye abantu bekhohlela phaya, abanye bechama, nabo betshintsha nabantwana iipampasi phaya akukho manzi. Naso ke into yandiphatha kakubi endayifumanisayo nje. Ndazibuza uba inoba kutheni mhlawumbi kuba kungabikho manzi futhi nokuthi kungcole ke. Ingaske futhi kulo mcimbi wamanzi ke kuyiwe kwamasipala kuyocelwa uba like namanzi etanki. Cela uba ngoko bakwazi uba kuncedakala abantu. Azinto mna ndingayicebisa.
Feel like ana province ntho ngwe le nako mo eleng gore still motho khona tswana ka nako mo eleng gore sometimes ke try ke tswe ka ma 3 o di se ke motho re cover up a line but still lo tswa ka 3 o'clock o ba o bua ka 4 o'clock mo eleng gore a khona tlhaloganya re problem e ba ka ke eng mo eleng gore o tswa lata o no tswa ka 4 still o bua lata go rana na go eleng gore ka zama ro push re ke tswe fru and then ke khona o bua ka pele still ho no ba slowly mo le ka na go bo botsora na sentse re ya lunching like sometimes o thoma na go tsa low shading le ona go ba staraga mo eleng gore challenge.
We now move to community members that have joined us in house.
Molweni, ndinguNolisindiso, ndihlala e-Eastern Cape, eMdantsane.
Greetings, my name is Nolisindiso. I come from Dansane in the Eastern Cape.
Ndisebenzisa NU1 Clinic Philani. NU1 Clinic.
I access services at NU1 Clinic in Philani.
Into yokuqala esikhalazelayo NU1 Clinic sihlala phandle. Sifika ngo-6 siphuma ngo-6 ezindlini sizofika ekliniki ngo-7 akukavulwa kuvulwe after 7.
Our complaint with NU1 Clinic is that we get there around 7 a.m. in the morning and then we sit outside and wait for the facility to open.
Kuqalwe usetyenzwa ngo-8 phofu njengoba kuqaliwe nje sihleli phandle noba kuyanetha noba kuyabanda.
They start working around 8 and while we wait, whether we wait outside irrespective of the weather conditions, whether it's raining or we are sitting in the sun.
And into eyenzekayo ke ngokuba nenantsika ndandiyothatha i-treatment ndithathela mna nomntana.
I went there to collect treatment for myself and my child.
Nge-21st ka-August ndabuya ndingayifumananga.
It was on the 21st of August and I came back home empty-handed.
Ndayoyifumana nge-24.
I had to return and finally got the treatment on the 24th.
Ndafika kwakusasa njalo ndophuma 3:45.
On the 24th, I had to leave early and I finally finished at the facility around 3:45. Thank you.
Before we go to the next person, Comrade Noloyiso, in September, we had a meeting with the district chief director of Buffalo City. He is a good fellow with Mrs. Nokwe, the provincial district health, something like that. I think as TAC and other colleagues that we are working with in Eastern Cape, we need to make a follow-up meeting with the district chief director of Buffalo City and try to get a feedback as to say, how have they intervened in terms of addressing the problems that we raised to them, including issues which is similar to the one that Umama is raising. Because I believe that we as the people, we hold the power. And at times, a facility manager or a staff in a facility might be negative to a user of the healthcare services without the knowledge of those in authority. But if these issues are brought to the attention of those in authority, we might be able to see a change. But above all, comrades, more especially to TAC provincial leaders who are here, it is a crime for us to hear a complaint of a person, sit on it more than 3 days without us escalating the matter to the relevant people. We need to be in agreement about the turnaround time of bringing these problems to the attention of those in authority. Thank you.
Molweni.
Greetings.
Ngipheliswa Mpokoti. Ndisuka eMthatha, Eastern Cape.
My name is Pelisa Mpokoti. I come from Tata in the Eastern Cape.
The clinic Stanford clinic. Phaya ndalahlekelwa ifile. Noba ngunyaka wesithathu manje ngasayibona ifile yami.
I access services from Stanford Clinic. I have lost my file at the facility. It's been 3 years.
Ndaqhubela kudala kokutsala igazi because bathi ifile yami abayiboni. Ndibhalelwa ephepheni ukuze ngifuna ipilisi pha. Ndibhalelwe ephetshaneni nje lingacacanga.
I'm long overdue for viral load testing. When I go and collect treatment, they write my details on a piece of paper.
And into endiphatha kabuhlungu into yoba uba ndeke ndagula mhlawumbi bazawuthi ndidefaultile because andinafile, ndithatha nje ipilisi ndiphume ndihambe. Akho nto ixakisayo uba mhlawumbi ndiyazithatha iipilisi. So nazo into endiphethe kakubi mna. Uba ndizoya ekliniki intliziyo yami ibethele uma because akwasihoyo kwapha. Akho luhoyo lukhoyo pha.
What does not sit well with me is that if it happens that I should get sick, I would be blamed by the facility staff that I have defaulted on my treatment, whereas that is not the case.
And ke pha kumdaka kakhulu, so akho manzi. Antenenye mina ngiyafika pha kuthiwa amanzi akhona. Sihlala phandle nje.
The clinic is very dirty. Sometimes you find that there's no water. We also wait outside. Thank you.
Sanibonani.
Greetings.
Igama lami nguZanele ngoKandaba. Ngibuya eThembisa Healthcare Clinic.
My name is Zanele Ndaba. I come from Tembisa. I use Tembisa Healthcare Clinic.
Ngizokhuluma ngendaba ye-load shedding uma sisekliniki. Ukuthi uma kungahamba i-electricity kuba ne-load shedding, asitholi usizo ngoba kusuke kuhambe ugesi and njengendawo yase-waiting area kuma-filing akubi nokuthi kuyakhanya kuba mnyama, so sihlala isikhathi eside.
I am here to share my story on how the load shedding affects service in the facility. Areas like your waiting area, filing room are dark when it's load shedding, and that prolongs the waiting time because we have to wait.
If load shedding is stage 2, kwamele sihlale for 4 hours silapaya kuma waiting areas. So iba a problem enkulu because some of yama patient akhona lapha azengama emergent azengawo, then abanye ba nida ukuthi banakekele kakhulu. So kuba i-problem lapho because abalitholi usizo ngaleso sikhathi.
When it's stage 2 load shedding, we have to wait for about 4 hours at the facility, and some cases are emergency cases that need urgent attention, and people end up not getting the attention and the emergency response.
Maybe if sizama ukuthi sikhulume nabo sister sibabuzisi sibatshele ngalaba abagula ngalendlela le bazokuphendula bakutshele ukuthi ayikho into esingayenza thina because of kumnyama sizanibona mangabe kungukuthi igesi iyabuya then baphume bahambe.
When we bring this to the attention of healthcare workers that we are waiting with people who are in a critical condition, they would respond that there is nothing that they can do because it's dark.
Sicela ukuthi iRitshidze kanye ne department bakhona ukusinceda ukuthi kube ne generator because akuna generator. Maba ubuza bazokutsho ukuthi akuna generator. So ngoba kungana generator sicela ukuthi bakhona ukuthi basize ukuthi kube ne generator ukuze sikwazi ukuthola usizo ngesikhathi nabagula serious bakwazi ukusizakala ngesikhathi. Ngiyabonga.
We appeal that Ritshidze and the Department of Health intervene in that the facility be given a generator so that the service is not interrupted, all the emergency cases can be attended to, and the waiting time can then be reduced.
Thank you. Before we go to recommendation number 4, I just want to announce that, comrades, there are a lot of officials from the Department of Health who have joined online and other few MECs. But also on the issue of load shedding here in Gauteng, the provincial chairperson of TAC in Gauteng had a meeting with the MEC and other officials from the province around the issue of load shedding and generators with fuel. But when provinces are coming to reflect, he is going to give us an update on that. But there is something which is being done in Gauteng to address the issue of load shedding as well as the availability of generators. Number 4, recommendation number 4. What do we want? We want plans in motion to renovate buildings and ensure adequate space to provide efficient, private and safe healthcare services. All public healthcare users to always be consulted, tested and or counseled in private rooms. All facilities to be maintained to the highest standards of cleanliness, including through implementing regular cleaning routers and soap and toilet paper provided in all clinic toilets. You know, comrades, as we are going to number 5, okay, let me read number 5. All public health facilities to have a functional generator with sufficient fuel, rechargeable bulbs, and other useful load shedding devices so that health services and administrative work can continue during power outages. So we're going to the next item now. But what I want to say, in South Africa, we've got an institution which is called Office of the Health Standards Compliance, which I serve on it as a board member. The duty of the Office of the Health Standards Compliance is to enforce compliance to norms and health standards. They normally inspect health establishments, and those that are compliant, they are issued with a certificate of compliance which is valid for 4 years. And in order for a clinic to qualify under the NHI fund, a clinic must have that certificate. And the question we must ask ourselves, how many clinics, if all of us, we are speaking with one voice, government, business and civil society, and say we want NHI as of yesterday, the question we must ask, how many of our clinics are ready to implement NHI? If NHI was to be implemented tomorrow, out of 3,800 clinics we have, how many of those that can be ready to implement NHI? We need to work with our government to make sure that we improve the quality of our clinics and infrastructure so that all our clinics can be ready to implement NHI anytime our government is saying we are going to implement NHI, because if our clinics are still in shambles, it therefore means those clinics will not qualify for the implementation of the NHI, which at the end of the day, again, we will be the ones who are going to suffer. We need to push, work with our government, and also sit down with the Minister of Health and MECs and say to them, stop this thing. Whenever there are financial constraints within the department, you take money that has been set aside for the renovation of buildings and building of new clinics. We want more clinics with enough space. So if our government always, whenever there are financial problems in the department, they take money that is meant for renovation of clinics and building new clinics, it therefore means we will always have the problems that we have in our clinics. Thank you.
Thank you, GS. The next set of issues is the national health insurance. As TAC, we support the establishment of a universal health coverage system in South Africa. The aim to make healthcare funding more equal and accessible to all underpins the values of life, dignity, social solidarity, and risk sharing that Treatment Action Campaign fully believes in and supports. The National Health Insurance, or the NHI, was planned as this promised land of healthcare. Sadly, though, as it stands, poor structure and implementation means that the universal health coverage won't be achieved through the NHI. We'll now hear from one of our comrades on the challenges surrounding the NHI.
We state at the outset our unequivocal support of the notion of universal health coverage. Having said that, we believe that the legislative process of the NHI bill, which is aimed at moving towards universal health coverage, is occurring in a manner that is leaving gaps in the gap that could undermine its implementation and in turn access to healthcare services. There has been a failure to put in place significant checks and balances for the exercise of power, which constitute a great threat to the independence of the fund and its proper functioning. A lack of inclusivity also means that health and lives of undocumented persons, asylum seekers, and nationals from SADC states who enter South Africa illegally are at risks. We have noted that the health system is at a point of a particular weakness, and the NHI will not in itself solve the dysfunction plaguing our public healthcare system. Well, it is hard to see how the NHI will work when so many questions remain unanswered, risks not only further damaging the already frayed trust between various stakeholders in health, but also putting in harm's way the elements of the health system. We believe NHI must go hand in hand with a new era of professionalism and end cage deployment.
Thank you. We're going to the recommendations. I hope that the MEC's officials, if the minister is online, are listening to what I'm going to say. We wanted NHI about 10, 12 years back, and we want NHI. We do not want NHI because it's a fancy word. We want NHI as a guarantee that our constitutional right is going to be protected, which is enshrined in Section 27, which gives us a right to access quality healthcare services. And then in that process, we are willing and prepared to work with our government to ensure that NHI is implemented. We are willing and prepared to work with our government to root out all the corrupt people in the system, because if we do not root out the corruption within the system, the money which is meant for NHI and to purchase health services and goods will be stolen by the corrupt and greedy ones. So that's why we need to work with our government to guard against NHI being sabotaged. We know that there are individuals who do not want the NHI, and the majority of these individuals who do not want the NHI, they are using private healthcare services. We know about the people in our clinics who are stealing medicines. And those medicines, when they are stolen in our clinics, we are the ones who get deprived. They steal these medicines and go and sell them in our community. We want to work with our government. If it means we as the community, the users of healthcare services, we must be the eyes and the ears of government and report any corruption that is taking place. Let it be. The recommendations are as follows. What do we want? That is number 6. We want an NHI that is an inclusive system that protects the most vulnerable and marginalized, with adequate checks and balances that will protect the fund from greed and corruption. 2, a new era of professionalism and an end to cadre deployment in the public healthcare system. We go to the next one now. James.
Thank you, GS. The next group of issues are on ambulances and our planned patient transport system. We have all heard stories like this or experienced it ourselves. Too often, ambulances take many hours to arrive. That's if they arrive at all. Critically ill patients and people with pregnancy complications are forced to wait or to hire private transport at prices that they cannot afford to take them to the nearest hospital, leading to many avoidable deaths. For members of key populations, especially people who use drugs, there can be additional challenges in getting emergency medical assistance. One person using drugs said to me that they have no time for us. They call us names like paras. If one of us is sick and you call the ambulance, they will tell you they cannot come. There are 3 guys that have died on the streets last year because we could not get them to the hospital or clinic on time because of the ambulance refused to come. This was in Escort in Utukela. It's not only emergency services. Unreliable and unavailable patient transport system also impacts on people's ability to adhere to HIV and TB treatment or access other healthcare services. In rural areas, many people must walk long distances to clinic and hospitals or for fit appointments, which may have long-term consequences on their health or on HIV treatment and adherence and TB treatment completion rates. We move to community stories.
Greetings. My name is Mantam Taung and I'm here representing the community of Verkekerskop and the farms nearby. We don't have a clinic in the area. We get services through a mobile clinic. Sometimes the mobile clinic does not come, and the people from the farms would have to travel to the nearby towns to get treatment from the clinics there. We also have an ambulance challenge. Ambulance e tlameng go thusa ke ya warden kapo ke ya Friede kapo ke ya Harrismith kapo memele re mahareng a tropo tseo tse four. We actually don't know which ambulance needs to assist us, whether from Warden or Harrismith or Memel and Friede. Ambulance ha re di founetse banka na go etelele haholo go fihla di plasing mo ikanka bo 4 hours 3 hours to 4 hours. When we call an ambulance, it takes a long time to arrive from the farms, either 3 to 4 hours. Last month una le incident e nngwe ile nge etsahala auso mongwe una tlameha ho ya sepetlele a lo pepa. Last month there was an incident where there's a lady who was in labor.
Re ile ra mo thusa ra founela ambulance. Ambulance ha e fihla. E soka e fihla ho yena. Ba founa ba kopa hore ba latuwe.
Before you finish.
Sabotage. You may proceed, my lady.
So before the ambulance arrived, they called to say we should fetch them from a nearby spot.
So ho na le abuti a ileng a nka pere a tsamaya a lo ba lata.
There's a gentleman who got on his horse and went to fetch the ambulance.
Ha fihla mo ba eme tseleng ho na le metsi ka pela koloi ana tletse ka ga tsela.
When he reached them, there was a pool of water, and the ambulance was standing before that pool.
Ba kopa motho o a tlileng ka pere hore a kgutlele hae a lo lata ausi o a lo pepa a tle le yena ka pere mo ambulance mo e leng teng.
They requested that the guy who came on riding his horse should go back home and get the lady who was in labor, bring the lady to them.
Empa abuti o ile ba jwetsa hore a le ha tsela e tletse metsi koloi ya khona ho feta mo le kana la feta la tla le nna ka lo bontsha mo ausa leng teng.
The guy refused and told them that even though there's water on the road, the car can pass by. They must pass with their car and go and collect the patient who was in an emergency.
Kannete o ile a feta koloi ba ya ba lata mmeo a tlamehang ho pepa ba tsamaya le yena.
They then went with their car and fetched the lady who was in labor.
Ne re kopa kannete ho Ritshidze le TAC le Department of Health hore re le ha ba ka eketsa di mobile clinic le di ambulance ditoropong tse haufinyana hore ha re founela ambulance at least ambulance ho bena le ambulance tse ding tse tla servisa batho ba di-place fela hobane di-place di arohane haholo.
Our plea to Ritshidze, TAC and the DOH is that we have more mobile clinic or that we have built a clinic because it's difficult for people from the farms to access services. They have to travel long distances. Thank you.
Thank you. Once again, my comrades, I humbly request that we put our phones on silent so that when it rings, it's only you and your phone who can hear the noise. Comrade Jody, the provincial manager of Free State, you need to meet with Umama before the end of this meeting so that we can organize a meeting with the district chief director of that district and find ways and means as to say how best can they make mobile clinics available for the deep rural areas as well as those who are working in farms. I think we need to work together on this with the districts and make sure that we make mobile clinics available as a temporary measure, but as a long-term measure, there needs to be a clinic so that our people cannot end up being subjected to all these violations of their rights. Because one of the problems that I have, Comrade Eric, before and after these meetings, which I think that's one thing that we need to consider as well. Before and after these clinics, I struggle to sleep because I do not know what to expect from these stories. And after these meetings, the majority of us end up being disturbed psychologically and otherwise, which I think there is a need for a counseling for some of the comrades that I'm working with, because listening to all these stories makes someone to be angry. And when you get angry against your own government, you will be called names. We know that politicians do not have a hand to what the officials are doing. But what the officials are doing to our people makes one to be angry and want to fight back. But when we fight back, we are being called names. We cannot, after 29 years of our freedom, you see black people being oppressed, their rights being violated by the same black person. Something must be done about this. Because I do not want to use my anger as a community member to organize and mobilize community members to occupy those clinics and deal with the people who are violating the rights of our people. But those in authority needs to do something about this. We cannot go on like this 29 years after our freedom, where you have nurses and some officials who are violating our rights. The same nurses and officials, when they are sick and dying, they don't go to our clinics. They go to private hospitals. And when they go there, they make appointments. They don't spend even an hour in and out, they are gone. Yet our people are subjected to spend 6 hours, 8 hours in those clinics without eating anything. We must use our anger to fix the problems that we have in our country. We cannot go on like this. We cannot. What do we want? We want a reliable, available, quick, and quality emergency medical services and planned patient transport system in South Africa. We're going to the next issue.
Thank you, GS. The next group of issues are on ARV collection and continuity. Access to HIV treatment was at forefront of TAC's campaign when we formed in 1998. Today, in large part due to those campaigns, South Africa has the world's largest treatment program. But despite good HIV policies, still more than 2 million people are not on treatment, either never have started or having stopped. The HIV crisis continues because people live with HIV are being pushed out of care or avoid it in the first place because of conditions in the health system and the way they are always treated. Long waits at the clinic are one of the reasons that people are discouraged from going back. Yet a simple solution exists for people living with HIV to simply get a longer supply of medication. However, only 57% reported receiving a 3 to 6 month refill in the last round of monitoring, despite being required in the national adherence guidelines. While this is an improvement compared to only 45% getting a 3 to 6 month refill last year, it remains well below the 80% of people living with HIV in 21 other PEPFAR-supported countries who get a 3 to 6 month ART refill in 2021. Most importantly, South Africa's ART guidelines require all stable people living with HIV to get a minimum of 3 months ART refill at a time. We can also see that this varies dramatically across districts. Positively, more than 90% of people living with HIV reported a 3 to 6 month ART refill in Mopani, King Cetshwayo, and Amatole in this period reported. However, many districts are performing far worse, with as few as 15% of people reporting a 3 to 6 month ARV refill. In Cape Town, only 4% in Thabo Mfutsanyane, and only 1% in Dr. Kenneth Kaunda. Not only would multi-month dispensing mean fewer trips back to the clinic, making medicine collection easier for people living with HIV, but it would also reduce the burden on congested and overstretched facilities. In addition to longer ARV refills, another strategy to reduce waiting times is to allow people living with HIV to go straight to the pickup point, either at the facility or in the community, to collect their treatment. This can also reduce the burden of facilities and should make it quicker and easier to collect ARVs. We ask and count the location of collection point for the person collecting. In this reporting period, 26% of people living with HIV reported collecting at standard medicine dispensing still, 42% using the facility pickup point, and 28% using the external pickup point. Of people interviewed, 8% more are using pickup points compared to last year. Worryingly, however, of those still using standard medicine dispensing, 49% said that they have not yet been offered the option to use a pickup point or club. All stable people living with HIV should be offered a range of pick-up point options as per the National Adherence Guidelines. Again, this varies dramatically across districts, with 100% of people living with HIV in Amatole, 93% in Kangala, and 82% in Lijolipoto reporting that they have not been offered the opportunity to use a pick-up point. Further, 35% of people living with HIV said that they would like to collect their ARVs closer to home. Again, this varies across districts, with high numbers of people living with HIV wanting to collect closer to home in Bujanala, Cape Town, and Ugu districts. There needs to be enough pick-up points to decant people into, especially linked to rural and peri-urban clinics. Pick-up points should make it quicker and easier to collect ARVs. They should be a one-stop, very quick ART collection only visit in under 30 minutes. Yet, 62% of people using facility pick-up points told us that they must still collect files, take vitals, and see a clinician before getting their parcel, adding unnecessary delays. These pick-up points are not a true pick-up point. Positively, people are satisfied with their pick-up points, although more with external pick-up points than those at the facility. We need to increase the number and type of external pick-up points and ensure that true facility pick-up points are implemented. Once enrolled, every effort should be made to keep people living with HIV continually active. Reassessment should take place at each clinical consultation to understand if people are satisfied using the pick-up point or club. People living with HIV who are not satisfied or very unsatisfied should be offered a different option that better meets their needs. Once on treatment, it is important to recognize that people living with HIV live dynamic lives and may miss appointments and may even miss taking pills sometimes. When they do, the public healthcare system should meet them with support when they return to the clinic. But often when people living with HIV return to the clinic, they are treated badly. This makes people feel afraid to go to the clinic and can lead to some people stopping treatment altogether. Implementing the 2023 re-engagement clinical and adherence guidelines are vital to supporting improved long-term adherence and retention. And some people who return to care still need intensive clinical management. Others will need psychosocial support. The majority need it to be made easier to collect treatment. These people should be offered multi-month dispensing and the option to use pick-up points as quickly as possible. Yet, so far, only 63% of sites monitored say that PEPFAR district support partners have provided training and orientation on the new guidelines. Again, this varies across districts and different district support partners, with 100% sites in Amatole and Capricorn reporting being treated, but only 22% in Ritshidze and only 25% in Zululand, 38% in Mopani. Only 69% of people thought that the clinic staff were always friendly, although positively this has steadily continued to improve since the start of the Ritshidze data collection. Staff attitudes vary across districts, with a 90% or more public health care users in Mopani, Krisani, Nkangala, Ngakamudiri Molema, King Ritshidze reporting friendly staff compared to less than 40% in Dr. Kenneth Kaunda, Nkangala, Bujanala Platinum. It is important to note that because our interviews take place at the facility, people who have already stopped going to the clinic due to poor staff attitudes would not be at the facility for us to interview. While 50% of people said that they are welcomed back if they miss or are late for an appointment, those who go back to the clinic after a treatment interruption can also be met with hostility. 11% said that the staff shouts at them if they miss or are late for an appointment, and further, very few people report being offered a longer ARV refill or the option to use a pickup point, or even a discussion on how to make it easier to collect their ARVs. A further 9% reported being sent to the back of the queue if they are late for an appointment, which goes against the ART guidelines that clearly say that no punishment is allowed for a late or missed appointment. We need to normalize late and missed appointments without penalty. People who have come back despite being late or made it easier for the health system, it is not necessary to track and trace them and encourage them back into care. The person has stepped back into the facility, so that experience should be as supportive as possible. Just so. Psychological support is another critical element to ensure long-term retention. In the last few years, we have seen too many of our comrades dying, having stopped their HIV treatment, yet psychosocial services are few and far between in our clinics, often only offering pre- and post-test counseling. We need counseling for people living with HIV at any time throughout our lifelong treatment. We need support groups attached to facilities. We need food parcels so that people without food are able to take their medication. Community models of support must be strengthened alongside multi-month dispensing and external pickup points. We have some recorded stories.
When clinic, ne, sibisa mama when clinic, ke la treatment ka mo, mara nna ba treat hantle. Nna ke nka treatment ya ARV. Okay. Ba treat hantle, ke thola dipilisi ka nako ke batlang, mara nako e ntina nako mo ke motho thoela. Wa bona, so ka ba tshintshana go ba ngola 2. Nne mona na sister wo wa mama habane wo. Ke fita ke mo botsa ke re nka khona go thola dipilisi tsa bo 6 months or 3 months. Mara nne mona ka mfa tsa 3 months. Ka ba botsa ka re nka se khone go thola tsa 6 months because sometimes we do ke le out. Wa bona ke nka bona go mo why re tame re fole batho ba dipilisi re to e se fikile clinicing ha ka clinicing a ke ile fela go lo phaka fela be ke gutla so ke na fela ke se itse senyeo wa ke tame ke lo nka bo high blood bo eng BP eng tutse tse ngata tseo bona wa ka tshintsa the process e ba se bitsenyo ya batho ba dipilisi tme ba fole ke batla fela ba tshintse mo everything's fine ke a bua nna le bona.
Nna ke berekisa Tsholofelo Clinic nna ke no di ARV ane ke dinwa sentle tsone di ARV tsaka ha ke di tlodise so ke nentse ke ditsa go posong di jaganyana tse di fitileng tsele so itsa ke re ke ya go posong ke go tsa treatment eo ke ba mplela gore ke boele go clinicing so go clinicing ga ba ntlhalosetsa for gore ke boele go bone ene bothata e eng ke tle ba mpha di treatment la ke bo ha ke itumela go khutlela go posong ka gore go posong ha gona stress se ngata o tsena fela o bontsha o shupetsa appointment ya gago ba bontsha dipilisi tsa go ba go fa tsone bo boa
ngola Whiteville in community ngithatha treatment ye-HIV positive ama challenges engiyahlangabezana nawo eclinic ukungaphatheki kahle nalo kuhlalisa isikhathi singanakwa bayalena lena ne-attitude bangithethisa zange bakwazi ukukhuluma nami kahle so after that ngajela ubhuti wami ukuthi angisayi clinic ngiphatheke kabi siyasaba le attitude yabo abanye bagcina ba defaulter ngendaba ye attitude lokuthethiswa khulunywa nathi ngathi sabantu singane ezincane so ugcina end up so sabuke clinic uhlale yayibona enye into mele sinikwe isikhathi like baba kunika appointment mele bakunike nesikhathi ukuthi ufika nini because ufika lapha ngo 6 uyahamba later ntambama yebo uthi buhlungu kwesikhathi awuphethanga imali yokudla awunayo ene kusavaliwe neclinic kuvulwa nini ngo 8 ene sima kuphi ngaphandle
ngithatha i-treatment ye-HIV eWinnie Mandela Clinic. Uma ngabe ngifika ekliniki kuyenzeka ube number 5 or number 6 kodwa ke ugcine se uhamba la se ungene ngishabo ma 51 ugcine susemuva angazi nami ukuthi kanjani so ekliniki bakwenzele appointment uma ngabe bakwenzela appointment wangafika ngalelo langa, uma ngabe ubuya ngakusasa bayakunika inamba kodwa uba semuva bakusiza ekugcineni. Nami ngimise i-appointment bekufanele ngifike izolo, idate yami ibizolo. Uma ngifika namhlanje kwathiwa bazongisiza ekugcineni. Hayi ngiphathi kahle because nami ngivuke njengabantu bonke.
And clinic nokwenza after pill angikwenze double condom bese ngithola inkinga yokuthi abo sister labana ngithithise ukuthi kanti umsebenzi wami angiwazi. Okunye futhi mangilanda treatment mangitshela ukuthi futhi ubuye ngani ukuduba kwami ngeclinic azange sayi-attend amaphilisi ngihambe ngeclinic ngithatha yona i-treatment yama-ARVs khona lesiyekho angingeze ngazi ukuthi bazongiphatha kanjani ngoba vele angisayi noma ngifotograph ngiwacelela ebanganini ukuthi badla maphi nami sengiyaphuza ngoba nami angiwathuli ukuthi ngiyahlukumezeka vele eklinikhi.
Gama lami nguphelisa Ntshintshi, ndine-35 years. Ndihamba eklinikhi noNtyatyambo ndithatha i-treatment. So phaya ndiyakwazi ndifike phaa 6:30 kusasa sihoywe ngo-10 kube kuseza kuthiwa ngo-12 izawuba yi-low shedding. So sihlale phaa imini yonke kude kubethe u-3. So kwafuneka singenise incwadi ke ngoku kwelicala lase-dispensary kuthiwe masibuye ngomso. Ndiyakhwela ke kandiyaphaya ndandiphangeli ndingumntu wegrant. Ndibuye ndinazo iipilisi nangoku ndiyekile i-treatment yam ngenxa yaloo nto. Thatha ugqibela kwamthatha i-treatment bengoFebruwari. Ndabuya late oko ndandilindile ndabuya ndingayifumenanga i-treatment. Imali kuba ndibanayo kade. So ndavela ndaxoma ndisele ndihlala ke ngoku. Ndathi xa ndisiya ke ngoku phantsi uba uyashawutwa uba ungakhange uye ngelaa xesha. Ushawute uba idate yakho idlulile ntontoni uhlale ke usilinde.
Ngihlala eSnathing, ngisebenzisa iSnathing clinic. Ngidla ama-ARVs. Ngangaya ngedate yami ekwakumele ngiye ngayo. Ngaya emva kwa7 days namaphilisi asengiphelele. Ngafika ekseni ngabopha 6 ngoba ulayini uba mningi. Sibaningi naseklinikhi, istaff siyashota. Mangifika ngibamba ulayini kuze kube ngene reception ngabo past 9 mangikhiphela ikhadi. Usister bheka ikhadi lami and wathetha ukuthi umhlakabani namhlanje kwakumele ngize mhlakabani bengihlalele zonke lezi insuku. Uzogcina ngami. Okay, kwangiphatha kabi lokho ngahlala ngaphandle ngalinda. Kwashayo 2, kwashayo 3 kuyavalwa ngo4. Kwakuthi sekufika ukuthi kuyavalwa ngibuza ukuthi ayibo ngibona seniqoqa. Ngenze njani? Sengikhuluma nomunye angikhulumi nalo ekade ngikhuluma naye abuza ukuthi awuyini ubuzokwenzani ngisho ukuthi hayi usister engene kuyena wasewathi angilinde ngaphandle bazogcina ngami. Wangiphendula usisi ukuthi cha njengoba nje kuyilesikhathi bona sebeyama angiphinde ngivuke ngakusasa. So nje kwangiphatha kabi lokho ngavuka nangakusasa mangivuka nangakusasa ngihlala eminyango kuthi mase sekusetshenzwa ngabo 8 ngingene ngaphakathi ngisho ukuthi mina lo kade ufika izolo. Bangichika ukuthi ayi wena sogcina ngawe na izolo ngisho njalo ngisho ukuthi na izolo nisho njalo ngenze njani. Bagcina bengibonile nje kodwa bangibona late ngabo 2. Ave kuyinkinga lokwakungiphathanga kahle. Aye ngasekho nje kwangisukumisa ekhaya ukuthi aye ngasekho amaphilisi.
We are going to community stories.
Sanibonani. Greetings. Igama lami nguPhilisiwe ngibuya eMpumalanga Lebohang Clinic.
My name is Philisiwe. I come from Mpumalanga. I access services from Lebohang Clinic.
Into engizokhuluma ngayo la ama pick up points kahle kahle into engangiphathi kahle kakhulu.
What I want to share today, I want to share about external pickup points. That's a challenge for me.
Yeah, because last year umama mbekaye ephehlweni, so I had to be the one collecting medication yakhe.
Last year my mother was undergoing the initiation process, so I had to be the one collecting her treatment from the clinic.
Mind you, being a student, so being in convocation in the clinic and collect the pills. Maybe go to school and then go to the clinic.
At that time, I was a student and I could not go in the morning, but only after I have come back from school.
Bacon, pick up point, I think 2 years ago from Udok and Joe Private. Then all of a sudden, I change a law. Yeah, Valwa, Manja, I say, there's only one place. Marvel and Amapili, so yeah, a clinic. Whether we were sugar or one, we all go to a clinic very and you follow a line. That's someone to also look good. I'll follow a line. If you get sent to Hambin Tamba, I'm a Falkland, I'm a police. Pick up point, I say, and there's only one clinic, Langboya Con.
About 2 years ago, there used to be an external pickup point. It was a doctor's room where we were collecting treatment from, but now it's no longer there. So it's only one clinic in the area, and we all go there. Whether you are sick or you're collecting treatment, you go there.
Enye the futhi njengoba mina bekuyimingilando mama philisi benginokufika lapha bangitshela ukuthi file like abalitholi, so I have to go back home without amaphilisi vele without ifile awusizakali shame noma ngabe ugula kangakanani bayakujikisa ukuthi they can't help you without ifile.
So when I went to collect for my mother, they told me that they cannot locate her file was lost, and when that happens you are returned back home. They cannot assist you without the file.
Yeah, so lo wagcina ukuthi kwesinye isikhathi angikhona ukuthi ngimthumelele amaphilisi because bengingawatholanga, so bengicela nje ukuthi le ndaba ama-pick up points bayi-attend abe khona, and indaba yokuthi kube ne-clinic one in the area is not a good thing. Ngiyabonga.
So that led to my mom not being able to take her medication for some time because of the file issue. I am appealing that at least we built another clinic because there's only one clinic in our area.
Malweni, ndisuka Alfred Zo kwikliniki yaseMatatiyela.
Greetings, I come from Alfred Nzo and I use Matatiyela Clinic.
Ndiyafunda Mount Fletcher.
I'm a student at Mount Fletcher.
Ngamisisha idate yami.
It happened that I missed my appointment date.
Bengibhala. Mangifika the following day.
I was writing exams, so when I got there the following day, they told me that they will service me last.
Ngahlala kwashaya u4. Wathi unesi uzoma lapho wena VIP.
I waited till around 4 p.m. and the nurse said to me, I will stand there. I will stand there since I'm a VIP. And she further emphasized that even if I decide to leave, she will not give me the treatment.
It's been 3 months ago.
I have since interrupted treatment. It's been 3 months without taking my life-saving treatment. I cannot imagine myself going back there. Thank you.
Before we go to the other person, I know that online we've got the DDG of Health among other people, Dr. Mueran. No loyiso. Now on my side, I'm gonna talk to Dr. Mueran so that we can attend the problem assist. When as a provincial manager with other comrades around Alfred Nzo, you need to reach out to the district chief director. This matter must be resolved. We cannot have people here in the country who are made to default by people who think that they own our health establishments. These health establishments belong to government, and we need to report these nurses to the highest level so that those who are in authority can dismiss nurses who are ill-treating our people. We cannot accept this. People come here and cry and tell us that they've got 3 months without taking medication because of the attitude of the nurses. We cannot. We cannot. Thank you.
Molweni.
Greetings.
Gama lam ndungubabongile Qubeka Ifani.
My name is Babongile Qubeka.
Diphuma kwi Johannesburg City eSoweto Snake Park. Di attenda clinic yasesiphumlile clinic.
I reside in Snake Park, which is in the city of Joburg, and I access services from Spilile in Snake Park. Spumlile Clinic in Snake Park area.
Dithatha ma ARVs. I found out last year, 2021, nguthi the HIV positive, they were doing a reach out.
I am on ARVs. I found out I was diagnosed last year through an outreach.
Okay, stay man fika, bebe sema ground in Tawaseka and that itinda mendo tester, this born by Tipila Shobuluni, Tafika, Dangeniswa Pam.
When I got there, the outreach program was near the sports ground near my home, and then I decided to go in the tents that were erected there to check myself.
So, can fika paya la sis lower na bezon testam. Kange anti brief uba into HIV ndayazi bayitheni xa kungathina ngani wabe seyikhupha icassette one poke emveni koko icassette lakhona lihleli xa kobuso bam udisclosed nje athatha igazi then andifake phaya sogqiba akancokoli nix nama kanikhanselishi.
The lady who was testing me did not talk to me, nor did she provide any counseling. What she did, she just poked my finger and then took the testing kit, which was near my face. There was no privacy.
So uthe njobe busy ke nifoni yakhe WhatsApp ebusy ncokola ndiyayibona mo status I'm positive now.
While she was busy with me, she was busy on her WhatsApp, on her phone. And while she was doing that, I peeked at the test kit and came to the realization that my result is positive.
Okay, Kendi Tule artist HIV positive. Ndizokubhalela ileta ngomsuvuke clinic. Wabhala ke nyani leta wangiqhubana nika kanga nikhanselishe still. Ndaphuma ndaya kumama ndomchazele ekhaya.
She then told me that CC, your result is positive. You have tested positive for HIV. I'm gonna write you a letter so that tomorrow you go to the facility. She did not provide any counseling. I then got home and informed my mom of this news.
Xa ndifika ngomso kula kliniki, ndifike nje nakhona ndavulelwa ifayili, kodwa mandithatha amagazi, akho mntu oyandibuza uba how do I feel, it's only my mom.
When I got to the clinic that I was referred to, they opened a file for me. No one spoke to me, no one counseled me, no one asked me how I felt. Only my mom did that. All they did was to take blood samples from me.
Okay, baniki pilisi zam ndiphume ndihambe ndekhaya. Then last year,
And then they handed me my medication and I returned back home.
Last year, ndithe xa ndisiya bafika bandixelela uba i-appointment yam funeka ndithathe amagazi kutata uSibeko. Tata uSibeko wathi wanibhalela i-referral letter le ukuthi hamba uthathe i-room 1 negazi. Mandifika e-room 1 ndifike kune-2 sisters bebehleli kanje, omnye ujonge ngaphaya omnye ujonge ngapha. Si-2 ama-patients ngusister nangapha ngusister.
Mid-year, last year, a gentleman by the name of Mr. Sbego had informed me while I was at the facility that I am due to take a viral load or to take bloods. And when I got to the consulting room, there were 2 nursing staff and we were also 2 patients in the same room.
Okay, xa sendifika phaya ndinika la sisi uyandifaka injection ethi uyandihlaba. Akafakanga i-tube le etsala igazi chithekela phansi. So ndithi kuye uyayibona nale nto yenzayo. Athi ngibhizi ngijahile mina while uncokola nalona omnye.
The nurse then poked me with the needle and the vacutainer was not attached to the needle. When I asked why she did that, she just did not pay attention to me. But what she was doing, she was busy talking to the other nursing sister in the room.
Okay, ayenzeke le nto yakhe agqibe athi segqibile athi wayi-viral load yakho iphezulu. Ndaqala ke ngoku ndaqheleka emphefumulweni.
After she did that, she then asked me rudely, why is my viral load so high? So I started then to feel sad.
Ndifilisa said ukuthi seyisdisclose i-status sami kwistaff sakhe nomuntu oyi-patient.
What made me feel so sad was that she had openly disclosed my status to the other patient that was in the room, including the nurse that was in the consulting room.
Ndimbuze ke ngoku since well ke uthi i-viral load yami phezulu, why? Because andiyazi nalo viral load ukuthi intoni, because azange ndafumana counseling, zange nda-explainelwa. Wavela athi sisi ngicela uhambiye kuTata uSibeko uzokunceda ubuze yena. Ndiphume ke nyani ndiye kuTata uSibeko.
I asked, why is my viral load test high? And she said I must go. She referred me to Tata USibeko because I had informed her that no counseling was done to me, so I had no idea what she was on about.
Xa nisiya e-room 3 kuTata uSibeko singenisa ne-draw, ama-ARVs wami aphethe ngesandla, akabarephanga nga-something. Kunabantu basestrateni sami abahleli apha. Singene eroomini, sithi mesihleli phansi ndithi kuye, why uphethe iipilisi zami kanje? And uthi uLerato mandikuxelele uba ivala road yami phezulu, and ndibuza ukuthi why. Athi sisithatha amapilisi wakho nqamile mna abantu balindile phandle.
When we got to room 3, she was with me and she had my ARVs in her hand with my file. And when we walked in the passage, some people from my neighborhood who know me were seated there. And when I inquired as to why my ARVs were in the open, she just said I must go to talk to Lerato.
Ngithe xa sendiphuma phaya bathi uyambona nalona ene-HIV uzofa kungadalanga. Bengincokola ngabekho mbala.
When I went out of the consulting room, you could hear other patients, those that know me, making remarks along the lines of saying, look at that one, she's HIV positive and she's gonna die very soon. I got home and told my mom that I was not satisfied at the clinic.
I-viral load yami since ukawuthe iphezulu. Yintoni yona lonto iphila njani? Like ndisebungozini kanye? Andikho sebungozini ngoba azange ndafumana counseling. The lucky thing inayo ifamily too supportive to me.
My problem is one, since that they're saying that my viral load is high, I don't know what that is because I'm not treatment literate. I don't know whether it means my life is in danger or I'm going to die any soon. The only beneficial thing to me is that I have a supportive structure from my family.
So into eyenzeke kanye futhi last weekend qhelileyo, it was my appointment. Kunomnye ugogo benifike naye wrong go past 6 ekseni.
Last week it was my appointment date and I had arrived with another elderly lady around 6:30 in the morning.
Xa bevula ekliniki basithathe basifake phakathi lamakhulu xa ifika le kuthiwa ifayile yakhe ayifumaneki. Wahlala ndade ndagqiba uattendwa usibusiso wabethuka la mama xa ndiphuma uba awuhlambanga nohlamba uzohlala apho ngixoxa ukuthi ufuna ifayile yakhe elahlekileyo. Umama wabantu wafeinta like isiphumile. I'm fed up with it. Ingavalwa because nestaff sakhona.
When we got inside with the elderly lady, she was told that her file was missing and she was not assisted until I finished with the whole consulting process. When I got out, a guy by the name of Sibusiso was insulting the elderly lady, saying that she was there and she has not bathed, she is dirty.
So ndicela bethunana ndinelike ukuthi nzile kwa Ritshidze ukuthi nizo expose our clinic. Bengicela yanga uThixo nganenzelela ukuthi nisincede kuma clinics wethu futhi aniphe ukuhlakanipha okuvela ezulwini ndiyabulela.
What I wish is for that clinic to be closed, and I wish and I'm praying to God that she gives Ritshidze the strength to keep on assisting us. Thank you.
Before Siswam, comrade Monwabis, usisi lo we need to attend to that matter. Tuesday, you need yourself and SEP and other comrades to accompany the comrade to the clinic. That's Usiso, and all those people who ill-treated here, that thing must be reported to the facility manager, and consequence management must take place. And you need to give the facility manager a time frame. If the facility manager is failing, you must escalate the matter to the district and the provincial management. We cannot tolerate people who are going to ill-treat community members like this. This must be reported, and we want to see something being done. You must go with USIS. Thank you.
Tumela.
Greetings.
Kalibiso kimsidisi Lakash.
My name is Mutsidisi Lakashe.
Lakaji.
Lakaji.
Kitswa ka tlasa district ya Thabo Mfutsanyane.
From Thabo Mfutsanyane district.
Ka tlasa Nketwane. Ke tlo bua ka tlasa clinic ya Petsana.
I'm here today to talk about Petsang Clinic.
Attitude ya front desk. Kione tloba
The attitude, the bad attitude from the front desk staff is the one that is disheartening.
You miss a date before bao fa file house since about chic.
When it happens that you miss a date before they can retrieve your file and hand it to you, they would have scolded you.
Before kenao sister, everyone at the clinic is
Even before you get to the consulting room, everyone in the facility would have heard what is your issue.
Okay, ke tlo matha hodima dihloho fela ne. Ke batla ba mokgutshwane because ke mtelele too much. The second one, thatsa ba ka ke bonana.
I will be very brief because I am tall in yes, I'm a tall person.
So bothata ba ka ba bedi ke di cleanera tsa Petsana clinic.
The second challenge that I have is with the cleaners from Petsang Clinic.
Di cleanera tsa rona di etsa di vital signs.
Our cleaners in the facility are doing vital signs.
How do you check? Toilet fail, clinic fail. How na toilet paper ka toilet, but also file yaka.
And when you assess, the toilets are dirty, the clinic is dirty, but what they know is to carry our files.
So, the months of it, I can lead counselor. Who life is a point or ki check ki cleaner. So, how ki check ki cleaner? Ki moto high blood. On check ka muchini or off.
So previously I was a lay counselor, and when I got to the facility, a cleaner was taking vital signs from me, and when she was taking my high blood pressure, the monitoring machine was off.
Then ongola ka ara file yaka because ha sa tshwara di file di dula clinic ni tshwara ke bona file.
She was writing my information on my file because we no longer take our files with us. They remain at the facility.
Ha qeta ke a mo botsa ke re me mama Khoba e ring high blood ya ka today o ya mpolella so a mpolellang yona ke a 3 months back.
I then asked her, me mama Khoba, what is my high blood reading, because the machine was off, and the reading that she gave me a reading from 3 months ago.
Okay, ha mfa yona ke re ke kopa a ke re yo mfileng yona no ke kopa ho bona ya last time ha ne ke le teng ke ha di tshwana le pulse di tshwana le temperature e tshwana and ha nka temperature.
I then asked to compare my blood pressure reading to the previous ones, and when she showed me my files, it was the same. The blood pressure reading was the same, including the pulse reading.
So ke qetetse ke tse mo yena o tseba ka ra file ha o scratch o se professional nurse kapa o se doctor. So ke kopa ka ra file ka o ska ba scratcha o ne yona ke tlo isa mo sister ene ho clinic manager.
I further requested that she does not scratch on my file because you cannot do any alterations in the file if you are not a professional nurse. I wanted to go and report this to the facility manager.
Okay, manager ulay attenda kayona nako hiyo ke a leboha ka yona.
The manager attended to my issue and I'm very grateful for that.
Okay, point ya ka ya ho qetela ke na pick up point.
My other point is on external pickup points.
Mo pick up point rona re batho ba sa sebetsing nini o thotse di piece job ne. Ha o thotse di piece job ka date ya go collect medication. O tlameha motho o mo romang o mo fe ID ya hao.
On external pickup points, since majority of us are unemployed and we rely solely on part-time jobs, sometimes you have to send someone to collect your treatment and they have to provide your ID document.
Ki ID ya hae plus ID ya hao. Ene mo yang teng o tlameha o tshware ID so that is why le medication ya rona re ilata late because motho a tlo o yela o tlo ya ka ID ya hao le nna mo ke batla mosebetsi ke ya ka ID.
So the person has to have their own ID, including my ID. And it's a challenge sometimes because where you have gone to do part-time work, they would require your ID book. So it means then we are late to collect our treatment from the external pickup points.
Ne ke kopa o ikopela ho ba ka hodimo. Ke started ho kena mo medication by 2001.
My request from higher authorities is that they assist us since I started taking my medication in 2021.
2001. Ne ke ikopela hore ha ile go ntsona medication wa ho hantle ha ke ba extend nako e ba re fa because ba re fa medication wa 1 month or 2 months. Ho ka ba jwang ke ba extend nako because medication wa gona go nwa hantle ka nako e ke o tosa madi ba tla bona if lo ga ke nwe hantle.
My request is that they give us stable patients, multi-month dispensing, because it will show it on our viral load test if we are not adhering to medication. There is really no need for us to be given 1 month, 2 months treatment when we are stable.
Ya o qetela di clinic hle bathong petsana ya hola clinic E1 so location ka ofela clinic E1 ka hodima bo sister by 4.
My last request is that the Petsana community is growing rapidly and the clinic is very small to accommodate all of us. The nursing, the staff complement in the facility is only 4 professional nurses. Thank you.
Dumela.
Greetings.
Ke attend the clinic ko Wynberg ko Jimiston.
I attend clinic services from Wynberg Clinic in Jimiston.
I wouldn't say the service is bad. You are not for the ratings the right. Service yabona is good.
Angeke ngisho ukuthi iservice yase Wynberg Clinic ayikho right, yona iservice yabo iyagculisa.
But problem erna leng yona it's that how we lo consult or we lay for data how you don't only get 1 nurse in the room. It's either only 2 or 3 and then ababereki ba xoxa so it gets difficult for na o tlileng hore o botsise di question and stuff like that.
The problem is is that when it's your appointment date or your collection date, when it's your turn to go into the consulting room, it's rare that you would get 1 nursing staff. It's going to be multiple people in the room, and which makes it difficult for you to open up about the reason why you came there and further ask any questions that you would like to ask. Thank you.
Molweni.
Greetings.
Ndithatha i-treatment yami e-Central Clinic eMont. Then the CCMDD.
I take my treatment from a CCMDD external pickup point in Eastern Cape.
Central Clinic in
Central
Eastern
Clinic,
Cape,
yes.
Then akho mohluko uyafola elihlobo ubukade ufola ngalo. Then ndaqonda kuba kungekho mohluko kodwa ka late manditshintshe ixesha lam lakusasa la appointment yakusasa ndithathe emini because ndidlele ndizogoduka late.
So there's really no difference between the facility dispensing and the CCMDD because you get there and you queue. So I decided to change my time because I used to come there in the morning. I resorted now to coming later in the afternoon.
Uba uyagula uzoxelela uba kubhizi namhlanje awuzokwazi ukugula. One time ndafika kwakusasa ndazixela ndingekayongena kwinesi egqithayo uba ndifunyenwe yihernia ndicela iipilisi yathi ndizazichaza xa ndingaphakathi.
When you are sick and you tell them this, you are not attended. On a particular day, I went there early and I just saw a nurse passing by. I informed her that I am sick and I'm suffering from a hernia.
Then ufika kwam ngaphakathi ke xa ndifika ndanikwa iipilisi zam then ndagula ke. Bathi iipilisi azikho ndibuze mna ibonjani zingabikho iipilisi zogula nazi i-ARVs ndinikile kwathiwa kwaba sokunika icontainer eyi-1 ye-ARVs bifana sokunika 2 iipilisi azikho urhulumente uyayazi uba intontoni warehouse loo nto iyo ibhayi idilikile so asinazo iipilisi so ndaphela ndiyozithengela.
I was not given any medication for my hernia condition. I was only given a month's supply of my ARVs. And when I inquired as to why that is the case, I was told that even the government is aware that the depot has experienced a problem. So that is why they are giving me even 1 month's supply on my ARVs.
So baphela ke bendikhuphelela ekhemist then bathi ndizofumana imessage exela iba ndizawuthatha kweyiphi ikhemist. So ngala 21st ndibafowunele a day before that andizoba khona kukho ijob endiyifumeneyo. So ndicela uqonda uba bona phaa kubo ayikaveli na uba ndizawuthatha kweyiphi ikhemist because ndiye ndalahlekelwa yifowuni. Intombazana bendiphendula ithi ayazani naloo nto ndithi ngicela ibize omnye umntu ozondinceda efowunini idrop ifowuni then phinde ndifowune i-following day which is nge-21st ndicela uqonda uba iipilisi zam ndizazifumana phi na because andinafowuni.
I was decanted to a pharmacy and before I could collect my treatment from the pharmacy, it happened that I lost my phone. I called the facility to find out if they are aware of the pharmacy that I've been decanted to since I don't have a phone. But the lady that I spoke to did not speak appropriately with me. She dropped the call and I had to dial the clinic again.
Then xa ndifowuna ke ngomso ulo bendincedwa wabuza uba bendincedwe ngubani izolo ndathi ndiyazi wathi so ke ngoku uzawutyhola ndathi no andityholi bendifowunile izolo so ndifonela uqonda nangokuba azikaveli nakuni uba iipilisi zam ndizazifumana phi okokoko bethe mandibambelele ndaphela ndingayi ke because ndikule ndawo ndijopha kuyo. So kule ndawo endiyojopha kuyo ndandiye ndiziphethele iipilisi ngecontainer yam ndihambe ndiye kwikliniki ekufuphi ndiyocela ke so bandinike xa ndibuya ke ngokule ndawo endiyojopha kuyo ndisiye ekliniki last week ndifike 3:45 isecurity kuthiwa mayingangenisi mntu ndithi because idate yam igqithile ndicela ubonana ubuso ngobuso nonesi ngabe ngathi khange ndize ithi isecurity akuvunywa then ndimeke ndikhwaze then kuvele kuzinesi ithi kulate abazokwazi ungenisa mntu ndiyixelele kuba bendifowunile for i-appointment umntu ebendinceda khangakwazi undinceda kakuhle so iipilisi andinazo ndishiyeke ngezi bendiziphiwe kulaa kliniki.
So the next day when I called, the lady who answered the phone asked what I wanted, and I informed her that I had called the clinic the previous day. She referred to me as an investigator, and I told her that all I wanted was to find out where I must go to collect my treatment. I was assisted in another clinic where they gave me 1 box of ARVs. And when it was my time again, because I had a part-time job, to go back to the facility, I arrived at the facility around 3:45. The security guard informed me that he was not allowed to let anyone into the facility. I requested to speak to the manager, and a nurse came and informed me that they will not be able to assist me since the clinic is closed at that time. Thank you.
Dumelang. My name is
Sorry,
Larato.
Sorry, sis. So, Sis Wang, from then until now, what have money treatment?
Dumelang.
Greetings.
My name is Lerato Tukisi. Ke tswa ke le ko Letlhabile.
My name is Lerato Tukisi. I come from Litlabile.
Ke berekisa Letlhabile Community Clinic.
I access services from Litlabile Community Clinic.
Ko Letlhabile Community Clinic, di nurse di chila ka maina rona ko mabialeng. They discuss our status. Ba re file le maina, rona le maina ko bialeng.
If we go from the Litlabile community, the nursing staff there discloses our statuses in the taverns in the area when they speak to their friends or acquaintances.
Even the people ba berekang ka home-based care. Kore ko Letlhabile ha gona privacy. If you are
Even the community healthcare workers, Litlabile Community Clinic does not offer any privacy and confidentiality.
If you are not strong enough, you cannot continue to go to the clinic because of you are being discussed on a daily basis.
If you are not strong-willed, you will not be able to continue accessing services because people there gossip a lot.
There are elderly people that are living with HIV. When they go to the facilities, they don't explain anything to them.
Kunabantu abadala emphakathini wethu abaphila nesifo sengculaza uma ngabe baya ekliniki elihlabile abachazelwa lutho.
They always ask us if we are queuing. What is this? What is this meant? They don't know even what is a viral load, what is a CD4 count. It's a surprise to them. They don't know anything.
Abantu abadala baze bancamela ukuthi babuze thina esibancane kunabo uma sihleli sisalindele ukungena ekliniki babuze ukuthi iyini viral load kuyini ukuthini and then siyabachazela ngoba inkinga abachazelwa lutho phakathi ekliniki.
When we ask them, what don't you ask the people who are assisting you? They say, those people are rude. They're talking to us like they don't have sense. They treating elderly people like they treating crash children.
Masibabuza abantu abadala ukuthi kungani bangabuzi phakathi bathi uma bakhulunyiswa istaff sase clinic bakhuluma nabo ngathi abantwana abancane base crash ababakhulumisi kahle balihlaza uma bakhuluma nabo.
Worst part, sometimes I feel like people who assist us at facilities, they don't know anything about this disease. You ask questions which you know, you want clarity only. They cannot even explain to you like clearly.
Sometimes ngibona ngathi abantu akumele ukuthi basize phakathi ekliniki abanalo ulwazi oluningi ngalesifo. Sometimes unoma wazi uyabuza ukuthi uthola ukuchazeleka kabanzi okujulile kodwa uthola ukuthi nabo ngokwabo ngathi abazi.
I will be happy if Department of Health will hire people baba experienced with this disease to help us. If we're being helped by people living with HIV, I believe we won't be demoralized, we won't default, we won't be afraid to go to the clinic to pick up our meds because of people are treating us like outcasts.
Siyacela ku Department of Health ukuthi ikwazi ukuqhasha abantu abaphila ne-HIV kube yiba abasifundisayo ngoba bazi kangcono ba-understanda kangcono. Lokho kungalekelela ekuthenini abantu bangaphuki emoyeni wabo, kungalekelela futhi ukuthi kungabi nabantu abaningi abagcine sebayekile ukudla amaphilisi.
And I will be happy if people at Letlhabile Clinic can be allocated to pick up points because of we are crowded at the clinic.
Okungangijabulisa futhi ukuthi umphakathi waseLitlhabile Clinic uma ungakhishelwa ngaphandle ezikhungweni ezokuthatha umshanguzo ngoba sibaningi kakhulu kulo yamphakathi waseLitlhabile. Ngiyabonga.
Okay, colleagues, before we move to the next speaker, we have a Deputy Minister of Health, Utatu Dlomo, and he is going to jump to another meeting at 1 o'clock. He requested to make few comments before he goes to a 1 o'clock meeting. But before I give to the Deputy Minister, in South Africa, under the Department of Health, there is what is called differentiated model of care standard operating procedures. One paragraph is in the report, reads as follows. Returning or re-engaging patients should not be made to wait until last to see any service provider, but should join patient queue on the same basis as all other patients. No punitive actions may be taken by facility staff. That is the first one, to say, if you missed your appointment, you are not supposed to be sent right at the back of the queue. If a nurse is saying to you, you missed your appointment, and then go right at the back of the queue, you must refuse. If a nurse is saying to you, go at the back, if it means you must make noise, you must strip and be naked there and tell them that I am not leaving here until I get my treatment, let it be. We must use our anger now. And then the other one, the guiding principles of the differentiated model of care, it reads, if a patient comes from a different facility, it is critical that the patient be provided with treatment on day of presentation to limit any further treatment interruption. And for patients living with HIV, reduce time of viral suppression. While referral letters are helpful, a patient cannot be required to leave the facility without treatment to first obtain a referral letter. So these two things says, if you miss your appointment and UNES says, go right at the back of the queue, you must tell them, no, I'm not going to do that. Rather, this clinic is closed so that all of us, we don't get a treatment. If you go to a facility from the other one, you do not have a transfer letter, a clinic cannot refuse you a treatment. If they are refusing us a treatment on the basis that we do not have transfer letters, we must refuse. Tell them that you rather lock this clinic, I will sleep inside here. Because these things are not a standard operating procedure of the Department of Health, but this is what Amanes are doing it for themselves. Over to you, Dr. Lomo, the Deputy Minister of Health. We will be glad, Tatu Lomo, if you can put your camera. Tatu Lomo. Over to you, Ngokeli. And as those Komshile. Over to you, Deputy Minister. I think you are muted, Tatulomo. If you can unmute, I know what the age means. Yes, shy age, Baba.
Yeah. No, I am not able to. I'm not able to unmute my video because of the host. Even unmute. Okay, now they are allowing me. Thank you. Okay. I hope everything is okay now. No, the video is still not showing because the host is not enabling me to show the video. But let me start. I'm pressing on this one. You cannot start your video because the host has stopped it. That's what it said.
Can you please assist Tatu Lomo Makaban? They are busy helping you, Tatu Lomo, but in the meantime, you can proceed in Ngokeli.
Let me start. Thank you very much, Chair. Marumo Fasi, Secretary General, don't build your anger again. Now, we have come very far from where we are. Let me then stay for logistics. For us who are logged in here since 10 o'clock, there is a number here. Let me look for this. There's someone with us on this platform who has refused to have his or her number muted, and that has actually been causing significant disturbance. I'll get that number. It's starting with 416. That person has not been really muted, but now hopefully they will mute. Chair of the meeting, I welcome this very much, and we come a long way with this program. And as Comrade Anele is saying, this is now today a national program. I have been invited somehow when they were doing some provincial built up in provincial reports. And there were certain recommendations that I made there when this matter was discussed, but I may just as well add on to them. Is it possible that some of us here in this platform can really begin to become committee members? There's a committee, there's a clinic committee, and it has members, and some of us can actually ask to be co-opted and be there. Because then, what are you doing as a clinic committee member? You become a voice. You become a voice of the community. You go to Sister Masego the next day and say, Sister Masego, when we're in the community, these people were saying they are not well being looked after very well. Some of them don't want to tell them your names, because that's why some of the videos they have not been showing people their faces. They don't want to show their names or give their names to you, Sister Masego, but these are things that we pick up. So I really want to encourage some of our members to really look into that space of becoming clinic committee members, even co-option, or be available when these committees are being selected. But comment, Anele, your community stories, I've listened to all of them since 10 o'clock. I haven't had one to say, you know, I was well looked after in that clinic. The sisters there tried their best, despite them being over their staffed, not poorly staffed, but they still have a good love and attitude. Now, we bring the only bad story is that everything is not well, which is probably not correct. Let me just say, 8 years ago, this government, with their support, trained a significant pool of nurses so that you don't have to wait for Chris Hani Baragwanath Hospital or Pelanome Hospital to give you medication, but the clinic next to you. So there was a program that was done, a NIMAT, a Nurse-Initiated Management of ARVs, which has assisted us greatly by improving the pool of many nurses who are out there in far-flung clinics giving to us support. Where there are challenges, we still want to really work on those issues. I wanted to say we have in the country now over 1,870 clinics that we call youth, that have got a youth zone program. What is a youth zone? It's clinics where young people say, we're not going to clinic, Mamelodi Clinic, a few years ago, because the clinic was not very conducive, it was not friendly, but now since you tell us there's a sister Mary there in that clinic who's trained to be youth user friend, who's friend to young people, let's use that. Then I've said to Ubabu Ulukhuzana, why don't we maybe use those clinics for now to really work around these issues, because there are some of our people here who still have their own attitudes against sex workers, against LGBTQI, men who have sex with men. Why don't we protect those populations and say they must use at least those facilities that are already having a nurse who is youth user friendly? So that I actually recommended in our last interaction, and I hope we are using that, because I cannot guarantee you, comrades, that that next year all our health facilities will suddenly have nurses who are youth user friendly, who are friendly to sex workers, who are friendly to LGBTQI. Is the attitude change that must happen. But let's continue working together in these processes, and where there are challenges, and they will continue. And I like the attitude of Comrade Anele, because he has got our numbers. That is why I was invited now to say, when am I leaving the meeting? Can I contribute? He has got our numbers. He has got all the numbers of HODs and MECs. He can, as your leader, be able to link up with us at any given time, and we solve problems. We are sitting as a department saying, but why do we start people in ARVs and then people stop or they don't continue? Some of the issues are coming in from these meetings, and we welcome them. So we actually are learning as a department as to what are the challenges, can we improve on those challenges. So we hope to work on these ones, but please assist one another again in what we call group discussions and those support groups. Support groups can go a long way towards actually becoming your voice in terms of this issue. So we want to say, comrades and all our members in the society, we are not excited to find that you do not access early treatment, whether ARVs or TB or diabetes treatment on time, because it is that which is empowering you to live longer. But let us take strength, comrades, on the report that was released on the 20th. Please read that report. I'm sure Comrade Anil will reflect on that. Released on the 27th of November 2023, just last week, a report by Human Science Research Council that talks about surveys that were done in our country saying at least now we are having mothers who are still falling pregnant, but because they are taking ARVs, they are giving birth to HIV negative babies, which is an extremely important story. We have people now, because of ARVs, are living longer and are not dying at a younger age. So we want to accelerate that, because that's a good story to tell. Why are we not? We should celebrate that as a government, because if a mother is able to stay beyond age 50, that mother is not going to go and die, and therefore the children are not going to start looking for a grant to go to school. So we benefit as a country if we live longer, and we stay on our slogan to have a long and a healthy life. So I encourage you, and I'm glad that some of the leaders who are logged in here, who might be getting this report, are listening, who are getting for the first time. I have heard these reports 3 times, and thank you very much for being invited once more. And what we need to do as a government, as a department, is to continue to improve on some of these issues that we have raised. But I would also urge some of the members here to continue being available to serve on the structures that are governing clinics, so that they could become the voice, not only of themselves, but the voice of the others in the society when we are not delivering what you are actually expected from us. Thank you very much for this opportunity. I'm glad that I've listened to you. I have to move into another meeting at 1 o'clock. And for all the comrades that are here, all the best. Wish you all the best for the new year, and all the best, and look after ourselves. Tell us where there are no condoms. We want you to have safe sex. We want you to really remain strong and continue the treatment and live longer. Thank you very much, Comrade Anel, and thanks to all the leadership that are there on the Ritshidze. Thanks.
Siyabonga Babu Dlomo, thank you very much. But also Tatu Dlomo, our reports are showing both the good and the bad side. That's why we are talking about best performing facilities, and we're encouraging the underperforming to learn good practices from those who are performing well. So, siyabonga Tatu Dlomo, and we hope that we're gonna work together in making sure that we fix the problems that we have, so that the people of South Africa can see hope on the NHI. And to us, people living with HIV, NHI, the success of NHI means success of the program which seeks to cap the spread of HIV and TB, as well as access to treatment. Siyabonga Tatu Dlomo. Uthixo akusikelele.
Inkosi Nkokheli, thank you.
Siyabonga. You may proceed, Simpiwe.
Greetings.
Igama lam ndingubuhle ndihlala eMdantsane.
Hi, my name is Buhle. I reside in Mdantsane area.
Ndi-attenda iThembisa Clinic ekwa-7. But sendayiyeka because of bad attitude endandiyinikwe nginesi eyayindinceda.
I used to attend the clinic at 7 section, and I stopped going there because of a bad staff attitude that I encountered from a nursing sister there.
Ndandifunyenwa zii-piles, then ndaya ke phaya, ndafika ngo-8 o'clock, then kwathi into yobana bakwithi time, then sayoncedwa ngo-4 o'clock xa kuzawuvalwa. Then ke ngoku abanye abantu sebemkile mos, so ke ngoku xa kufikele ixesha loba ndiye phaya, then ndafika phaa kwi-consulting room, ndafika kuvulwe umnyango.
I was suffering from piles, and we had gotten to the facility early, and we waited for a very long time till around 4 p.m. when other patients had already left the facility. So at that time, I had gone and checked the consulting room and found that there was a door open.
And then ndafika ndangena. Then xa ndilivalayo icango phaya, then athi laa nesi into yobana ngubani othe vala eli cango apha because ufike livuliwe.
I then entered the consulting room and closed the door. The nurse asked me who asked me to close the door since I found it open.
Then ndafika ndangena ndahlala phansi wabuza uba ndize ngantoni, then ndamchazela uba ndifunyenwe zii-piles. Wabuza ngoku yena uba bekutheni uzibe nee-piles. Then ndiyamchazela ke mna kuba ii-piles ziyakwazi uba nazo because of utya sometimes into enestarchi okanye mhlawumbi utya isonke esiwhite. Then wathi ke nanto yobana ndiyaxoka mandithethe inyani why ndinee-piles and akazukwazi ukunceda if andithethe inyani.
Okay, she then asked me what was the issue. I told her that I'm suffering from piles, and she further inquired, why am I suffering from piles? I then informed her that you can suffer from piles if you eat a lot of starchy foods, and she said to me, if I'm not transparent with her, she won't be able to help me.
Then ke ndamchazela ke uba andiyazi ke ba why ke andiyazi ke ba because kaloku igqibeleni nguyini suppose yazi bii-piles zenziwa yintoni na. Then wabe sithi ke nguye into yokubana awuzungabi nazo ii-piles because of ezi zinto nizenzayo nina nenza sex kwinto like wathi nenza isex kwiindawo ezisensitive so awuzungabi nazo ii-piles and andizukwazi ukunceda zawusele ndibhala nje kokuba kuthiwa ndibhalile. Then ke wabhala then wandinika incwadi ndaya phaa kulaa ndawo inikeza amayeza.
She further asked me to be honest because she cannot be able to assist me. And then she said to me, I must be honest because as we have sex in the most sensitive areas, which is our anal areas. So then she wrote a prescription for me and I had to proceed to the dispensary to collect the medication.
And then phaya dispensary xa ndinikwa amayeza laa mama wabekhwaza ke wethethela phezulu uba bhuti ke ile nto kayokuqaba phaya asinayo uzuze ngenye imini. So ndaye ndafilisha ndihlazekile ngalaa day and abantu abaninzi babendihleka that day so ndaba-hurt.
So at the dispensary, the lady who was assisting me there was shouting for everyone to hear and saying that they don't have the ointment for me, for the anal area. And this humiliated me because other patients in the facility were laughing at me.
Thank you.
Thank you.
Sanibonani. Mina ngisuka eSinethemba Clinic eBorik.
Greetings, I come from Porky and I access services from Sinethemba Clinic.
Mina into eke yangangiphatha kahle August ngike ngaya ngiyolanda medication yami. So mangifika lapha yana ngifike ngabo ma 10 sahlala ngabona isister iphuma iphethe lunch box ihamba. Ngase ngoba ngingumuntu okhuluma too much ngathi ngiyocheck ukuthi lo sele wenzani.
So my experience that I want to share is that I went to collect my treatment on a particular day and we waited at around 10 a.m. I saw a nurse with her lunchbox going to tea time. So since I'm outspoken, I then inquired what is going on.
So mangifika ngale room 3 ngifike ngathola ukuthi bavalile ngafike ngakokota bathi ngena ngangena.
When I got to consultation room number 3, I found the door closed. I knocked and they said I should enter and then I entered.
So mangena ngithe mangena ngathi ngabavusela ngasithi ngizolanda medication yami. So instead ukuthi kuphendule usister kuqala kwaphendula le assistant.
I greeted them and they asked what I required and I told them that I came to collect treatment. Instead of the nurse responding to me, it was the assistant who responded.
So ithe mayiphendule assistant obe angitshela ukuthi nakasa usayakhuluma nami lo assistant kwabe khuluma lo sister futhi naye eceleni ngesikhathi esi1 leso sikhathi usister beka busy ngefone assistant beka busy ngamanye amaphepha wabe angitshela ukuthi why ungena lana uzositshela ngalo uzofunani lana ngabe ngithi no ngibona ukuthi akunamuntu musi ongenayo ophumayo sorry sihleli from ngo10 sekuze kushaya 11 sihleli lana sinakekelwa why.
So both the assistant and the nurse were very busy and the assistant was busy with some filing work and the nurse was busy on her phone, but both of them were talking to me at the same time, inquiring as to what do I want, why have I entered the consulting room, and I responded that we are here to collect treatment and we've been there for a very long time. seeking assistance.
So kuleso sikhathi leso ukhuluma nami lo assistant bayangishawuta ngendaba ethi ngizolenda i-medication. So ngikhiphe i-card, bathi bafuna i-card, ngilikhiphe ngibanikeze bese bathi phumela phandle. Ngiphume mangaphandle ngiphinde futhi bangibize ngene. Nangingena bangitshela ukuthi bakhona yini abanye abantu ngaphandle. Ngithi iline liningi ngaphandle. Manje uzofunani wena lana ubani othengela. So abangithithanga kahle ngoba bebangishawuta kungathi akusiyo i-date yami kodwa kube kuyi-date yami. Base bangipha i-warning ke into le yangizwisa ubuhlungu ukuthi bangiphe i-warning bangitshele ukuthi next time ngafika ngalesikhathi engifike ngaso angeke ngiyithole i-medication. Kufuneka ukuthi ngifike ekseni nabefika ngila ngizothola khona i-medication. So akungiphathanga kahle lokho cause ngazibuza ukuthi ngo-10 sebaya complain bangitshela ukuthi from ngo-10 bona benza i-paperwork. Angizange nga-understand the meaning of paperwork ngo-10.
Okay, so they proceeded to shout at me and they sent me out of the consulting room, but they then called me back and I handed them my card. They gave me my treatment and inquired if there are other people who have come to collect treatment. I told them that there was a line of people waiting to be served. They assisted me, but they reprimanded me, saying that next time when I come for my collection date, I should come there early. I was perplexed because it was around 10 a.m., but what I got from them was around that time, 10 a.m., they are busy with their paperwork in the facility.
So, ngase ngiyabuza ngithi the reason ningikhiphe ngale e-short left yini ningiletha lana mangabe nizongitshela ukuthi next time ngeke ninginikeze kahle kahle umthetho walana nisebenza from ngo-7 ekseni till ngobani isikhathi ngami ningazi ukuthi i-clinic isebenza from 7 till ngo-4 o'clock. Babe bangitshela ukuthi ngilothi ngizenza umuntu nje shothi umuntu owazi kangcono kunabo.
I inquired as to why I was brought back into the facility since I was decanted to the short left pickup point before. And what I got from them is that it's because I think I'm better than them and I think I'm better than other people.
But ke kuthe manje ngoNovember mangiya futhi ngiyolanda i-medication ngangifuna ngizitshela ukuthi bazophinde bangixoshe because na this time ngifike ngabo ma9. But ngenhlanhla yami ngithole ukuthi kune emergency and ngithe ngiyafika kwathothi abanakekeli umuntu but nangiye short left ngafika ngathola ukuthi medication yami sengithole short left. So ngiyakubonga lokho.
So in November when I went for my collection date, I was scared that they will shout at me because I felt that was late. But luckily or fortunately, when I got to the facility, they were attending to an emergency and there were people queuing. I proceeded to the short left pickup point where I was handed my medication. Thank you.
Siyabonga. Simpiwe, we're going to recommendations now. Thank you. So quick. Number 8, what do we want? 12 monthly prescription and the rapid rollout of 3 and then 6 month supply of ARVs to reduce unnecessary burdens on people living with HIV and the health system. Quality clinical management when people are required to come to health facilities to see a clinician, not just a script and refill. 9, more pickup points established, especially linked to peri-urban and rural clinics. All stable people living with HIV being offered and voluntarily enrolled into a pickup point or adherence club of their choice. Facility pickup points are a quick, one-stop ART refill collection, only visit in under 30 minutes, no need to go to the registry, vitals, collect folders, see clinicians, and etc. The re-establishment, revitalization, and widespread rollout of functional adherence clubs. Collection of ART refills for up to 28 days from pickup points. 10, healthcare workers to provide friendly and welcoming services and acknowledge that it is normal to be late for or miss appointments and to support people living with HIV to re-engage in care. People never to be sent to the back of the queue when they return after a late appointment, silent transfer, or interrupt treatment. All facilities must implement 2023 revised, differentiated re-engagement approach in ART and adherence guidelines, standard operating procedures with fidelity.
The next group of issues are on people being refused services. For some people who move to a new place or relocate for work, getting access to life-saving ARVs become a challenge. In the last year, a staggering 1,371 people we interviewed had been denied services because they did not have a transfer letter over the last year. Given that most people interviewed are unlikely to have attempted to transfer services, it points to a larger problem regarding the communication and policies regarding transfer letters. Transfer letters are not required by national guidelines to start or restart your ARVs. They say, while referral letters are helpful, a patient cannot be required to leave the facility without treatment to first obtain a referral or transfer letters. A further 2,083 people had been denied services because they did not have an identity document over the last year. Further 252 people had been denied services because they are not South African. Again, it is important to know that Ritshidze interviews take place at the facility. Therefore, people who had already disengaged from care due to challenges of accessing a transfer letter, not having an identity document, or being denied services for not being a South African will not be in the facility to interview. Members of key population we interviewed had also been denied services, including 8% of gay, bisexual, and other men who have sex with men, 31% of people who use drugs, 11% of sex workers, and 10% of trans people. One person who uses drugs told me, I know that I use drugs, but that doesn't mean that they have to mistreat me. One staff member swore to me and said, get out, you para. You are wasting seats for the patients that really need help. A sex worker further said, the nurse said, why do you bother us? Why should the government waste money treating people like you rather than giving ARVs to the people who deserve it? I felt so humiliated and I hated myself. I was crying and begging the nurse to help me. She said I disgusted her. Now we'll move to recorded stories.
Nikile Mutembisa Health Clinic, Soden. Kinkile transfer from Free State. To be honest, azanka thola treatment sharp. So then kile ka ba fa ID ya ka ba fa le transfer ba ntwetsa gore no ke tlamile ke batle ba batla proof of resident. Ka ba jwetsa ke re no ke dula hole and so then nkesi and le lot ya ka high. So then ba re hona ba ke se khone o nthusa without proof of resident. Azange antula sharp cause by that time azange thola di treatment yak. The other day ka tla le proof of resident ba mpulela file. Tlamile ba nke body testing in kaofela. So then sister o mone ona le busy o mo and transfer ho another sister ne o mo antwetsa gore ena ke se khone o nthusa. So then yena ke ngwana motho. So then azang lantula sharp lensile la haila gore yena ke ngwana motho thuso. By that time azang ka thola thuso ke le ka boela hae ntlong ke sanka madi ke setsa pap smear ya ina nna ka ka etsa pap smear la nka madi azang until be ke reka di pills mo clicks azang ka khutlela clinic and ke na le fear even today ke tshaba ya clinic ka ona treatment ya bona fela. Treatment ke nwa ke antiretroviral treatment ya le tlamile ke dinke mo Tembisa Health ya se bile ke di reka no attitude tse ya bona yes ba change parce que ba jaja motho like ba re treat equal, so then le e ke batla gore ba change ke ya transfer yo mpela e serious ya gore be re batle di proof of resident mare tshwere di transfer le ID ya ha holo nka thabela thuso ho tsetsa mahala cause ke a spend and nini dina lo fela pele ho nako. Sometimes motho a default otla nini o default 5 days 4 days o tla bona di fela le nni ha ke na chalete, let's say yes.
Jala ntomazane ePola Park clinic engisebenzisayo eMandiyeni Kenville. So 2021 bengikhulelwe ngifuna usizo ePola Park ngangalithola. Ngaya ke ePola Park clinic ngayokwenza ilokhunja ngakwadingeka ukuthi kumele ngenze ikhadi ile maternity lokukhulelwa. Bangathi ngeke baze bakhona ukungisiza ngokuthi ke angiseke wala. Futhi bengakayiphathi netransfer. Ngokuthi vele bengasiwa la bangifuna itransfer yaseSwazini. Ngabatshela ukuthi okay ngihlale ekudeni futhi nalana sengithola umsebenzi ngahamba ngalo December lo ngaya eKenville but angisakhumbula ukuthi beyingakhi date. Umuntu osiza abantu abakhulelwe vele ulo Sister Nkosi wafike wangisiza uSister Nkosi eKenville ngendaba yamaphilisi. Wangibhalela washo ukuthi kena incwadi abanendaba nayo ukuthi kanjani ezilonga ngisizakele endabeni yamaphilisi ukuthi ke ngikhona ukule treatment mangiwazi amaphilisi ami bazongidonsa igazi ukuthi vele isiqiniseko sokuthi ngiyawadla amaphilisi ngoba ekhaya kusekudeni angeke futhi ngizingibulale ingane ngenxa yokuthi ekhaya kusekudeni kumele ngicingane nama transfer. Washo ukuthi uzongisiza ungaqhubeka njalo wangitreat lokhu ngitreatwa nguye wangishintsha ngoba bengidla amanye bengiphuza la wanga2 wangishintsha wanginikeza iLTD laso Scopotinus Blue. Ngahlala 3 days ngakawaphuza uma ngikhumbula kahle ngoba ngayelangeni lesi3 eKenville bafike bangisiza ikhona eKenville till today vele ngasizwa nguSister Nkosi kube bengasinguye mhlawumbe engabe ngithanga wathola ngoba vele iPola Park azengibaze bangisiza so lo ngisaqhubeke enlo eKenville ayikho enye clinic engiattendayo. Yebo kuke kwaba khona ukuthi nje endaweni njengase clinic Pitritif le isedrobheni eTown nakhona bekubantu nje abangifuna ID sothi bafuna ID ngesikhona ukusiza kufunakala iID na sibone ukuthi vele kuyaclicka yini nalena cause nami ngicabanga ukuthi njenge clinic modinga usizo ugula manje bayakusiza. Yebo bengazi ukuthi uma ngabe uthatha amaphilisi sazodingeka incwadi mele click mina bengicabanga ukuthi mhlawumbe bakuthatha igazi njoba bangenze eMandiyeni babona ukuthi okay igazi lakhe lo muntu liso uyasibikela ukuthi okay isimo sakhe vele wazalwa naso kanje. Kungiphatha kabi ngoba special nje kithi mawuseswazini asikwenzi noma ngabe kuthiwa umuntu ufuna usizo.
Freedom Park nje kubani kuyangamaweni baxosha bonke labantu abasebenza lapha. Qashwa abanye abantu abasebenzayo. Labantu abanamsebenzi ngile clinic oqala ngisafika la Freedom Park. Mangiya lapha bengifuna amaphilisi wami awuyama ama-ARV because ngidla amaphilisi we-ARV. So mangifika lapha bengana transfer because I lost my things ama-files wami. So bengize ngamanye ama-issues like Jozi. Kwacost ukuthi ngabe akusabuyele kuvele ekhaya cause so ngaye Freedom Park clinic bangitshela ukuthi angani transfer yami le la ngisuka khona. Ngamtshela lo sisi ukuthi anginayo indlela ukuthi ngibuyele emuva le. Into engingayenza ngingakutshela ama-initials wami ufake ku-computer. Kuzophuma kwi-system because amaphilisi kudala ngwaqala ukwadla ngisazalwa ngikhule ngiwadla vele no sengize nga-default yamo manje bengiphuma ebhara ngiphuma izolo ntambama bengiyile khona futhi khona la eFreedom Park Clinic banginika nje amanye amaphilisi adomunyana nje bangi-admit ebhara ngalala bangigaya ke lokho bangijova ebhara benza yonke into.
And now we move to community members that have joined us today.
Greetings.
East London,
I'm from Tanzania in East London.
East London Central Clinic.
From?
Central Clinic.
I access services from Central Clinic.
I'm angihlale East London per se, ngihlala eMdantsane, but because asikho comfortable using services the local clinics zaseMdantsane, we opt for clinics ezizabakude because of the discrimination and other things.
I actually don't reside in East London, but in Tanzania, but we opt to use faraway clinics because of the discriminatory behaviors that we experience from our local clinics.
So in November last month, me and my partner, we decided to go get tested in East London Central Clinic.
Mina kanye nesithandwa sami last month sathatha isinqumo sokuthi siye e-clinic e-East London ukuthi siyotesta for HIV.
So when we got there, I saw a lady who was directing people on where to queue for which treatment or whatever the queues may be.
Okay, uma ngisifika khona ngabona usisi obekabukeka ngathi uyi-queue marshal obeka direct abantu ukuthi othatha le treatment uya ngalapha noma uya ngalapha ya.
So I then asked her for directions as in where to go get tested, me and my partner.
Mina ngaya kuye ke ngiyobuza ukuthi mina kanye nesithandwa sami siya ngakuphi njengoba sifuna ukuyihlola isimo sempilo.
She directed us to a men's corner and she also accompanied us to the men's corner.
Wasiyalela ukuthi siye kukhona yabantu besilisa naye wasiphelezela ukuthi siye lapho sobabili.
When we got there, she said to the male nurse who was there, nurse stats.
Uma sifika khona uQ Marshal lo besihamba naye wathi ku nurse lo muntu wesilisa esalithola khona nurse stats.
When we went inside, the male nurse told us that there should be one person at the consultation room at a time.
Masingena ngaphakathi unurse lo umuntu wesilisa wasazisa ke ukuthi ngaphakathi kungenwa one by one.
So we then had to explain that we are a couple and we want to get tested together at the very same time.
Ukuthi ngeke ukuthi simchazele kabanzi ukuthi isizathu sokuthi size lapha kumtholampilo ukuthi sizoyihlola sobabili njenge couple.
He looked so astonished and so much disgusted.
Wabukeka emangele kakhulu futhi wabonakala engathi uyanyanya.
In his words, he said, "Makwedini phumani apha andinalo ixesha lalento nizoyithetha apha."
Ngamazwi akhe uthe gentlemen, please get out of here. I don't have time for your nonsense.
Yeah. And I also don't command your demonic practices.
Nefuthi angixhasi izenzo zenu lezi ezihambisana nemimoya emibi.
And I could feel that my partner was not at ease with this tension that was rising.
Ngengabona lapho ukuthi isithandwa sami ngihamba naso asizange sibe right ngoba imimoya yayiseyiphakama.
So I decided to step outside to seek for other help.
Ngathatha isinqumo sokuthi ngiphumele ngaphandle ngiyofuna usizo kwenye indawo.
So to hush me, they referred me to a female nurse.
Ukuthi bangivala umlomo bangithumela ku nurse womuntu wesifazane.
Then we were consulted by this female nurse,
okuyena ogcine asinikeza usizo.
Who she then told us that we must understand that male nurses don't feel comfortable attending gay people.
Uye wasichazela kabanzi unurse lo muntu wesifazane ukuthi sazi ukuthi ama nurse wabantu besilisa awazizwa kahle uma esiza ama couple or gay couples.
And that we must not enforce ourselves to them. It only makes them angrier.
Wathi ke nathi singaphoqeleli ukuthi siye kubo because lokho kuyabathukuthelisa.
I felt that we were not going we were not getting anywhere. So we decided to just leave the facility in shame and disgust.
Ngase ngiyabona ke kuyasikhanyela ukuthi ayi akukho la siyakhona futhi nosiza silitholi sagcine sihamba kodwa siphatheke kabi kakhulu.
So all in all is that we did not receive any services at that facility. The same story that the same story that we're running away from in our own communities will be the same stories that we experience in other healthcare facilities.
Lilonke nje asizange silithole usizo kule facility okubhlungu ukuthi lokhu sekubalekela imiphakathini esihlala kuyo kodwa uma sibalekele izikhungweni zethu zakahulumeni zomtholampilo nakhona siyathola le discrimination. Thank you.
Sorry, Comrade Simpiu. Comrade, when did this thing happen? Last month. You are from Buffalo City, Mosadet, PCM. Noloyiso, let's attend to this matter. Let's take this matter to the district chief director with Comrade, ne partner yake. Go back to that facility. You point these people who said all these evil things to Comrade, and you must go with branch members, and we must demand on the spot that these people must apologize to Comrade and other people that they are ill-treating, because we must ask ourselves, how many people who decide not to go to the facility because of that attitude? If those male nurses do not want to serve the people, they must pack their bags and go and get people who are willing to serve the people. That is not their property. That is the state property. People are not going there to ask for favor. People are going there to access healthcare services. We need this matter to be resolved. And then Tuesday or Wednesday next week, you must give me a feedback so that I can call the district chief director as well. We are on recommendations now. We are saying no one is denied health services for being someone who uses drugs, is a sex worker, or part of the LGBTQIA plus community. Those who move or relocate for work should not be denied ARVs without a transfer letter. Migrants, asylum seekers, stateless people, and people without identity documents or proof of address should not be denied healthcare services. We going to
Thank you, GS. The next set of issues is on treatment literacy. Treatment literacy educates and empowers ordinary people in South Africa to understand how HIV and TB work in the body, how they can be treated, and how transmission can be prevented. It helps people to understand the importance of taking treatment as prescribed. In our last round of monitoring, 94% of people had a viral load test, but only 87% of people knew their viral load. When we asked people if having an undetectable viral load means treatment is working well, 87% agreed. However, only 81% agreed that having an undetectable viral load means a person cannot transmit HIV. Only 88% said a healthcare worker had explained their results to them, showing that not all clinics ensure that they explain the results of people's viral load test and help them understand the importance of taking the treatment effectively. These results vary dramatically across the country, with some districts performing well and others absently. As seen here, with 100% of people living with HIV understanding that an undetectable viral load is good for your health in Mopani and Ngakamudirumulem, but only 57% in Cape Town, only 35% in Kangala, and only 16% in Bujanal. Results also vary dramatically, with people living with HIV understanding that an undetectable viral load means a person cannot transmit HIV. With 100% understanding this message in Mopani and Ngaka Molema again, but only 54% in Cape Town, only 36% in Nkangala, and only 15% in Bujanala. Treatment literacy and explaining people's results remains a fundamental to helping people stay on treatment. We are going to move to recorded stories.
Ke tsama clinic ya teacher ba khodi ngwe le ngwe ke leta treatment ya HIV. So for nna side like treatment ko ya dinese ha sha for nna because ke na ko khodi ngwe le ngwe ha ke clinic ya teacher ke tswana le bo sister abantu hlalosetse even today ibile ba chinchile no jin hona le tse ding tse ba mfileng tsone and a dintshwa gantle ke dinwa ka timetable which on happy like I dumela gore e no treatment ke I no happy like I sa dumele again the pedis treatment ba mfa yone ha ba ntlhalosetsa gore ke mofuta mong wa pedisi ke tseba fela gore ke di pedisi tse sebetsana le ke le gore ke na le lona philo ke tlo phela lona full time ke which on ke mix ke komana tse two ka komaneng e nngwe e golo ke nka tse two ka komaneng yana ke nka e one mara ke dinwa kana ko one which on ke dinwa o seng le mantsibu ke tsama clinic ke re khodi le khodi mara ha ke ile kgoding ha one ke fuwa treatment komana ya khodi fela ha ke lonka madi di result which on ke anka madi sometimes ba njoitsa sometimes ba njoitsa since ke scopa speed sa treatment ke nwa ha ke so arabu ntho e loreng e hlakile hore se a tholahala kapo ha se tholahale.
I'm a patient living with HIV. It's been 3 years now. You collect medication. I'm at Meremotli Clinic. And sometimes the pills abanginikeza wona are different. Sometimes they are white, sometimes are peach, nina aloe. And every time abangidonsa igazi ne malibuya azange bangichazela nge-CD4 count yami, nge-viral load or anything. Ngathi mangibuza ukuthi i-viral load yami itsini, bathi hayi right, samendlini shuthi treatment uyithatha kahle. Ngathi mangibuza ingakanani phezulu phansi, si baningi abantu bakhona la mina siba attend namhlanje. So na mangisabuza next, ngifila ngathi bayangifaila. Because ayikho into bang-educator ngayo akuna ikhona ilo ama-groups abantu abasha, but most of the time kuya nge-data bakunikeza yona ukuthi uza ngelangeli so mawufikile ya akhona ama-charts aplakiwe ne but angaze ngayobona lawo ma-groups we-youth kuthiwa nayi namhlanje leyo group leyo nto yakhona yenzeka namhlanje yothi angaze ngayibona aza angikhumbuli bangireferela kulawo ma-support group lawo we-youth or anything. Yeah, I do wish ukuthi nami ngibe khona kulawo ma-group lawo ngizothola i-experience ngifunde okuningi kubo mhlambe nami ngifundise ngaloko ngikwaziyo si-educatane.
Now we move into the community stories.
Dumela.
Greetings.
La ke sebedisa Stanza Bopape Clinic 1.
I access services from Stanza Bopape Clinic 1.
Ke nka treatment ya HIV.
And to collect my ARV treatment.
Ko Stanza Bopape, they will test you, yes, and then ba jwetse if only positive. And abakaso tlhalosetse hore like hore CD4 count ya how it's how much and then how much it's your viral load.
At Stanza Bopape, they provide testing services, but they will never explain to you. They don't explain your viral load results as well as your CD4 count.
And then medication batla offer and then batla ujutso medication wa how.
They provide medication and all they tell you is that go and take your medication.
And then if oba botsa hore what's going on ka viral load le CD4 count, ba botsa hore o mang wena o nyoko itseng ka tsone dilo tseo CD4 count le viral load.
Should you inquire how your viral load how you are faring with your viral load results, then they would respond and ask you, who do you think you are, wanting to know, wanting them to explain your results.
Because as it's my body, but on the bank said for me to know medication how much is my CD4 count or viral load yaka ijwa. If it's not okay, ke khono butisa hore ke eng se right hore ke khono se change ke re se right hore ke khono ba right.
For me, I feel it's very important, since I am the one taking the medication, so that should I get a high viral load test results, I should know how I should adjust my lifestyle accordingly, so that I get to the safe and healthy test result.
Okay. And then go clinicing return for the sake ya hore or maybe ki tshware line, but batlo bula ka 80 and then batlo try le clinic.
So we get to the facility very early at about 4 a.m. in the mornings with the hope of beating the long queues. But once the clinic is open, they will open and just be idle in the clinic.
And then how butisa lo hono you are wrong. So urtwamola ka bo ma 4.
When you inquire, you become the enemy. You end up leaving the facility around 4 p.m. Thank you. My name is Nobuntu. I come from Flagstaff in the Eastern Cape. Accessing services from Holy Cross Clinic. I get monthly treatment from Holy Cross Clinic.
Holy Cross. Xa ndifike ngo-8 umzekelo ndiye ndiphume noonesi ngangendlela uba ilayini ihamba kancinane uba ndingene ngo-8 ndiyophuma xa bephuma bona nxa ndithi ilayini ihamba kancinane.
When I get to the facility at about 8 a.m., I usually leave the facility at about 4 p.m. And the reason for this is because of the sluggish line in the facility or queue.
Igazi ndilitsala xa kuphela unyaka banditsala ngoJuni. Xa ngaba bebuyisa ama-result abandixelela noba i-CD4 count ithini, i-viral load ithini, bayathula qha. Ndihlala ndisebumnyameni.
I usually am due for my viral load test around June, but when the results come out, or they do indeed take bloods, but when the results come out, they don't thoroughly explain how my viral load is and how my CD4 count is as well.
Ndizocela ke uncedo ukuba bakwazi uba basixelele uba masiqhube bangabe besitsale igazi basixelele uba kwenzekani ngoku singadlalisi sebumnyameni. Enkosi.
I'm pleading with them to please explain our results so that we can know how to adjust our lifestyles accordingly. Thank you.
We are going to recommendations, but before we go to recommendation, I will humbly request TAC provincial chairpersons, provincial managers, Ritshidze project officers, to make sure that we try to secure meetings with district chief directors. Because all of us, as we are listening here, we're hearing different stories and different incidents from different provinces and districts. I know that some comrades are on the festive mood, and it is our right to be on the festive mood. But how do we enjoy a festive while we know that people are dying? Even if it means that these meetings must be held on the 25th of December, we need to have these meetings with district chief directors so that if you go to Nelson Mandela Metro, you talk with the district chief director of Nelson Mandela Metro about issues that are related to Nelson Mandela Metro. But these meetings must not just be meetings to tick the box. We must go there, list all these issues, and ask for time frames on a turnaround of attending to these issues. But I am not expecting that in January 2024, we must have meetings like this. January 2024 moving forward, we must convene these meetings to give feedback about progress made in terms of our interventions. That is my request, comrades. Please. Because since 2019, we have been doing this work. But also, as much as I agree with the deputy minister, but I disagree with the deputy minister on some areas. And I will reach out to the deputy minister to secure a meeting so that us and the deputy minister, we can, and the department, MECs and everybody, we can work together in fixing the problems that our people are faced with at clinic level. We know about the Human Science Research Council report and other issues, but that report does not address issues of staff attitude, long waiting hours, missing files. These are the things that we want the government to address them. And if we do not get a joy, we must write to the deputy, to the president of the country. We must write to the ANC as the governing party and say, ANC, people that you have deployed in government are allowing the officials to do 1, 2, 3, 4. We must use all powers that is in our hands, comrades. More especially next year, we are going to elections. If these problems are not resolved and we do not see a sign of willingness from the officials, we need to take a resolution to say, if these problems are not going to be resolved, we are going to boycott elections. Because we cannot continue to go and vote for bad service deliveries. We must go to vote in order for the services to be improved. And we need to see signs of willingness from politicians that we have elected in order for them to put pressure on the officials. We cannot come to these meetings and try to protect officials, nurses who are ill-treating our people on the ground, because if we continue to do like that, many people that we have saved from dying from HIV will end up dying from HIV. From where I am seated, I am not prepared to lose the grounds that have been gained by the previous leaders who came before us. Our duty is to build on what leaders who came before us started. But we cannot, if as South Africans, we stood up against AIDS denialism, we stood up against pharmaceutical companies, we stood up in order for people living with HIV to access treatment. That is our victory, and that victory must be maintained. And what I am hearing here and in other meetings, it shows that these nurses want to see our government failing. We do not want to see our government failing. We must work together with our government to police what is happening in our clinics, because if our clinics are not fixed, we will all die. The recommendations are as follows. All healthcare workers must provide timely, accurate, and easily understandable information on treatment literacy and adherence, and the importance of an undetectable viral load through consultations, counseling, health talks, and outreach. We're going to key population.
Thank you, GS. The next group of issues are those affecting people who use drugs, sex workers, and the LGBTQIA+ communities. Going to the clinic can be a traumatic experience for people who use drugs, sex workers, and people from the LGBTQIA community. Instead of helping me, they start mocking me, making fun of me, and calling me all sorts of names, one sex worker told me. A trans woman who has been 2 days late for an appointment told me, the nurse came out and said, Mahosha, why are you late? I cried and she continued stigmatizing me. I waited until they closed and I ended up not getting my ARVs. I don't want to go back to the public health facility again. Only 33% of gay, bisexual, and other men who have sex with men. Only 17% of people who use drugs. Only 26% of sex workers. And only 35% of trans people said staff are always friendly. Staff unfriendliness was one of the reasons given by 72% of gay, bisexual, and other men who have sex with men, 75% of people who use drugs, 70% of sex workers, and 72% of trans people as to why they stopped accessing healthcare services. The majority of people interviewed did not feel safe or comfortable at the facility. In order for members of key population to access health services, spaces are needed that feel safe, comfortable, and private enough to disclose that you're a member of a key population group without fear of judgment, abuse, or even arrest. Disgraceful privacy violation continue to occur that destroys people's right to privacy. 57% of gay, bisexual, and other men who have sex with men, 74% of people who use drugs, 65% of sex workers, and 61% of trans people interviewed did not think privacy is well respected at clinics. Where key population do continue to suffer the daily indignities of using the public healthcare system, specific services remain unavailable for the most part. Ritshidze data reveals that a few sites say they provide key population specific services. However, when you drill down into what those specific services are, it becomes clear that there's little available. Even basic HIV prevention tools are not always available. Only 89% of sites add external condoms in the last round of monitoring. Only 76% add internal condoms, and only 29% add lubricant. This, while 76% of sites say they offer lubricants for HIV prevention, where lubricants are available, too often they are put by the reception or in the main waiting area, or you have to ask for them in the consultation room. Lubricants need to be put in places that people can take them without fear of judgment. Further, only 36% of gay, bisexual, and other men who have sex with men we interviewed, 31% of people who use drugs, 37% of sex workers, and 46% of trans people who had tried to get lube at the public health facilities said they could. In addition, while this has improved this year, not all facilities prioritize offering key populations PrEP, despite this being available in 97% of facilities monitored by Ritshidze. Only 29% of gay, bisexual, and other men who have sex with men, 12% of people who use drugs, 19% of sex workers, and 23% of trans people interviewed reported being offered PrEP at the facility, pointing to the reality that while PrEP is sitting in facilities, those who could benefit are not always made aware of and actually offered PrEP. Harm reduction services are all but impossible to come by. Only 10% of people who use drugs were offered information about where they could get methadone. While only 9% of people who use drugs were offered information about where they could get new needles, meaning people end up using needles or have to share. Only 16% were able to access drug dependency support at public health facilities. Healthcare is also rarely gender affirming. Only 32% of trans people said health services at their clinic were respectful of their gender identity. 64% of trans people that said that clinic staff use their wrong names, and 64% said they use their wrong pronouns. 56% of trans people who spoke to wanted to access hormone therapy at public health facility. Yet, most clinics were unable to even provide information to trans people about where they could access them. We now move to recorded stories.
Kune-story lana engithanda ukushare esingasange singiphathe kahle esenzeke this year January. Okay, mina ngumuntu odla amaphilisi ARVs. I'm transgender and I'm also HIV positive. So amaphilisi ami ngiwalanda eNothdale Clinic khona la eMgungundlovu. Ngelinye ilanga kwakuyi-date yami yokulanda ama-ARVs ami. Ngakhohlwa ngadlula u2 days ngingazange ngiwalande. So ngathi mengichecka ikhadi lami ngabona ukuthi hayibo sengidlule u2 days ngazange ngiwalande amaphilisi. Then I got up in the morning and went to the clinic la ngilanda khona amaphilisi. Ngafika ekliniki ngabeka ikhadi lami as usual because mawufika khona ushiya ikhadi ngaphakathi ekliniki. Hayi ngaqhubeka ngame-queue. Ngathi ngisame i-queue kwaphuma usister ephethe ifayili yami. Ifayili yami yayipink, which was wrong ngoba laphayana amafayili ahlukaniswa ukuthi laba they are positive, laba ba negative. So ifayili mi-pink, it means you are positive. Kukona lokho nje kukodwa ku-wrong. Then waphuma usister ephethe ikhadi lami. Wathi you wena mahosha ngingile engibiza ngawo wonke amagama. Why ufika late? Why uqale clinic eyakho? Because this is not your mother's house. Ngakhala khona ulayini. Ngathi mengikhala wathetha wathi ukhalelani vele ninilala namadoda abantu nenza kanje ngicaze neclinic yenu. Babizwa abantu bathola amaphilisi abo baphuma bahamba. Then kwaqhubeka kwabizwa abanye emva kwami. Ngaze ngathi mina hawu sister mina ngibizwa nini? Kwaphela ngifike before these people asebehamba. Wathi leyo imsebenzi yokuba umahosha. So uzohlala lapho. Ngahlala lapho. Ngahlala lapho. Kwaze kwavala clinic. And I ended up not getting the medication. Angisizakalanga. Ngaze ngaya kwenye clinic ngaqala phansi ngathola amaphilisi kabusha. Kwi-mobile clinic. Njalo bengicabanga lento le. Angifuna ukuphindela kwi-public hospital. Ngenxa ye-Nothdale hospital into eyenzeka kimi. Ngavele ngayeka ngaya kwi-mobile clinic ngaqala kabusha amaphilisi. Kwi-mobile clinic ungcono ngoba if umise i-date bakufonela and then they bring you your medication. Kanti kwi-public sometimes you don't have money to go there, so you'll have to walk. That's why abantu abaningi they end up defaulting. Bengingazitholi at all kwi-public. Into ebengiyithola bekwama-condom and sometimes bengifika khona they were out of stock. Into engathanda yenzeke kuma-public hospitals for abantu abafana nathi ukuthi mhlambe kube ne-section yabo like babe nodokotela wabo kube ne-hormonal therapy yabo abazokwazi ukuthola khona uncedo.
It seems like staff sa kuma-public clinic selela like lama population bani labafana nami too much siyaba disrespecta before sibanika ama services soqale siba humiliate in some stuff like angathi ukuthi or abana knowledge. So I think ngiloko kumele improve nesikhathi if like ngasithi example eclinic kungaya like umuntu loku general population kunguye nemuntu longala kuduka ama-key population lo general population batomnaka fast. Then wena na ufika utafika bokuqala bakubudetela ama-question nje la ngasile la unnecessary like kuthi batry uku-humiliate bayinde i-joke like yeah bakwenza be livestock something like usually suke ukuleli room labo so utshele ukuthi maybe bayi-2 for example akubude uphendule so yahleka so ubita lo mnye mngane wakhe sebabayi-3 yabo like bakwenza i-joke yeah like la ku and obvious nebani labasuke bala ngaphandle because angithi i-queue iba khona la ngaphandle kwalelo room na uphuma babuka wena bavile konke leyo bakukhuluma la khatsi because benda lokho bayashouta bahleke bamake amajoke ngale ngesimo sakho. Yes, there's someone I know low wire for prep naye. Okay, waya kuqala wafika benda lento labangende yona. So wakhona kubeketela wayithatha. Then the following time nagaya for i-refill ngathi uthi bamtshela ukuthi solo akayekeli kubhayiza njani that's why phone treatment nini. Then waduba vele wangasabuyini. Nanyalo akayisebenzisi vele le clinic akayi ngenxa yendlela laba mphatha ngayo. So biyekeli akasayiko access ilo ma services khona. Even noma wathi ngiprefer ukuthi aye kule clinic le sekuthini. Ngenxa yendlela abamphatha ngayo.
Igama Anonymous. Umsebenzi wami engiwenza ngisebenza emgwaqeni. Ngisebenza emgwaqeni. Okubuhlungu ngathi thina sisenza emgwaqeni kuyo yonke indawo la sihamba khona abasithatheli. So XI yakhona bekade seyinuka to a point ukuthi bengisabuke esibhedlela. Ngathi mangifika khona esibhedlela bathi honest bengihlaleleni isikhathi eside kangaka ngazi infanele ngisebenzisa icondom in and I was like hayi ngoba nakho icondom bengayisebenzisi bengisebenzisa. But emva lokho kunokuthi bangisize bakhetha ukuthi bangidelele bangimemeza ngayo bangibiza ngayo wonke amagama. Lento yenzeka ngoMay 28 eRK Khan. Yeah, lapho nakhona ngagcina ngiphumile ngathola ngosizo ngaze ngasizakala kathi BK. Lezo azitholakali kalula especially mawuqunyelwe icondom. There's the thing ukuthi mawufuna amaphilisi kubona bakutshela ukuthi hambe wathenge echemist. Kungajabulisa khona mangase ngelilanga bakwazi nabo ebhedlela bakuthi babe nawo basikwazi usinikeza if siwacela bengasinyasi if ukuthi mhlambe sinezifo esinazo zangaphansi zasemzimbeni like ngoba yonke into ephathelene nomuntu ophantayo emgwaqeni ayikazi yathathelwa entweni ayibhekelwe entweni. Yeah.
Ya nna sister ne ke tsubanya ope ka yona ka thuso go clinicing kwa. Sister batho ba le like sala bona batho ba fella pelo sister ka ke tsela no monya ka thuso ba o ja o be ngwa le bjana wa bona sister ka banda teng sala mkusa bothata wa bona tswa le no le tseba le bo clinicing no makelo ala ke ratoya because of abantshwara wete le no ke ka tshaba pila ke tsama di clinic that's why extra to tsama di clinic. Ana sister no ne ke kula ai ngona sister ke sa clinic ngono ke swa ke go go tsama spetlele vela ai a ke dingwadise.
Lebitso la ka ke Ritshidze Julius Lomo ke dula nyaka Longalang Ritshidze. Ke ne ke na le bothata ba di drugs ke sebedisa di drugs so ka end up ke batla go fumana thuso se ke le tired ko sebedisa di drugs ka qala ka ya clinicing enana e haufinyana o thong ke thusa no clinic ha ke fitla mono ka fumana hore ba mpella ntho hore bona ba ke se kgone ho thusa mabapi le bothata bo ke nang le bona bo sebedisa di drugs ba mpella ntho hore je ka ile hore nna ke itlalletse tsona ho di tsuba ke tla di tloella ka bonna ha ona thuso e batlang fine yona ke ntho ke nyaope batho ba bangata ba ihlalosa ile nyaope nna go re fela ke tsamaye ke ipe hantle nna ke rehabilitate ka bonna ha ona next le medicine a tla mfa ngona ka fa injection ya na tla mfa yona and ka nako eo ke a kula ho bohloko ke di pain e ka mfa la ka ba go di pain bo kona mara ha tlo am feeling next so ka ke nagana ke utlwa le batho ba bua di-advice di tswa bo bathong docteng before ke itlwelela ka drugs e ke itlweletseng ka yone ke ile docteng e bitswang doctor motsweneng monana ka nka prescription ka ya o dindala chemisting ka nka methadone ga ba nthusa ko nwele about a week after a week ka o fedile ka continue gape ka tsuba
Ndingumntu otshaya i-drugs. Into eyenzekayo ndathi nditshaye kanti ndiya-overdose. Ngoku ke into eyenzeka ndaya ekliniki. Xana ndifika ekliniki kwathiwa ekliniki eGompo ekliniki kwathiwa ndizenzile. So akho nto banoyenza bona. Ever since then ke ngozange ndiphinde ndilufumane uncedo uba nangosaqhubekeka kutshaya i-drugs. Zange ndilufumane uncedo endandifuna uyolufuna njengamntu owaye wathi etshaya ndi-overdose ndamongoza ndathini kwafuneka ndidibanise nekliniki sabakwazi undinceda ngoba kaloku babona uba ndi-overdose nam ndayithetha inyani kodwa zange bakwazi undinika uncedo into ndayifumana kushawutwa. Akho nto ndiyifumanayo xa nokuba ndiyile ekliniki andifumani zi-injection andifumani zinudle akho nto ndizifumanayo akho nto ndiyifumanayo xa ndiye ekliniki njengamntu utshaya i-drugs.
Before we go to community stories, in our midst we have Comrade Usaira, who is PEPFA's Deputy Country Coordinator, and she is having a meeting 2:30, and she requested that before she leaves, she can say a few words, and then she will excuse herself. Over to you, Comrade Saira. Must I bring a mic to you, or Mary must bring it, or Simpi? You must choose. Thank you.
Thank you. Just wanted to introduce myself, but first to say the National Department of Health leaders and all who have joined us online, provincial and district department leaders, UNAIDS, country office representatives, Global Fund, other multilateral representatives, civil society leaders, the Ritshidze team that has convened us today, and then of course all of you. A good day to you all. Thank you so much for having us. All protocols observed. So I just wanted to take an opportunity to introduce myself. My name is Sarah Johnson Qureshi. I'm serving as the Deputy PEPFAR Coordinator here in South Africa. This is my 12th day on the job, so 1-2. So I'm relatively new, and I'm so glad that I was able to be here today to hear all of these stories and to hear directly from you all, from the community, hear all of the different recommendations, and have this report. It's very timely. I'm so incredibly proud of the partnership that we have and the importance of the work that you all are doing to improve HIV services here in South Africa. And I just want to take a moment just to reflect on just in the past few months how many data points you all have collected, visiting over 400 health facilities, interviewing over 22,000 public healthcare users. This is incredible. This deserves a round of applause, yes. I just want to acknowledge those enormous efforts to collect this incredible and important information. I have to say I'm deeply moved by what I've heard today, and I believe that together we can work hard to remove barriers. Some of the barriers that I heard we're only halfway through the agenda and halfway through the report, but accessing healthcare, long lines, lost files, stockouts, experiencing stigma and discrimination, so many other stories we heard today and that are included in this important report. One of the reasons why I am involved in this program and that I do this work is that I feel that I'm called, we're called to serve. We're called to serve our communities and called to serve others. And so I think about when I'm at work and the programs that I'm working on, the quality of services that people are receiving in clinics, is it someplace that I would send my family? And if it's not, then we need to do better, and we can do better. Ritshidze is often highlighted as an example of excellent community-led monitoring work across the continent and at the global level. And if there's one thing that I've learned during my 2 weeks here is that what happens in South Africa really not only impacts the country, it impacts the continent, and you all have an impact on a global level. So, you know, what we get right here and what we don't get right here has huge ramifications, and that's a call to action for myself, for our team, and I know for all of you as well. We're excited that in the last 5 years, our collaboration with the government of South Africa, WHO, and UNAIDS collectively saw it fit to support community-led monitoring. Prior to serving in South Africa, I spent some time in Nairobi in Kenya. That's where I'm most recently coming from. And then also, I was in your neighbor in Mozambique. And both of those PEPFAR programs were working on establishing community-led monitoring, and we looked to this program for guidance, for wisdom, for insights on best practices on how to establish a strong and robust community-led monitoring program. I'll say that together we're not only saving lives, we're transforming communities, we're co-creating and reshaping the global response to HIV. This is what you are doing. Thank you again. Communities, they play a vital role in this journey of ending HIV as a public health threat by 2030 and empowering South African communities with the resources, support, and platforms to lead initiatives such as these has been a cornerstone of our success, of our shared success here in South Africa. So my apologies for having to depart early, but I just want to say thank you to everyone here and to those who are not here for supporting this great project. Congratulations to UNAIDS and the project team for yet another successful delivery of the State of the Health report. I'll also say this report is very timely. Our colleagues in Washington, D.C. are already starting to begin discussions and planning for our next country operation plan. So I've requested an electronic copy of this report so that we can share it with them and so that they can, include what's in make sure that they consider and include what's included in this report as we begin our planning for next year's COP. So thank you again so much and looking forward to working together with you.
Thank you, Sarah. We are going to send the soft copy to Comrade Masilo so that he can share with you. Thank you very much for joining us. Over to you, Comrade Sim.
Dumelang.
Greetings.
Kopa ba anonymous.
I'd like to remain anonymous.
Ke sex worker. Clinic ke sebedisa Palm Ridge Clinic.
I am a sex worker and I access services from Palm Ridge Clinic.
So it happened the other day, kile ka raped.
So it happened that I got raped.
Then ke be ke ya clinicing ko Palm Ridge. Ha ke fihla clinicing Palm Ridge,
I proceeded to go to Palm Ridge Clinic.
Then ha ke fihla like ke kena ko roomong, ke thola hona le bo sister oi one ke wa monna ba ithu ke ba basadi. Then hona le me o dutseng o pregnant ka mo hona le o mong o tlo hlaba. Then ke nna ka mo.
Upon reaching the consulting room, I found there were two staff, nursing staff, and a patient who was pregnant, and there was another male patient also in the consulting room.
So like, ka bothata bo ne ke tlile ka bona, ne ke sa feel comfortable hore nka bua hore ke tlile ka eng.
Due to the sensitivity of my issue, I could not proceed to be open about the real reason as to why I was at the clinic at that day.
Okay, so sister ankopa hore ke tsamaye ke rota ka toilet ho na le dikomiki.
The sister proceeded to request that I go and urinate in the funnel in the restroom.
Okay, ke be ke ya ko diromong. Then ha ke fihla mo, like glass o tlamele o itsukuletse yona. Number two, like mroto wa hao if o le ditshila o tlo feta pela batho ha ona le toilet paper.
So the funnels that or the containers that we use to urinate to take the urinary samples are very dirty, you as a patient, you need to take that and rinse it yourself before you can proceed.
So ha ke kena ka roomong ho ntso ho tletse ke batla thuso o kenya pampiri ya bona ba e kenyang ha ke tsebe le hore keng then a nkope hore ke tsamaye ke o qhala moroto hape.
I returned in the consulting room once again, and it was still packed as it was before. The nurse then inserted the strip in the in my urine, and then requested that I go and dispose of the my urine.
Like ha ke le ka go monyele ne ke batla privacy cause thata ke le nka bona like in a situation e leng like ha ya tlwaeleha ke tlo kgona ho ba free jwang ne ke expectile hore ke be re be two fela ha ona privacy so like the way ho no le ka teng ha ke a rata.
The way I was, and due to the sensitivity of my issue, I had expected a bit of privacy so that I can be open and I can get the assistance. I had preferred if it was going to be myself and then attending staff only in the room.
So like tlamehile ke bue and the other thing ne ke na le rashenyana ka mo vagina ya ka ha ke kgone hore ke me explainele cause hona le batho ha ke mo jwetsa o ntjwetsa hore like ha ona ntho re tla o fang yona di ointment ha dio the only thing ha o fihla ka tlong o ka vele nje o nke Vaseline o itlotse o tla ba sharp.
I had no choice but to speak up about my real issue. And in addition, I had a vaginal rash. When I informed her of this, she said that they don't have anything to give me for that. So what I should do, I must apply Vaseline ointment when I get home.
So like I ne ke sa tshaba ka treatment e ke thotseng if ho no ya ka nna ke na le tšhelete like ne ke tlo ikela me ke tseba hore ke tla ntsha tšhelete ke be sharp ke thole privacy ne ke batla ke be right nje o kile bona ke cancel but dintho tseo ha ke a di thola and the other thing it's like kopa le di lubricant and tjwetsa hore yo hai le wena o tseba too much o batla hona so like I so wish hore di clinicing ha re fihla like re ka thola treatment e leng ra deserve as the patient like mathata re kopana le ona sometimes re batho ha wa deserve.
So I wish that I can be privileged to be able to access private health care so that I can get the best quality service, especially for the situation that I was in. On that day, I requested to get lubricants from the nurse, and she was irritated and agitated by this and said that I know too much. So maybe in accessing private health care, I can get the dignified and private health care that I deserve.
Okay, ke a leboha.
Thank you.
Sanibonani.
Good day.
Mina ngisuka eThekwini eKZN and I'm a recovering drug addict.
I am from Etegwin in KZN and I'm a recovering person who's using drugs.
Qaleni ngisasebenzisa ama drugs bengiphandela eMlazi so kwenzakalani la ngolunye usuku saqabana sibanga imali and ngagcina sengikwazeka 8 toes emzimbeni.
During my tenure as a drug addict, I was hustling in the Umlazi area and I was confronted with a situation where I was stabbed 8 holes.
Kulo mzuzu ke shuthi ngagcina ngiquleke emgaqweni hlanhla leyo ke okakhona imoto efike izongithatha yangiphuthumisa esibhedlela.
I collapsed on the side of the road. Fortunately, there was a car passing by and they assisted me to take me to the nearest hospital.
Leso sibhedlela okuthiwa King Mshiyeni Hospital.
The hospital was King Mshiyeni Hospital.
So ngamangifika ke khona ke bangithathe ke bangihande over to ama security. So ama security kube wona angithatha ngisa ko nurse So honest ngalesikhathi ngangibleed kukhona inxeba ngangibleed ngayo lalela isisam la esayidini elona laliwa because ngangibleed ngalo. So
Our first point of contact at the hospital was the security personnel at the gate, and then they later directed us to the nursing staff. So one of my injuries that I had sustained, there was a stab wound on my abdomen.
so bathi honest angijoyine ulayini lapho kugcwele lapho, so ngajoyina kulayini. Ngokwazi kwami ke mina kwangimele mhlambe bangiphuthumise ku-emergency room or something.
So the nurses requested that I join the queue, but what I know is that if you are in that emergency situation and you are bleeding, you should be attended to immediately.
So ngawujoyina kulayini ngokuthi ngangibleeda kakhulu ngagcina sengiquleka.
I proceeded to join the queue, but I was heavily bleeding, which led to me collapsing once again.
So ngoba ngiquleka ke into engikhumbulayo ngiyaphaphama sengise embedeni isikhathi esihambile sekuyintambama ngoba lento yenzekayo ngekhathi sekuseni.
I regained consciousness and I was on the hospital bed, and it was late evening. The incident had happened earlier that day in the morning.
So ngesikhathi nje ngivuka umzimba ubuhlungu ngarealize ukuthi amanye ama-wounds ami engastishiwe, umzimba ubuhlungu mawidlula inesi la ngilicela uxolo.
When I woke up, my body was sore, and I came to the realization that some of the stab wounds were not stitched.
So mangimcela uxolo unesi athi mina seku right manje sengathatha into zami ngibuyele ekhaya. So ngambuza ukuthi ayikho mhlambe amaphilisi engizowanikwa or something. Wathi nje yena cha into emele ngenze qoqe into zami manje ngibuyele ekhaya akekho umuntu ozolokhu ethintana nami ngiyibone ukuthi nginjani.
When I asked the attending nursing staff as to why some of my wounds were not stitched, she responded to say that I should take my belongings and go back home. I further inquired if they cannot give me any pain medication, and she said they cannot do that. All that I need to do is to take my belongings and go back home. They cannot administer any pain medication.
So loyo kozama uqoqa into zami ahambe. Ngendleleni yami nje sengimele ngiphume esibhedlela angivimba ama-security 200 uyaphi ngithi mina ngekhaya. Kuthiwa usukhokhile ngithatha esibhedlela ukuthi kuyakhokhwa ngithi mina cha. Kuthiwa ke indoda kuyakhokhwa esibhedlela.
While I was on my way out, I was stopped by the security personnel at the gate, and they asked me if I had paid for services at the hospital, and I responded to say no, I did not, and they told me that I should know that I should be paying for services from the hospital.
Ngihambe ngiye ekhaya. Mangifike ekhaya so amunye wasekhaya useke wake wakalimala. So wayazi ukuthi itishi kumele ngiqaqe after 7 days. Kodwa ngenkanyama mina I refused because ngangisaba ukuyiqaqa ngabuyela khona to King Mshiyeni Hospital.
Upon arriving at home, I had found my sibling who had also had stitches before, and they told me that after 7 days I need to go and remove the stitches from the hospital. They had removed their stitches themselves, so I insisted on going back to the hospital after 7 days for my stitches to be removed.
So mangibuyela esibhedlela ngaphinda ngivimba ama-security athi ndoda ngeke sakwazi ukuthi sikuvumele la cause why wena awukhokhanga ekuqaleni, so angeke sikwazi ukuthi siphinde sikuvumele ukuthi uze la.
When I reached the hospital, the security personnel stopped me at the gate once more, and they informed me that they cannot allow me to proceed and to proceed and get services in the hospital because previously I was not able to make payment for services.
yimi loyo ngibuyele ekhaya leli nceba ngangilisho ukuthi ngangiphefumula ngalo laseliswa lensilivuvukele ligcwele nodoti. So
I had no choice but to return home, and one of the step wounds was septic, and it was septic and swollen.
ngaphoqeleka ukuthi kumele ngiqaqe idishes zami lezi engisho lenqabela eswini ngathi mase ngiqaqe isidishi sokugcina ila khona laphudlukwa kwaphuma into emnyama yayigazi lamahlulu.
I was forced to remove my own stitches when I arrived at home, and on the step wounds on the abdomen, when I removed the last stitch, a blackish substance, which was bloody and full of clots, started to ooze out of my wound.
Imnikelo wesamuklina-ke leso silonda. So kuze kube nje imanje angaze ngathola amapilisi esibhedlela angaze ngathola lutho ngaze ngayitreata mina up till manje, and ngiyengizwe sometimes ukuthi mangisuthi kakhulu ngiyengizwa amapains esiswini.
I had to proceed to clean up myself because I had no choice. Even today, I am still bothered by this wound. When I eat, I do get some pains on my stomach area. Thank you.
Sanibonani.
Good day.
Ngiphuma eSoweto eSnake Park.
Come from Snake Park in Soweto.
Sex worker.
I'm a sex worker.
Ngapha treatment yami ngithatha eSiphumlile clinic.
I collect my treatment from Spumlile Clinic.
Kunento engangiphathi kahle eclinic, unesi ongangiphathi kahle.
There's a particular nurse that does not treat me well in the facility.
Unesi mangijampise 3 days or 2 days ngimtshela ukuthi ngiye esikorobheni uyangijika ukuthi angikhiphele ngaphandle anginikeza amapilisi phambi kwabantu.
If it happens that I miss my appointment date by 2 or 3 days, the nurse would shout at me and scold at me in front of other patients and chase me outside of the consultation room to hand me or administer treatment to me in full view of other patients.
And ngiyamtshela ukuthi mangiye esikorobheni funeka ngibuye nginokudla angeke ngizothatha amapilisi ngenakudla ngoba la mapilisi aphathisana isiyezi mawungadlanga.
When I inform her that the reason for me missing my appointment is because I'm going to my part-time job, because how am I expected to take treatment on an empty stomach? When you do take treatment on an empty stomach, it makes you feel dizzy and groggy.
And ngapha akangitsheli next makanginikeza amapilisi noba sekangidonsa igazi i-viral load CD4 count angazi next mina ngezonto.
She also does not explain the type of treatment that she's administering. She doesn't explain my viral test results. She does not explain my CD4 count as well.
Ngigcine ngiyekela amapilisi July na 4 months ngasawadli.
I interrupted treatment from July. It's been 4 months not taking my treatment.
Ngaphathwa ukugula ngoNovember ngaye clinic.
I became ill in November and returned to the clinic.
Ngafika eclinic ngatshela umphathi ukuthi ngihlushwa ngunesi ngiyekela amapilisi and manje ngiyagula.
I informed the facility manager that I have defaulted on my treatment because of the bad treatment from the nursing sister, and now I'm feeling sick as a result of the interruption in treatment.
And ngigcine ngincedwa ngomnye unesi wangipha amapilisi nento zokugcobisa. Wathi umphathi wakhona ngingasaphinde bangidibanise nale nesi noba sinye eclinic ngoba uhlekisa ngamphakathi kwabantu unongilahlela amapilisi ngaphandle.
I was told, I was assisted by another nurse in the facility who provided me with a treatment and some ointment to put on. And the facility manager informed me that the next time I must not go to this particular nurse who made me default in the first place, because she would just give me treatment out in the open for other patients to see.
And ngiyacela ukuthi Ritshidze ikhiye kula clinic ngoba ngiyathuka ngilonesi ukuthi ngumahosha ngaze ngibangisana angahambi nami naye makafuna.
I am requesting, I'm requesting for Ritshidze to attend to this facility because at times she would be shouting at me for the very reason that I'm a sex worker, and I don't know why she doesn't join me if she wants to.
Ningaphi into engicelayo ukuthi nasemakliniki bangasibekeli ngaphandle ngoba elokishini sifike sithukwe ngabantu ukuthi siyagula. Ngcono sibe negumbi lethu sodwa ke.
What I'm requesting is that in our clinics, they must not make us stand outside because once we go back to our communities, we are discriminated against and people call us names and give us labels to say, these are the sick ones.
Yeah. Oh.
Thank you.
One in the space and everyone watching online. My name is Aisa Wakamachimana and I'm from Zenini in the Limpopo province. I'm based in 3 different districts, but mostly in Mopani.
Yeser Machanani, Ngipuma Etsanin in the Limpopo province.
I am a transgender woman, and my concern is around gender affirming healthcare services in the public healthcare facilities. The issue is pronouns. The staff at healthcare facilities misgenderize us. So,
Ngingumuntu oyi-transgender, okusho ukuthi ngumuntu onobulili obuhlukile kunaloko engizizwa ngingikho, and inkinga engiba nayo esikhathini esiningi ilokuthi bangibiza ngomuntu wesilisa ngibe ngomuntu wesifazane.
yes, and also the access of human replacement, human HRT. Okay, so with regards to pronouns, it usually starts from the security. You are mostly denied access to the facility because you are producer ID from the gate.
All right.
And
So, enye inkinga ilamaphilisi asisizayo ukuthi sikwazi ukushintsha ubulili. Bayasokolisa ukuthi basiphe wona, but also inkinga enkulu icala lapha ku security mawufika egateini bakwalela ukuthi ungene eclinic ngoba mele ukhiphe iID and mawukhiphe iID ithi wena umuntu wesilisa kanti ubukeka njengomuntu wesifazane.
yes, they will say you are somehow fraudulent and they will deny you services because obviously the picture on your ID and now that you are transitioning, you are twine, right?
Bazothi uzama ukwenza ifraud eclinic ngoba lesithombe esikupasi lakho nale transition ophakathi kwayo noma lesimo sokushintsha ubulili osi-undergowayo akufani.
So even if you try to explain yourself about your identity, they would say, they would use this religious beliefs on you, forgetting kuti that's personal, kuti that you demon, how come you born a male and now you say you are a female. So there's just a lack of training and or knowledge around gender affirming healthcare for the trans community.
Mawuthi uyabachazela ama-security ukuthi usesimeni esifana nasiphi basebenzisa iy'nkolo zabo bakugqeke ngazo bakubiza ngokuthi unedimoni lokuthi why ufuna ukushintsha ubulili ufuna ukushintsha ekubeni mfana uNkulunkulu akuzale unjalo ube yintombazane. So ngibona kunesidingo esikhulu kabi sokuthi abantu bafundiswe ngezinto zokushintsha ubulili.
Also, when it comes to hormone replacement therapy, the staff at facilities don't know anything about it. Personally, I do consult. Even if maybe I could visit your area, I would just go to nearest clinic to access the services. Honestly, healthcare facility workers do not know anything about hormone replacement therapy, and they're not sensitized at all. I remember in July, I consult privately. Unfortunately, it's 3 months now that I haven't been taking my hormones because I consult privately and I don't have a job anymore for the past 4 months. So meaning I'm out of treatment for 3 months now.
So into enye ngiyiqaphelile ukuthi ama-clinic wethu eqiniseni eliphelele ama-nurse awana lwazi ngezinto eziphathelene nokushintsha kobulili kakhulukazi amaphilisi lawo esiwathathayo. So sonke lesikhathi bengisebenza ngithola amaphilisi wami okushintsha ubulili at a private institution, kodwa ngoba angisasebenzi manje angisakwazi ukuthi ngithathe lamaphilisi senginenyanga ezingaba u3 ngingakhona ukuthatha amaphilisi and
the fact ukuthi ama-nurse mangisendaweni mhlambe ngiyovakasha ngiye emakliniki wabo bonke ngibona abafana ngokuthi abazwisisi into yokushintsha kobulili.
Correct. In July, I went to the specific facility in the Vembe district, and I wanted to do my blood work. I was 10 3 times. I went on a Monday, and I only got to do my blood work on a Thursday because that was the only day that the doctor was coming because the rest of the staff didn't know anything about it. And still, when the doctor arrives, I'm the one who needs to give them training about what I'm there for.
July bengise Vembe district la ngiye khona e-clinic kumele ngiyothatha amagazi ngoba ngithi mawushintsha ubulili kumele uphile uthatha amagazi bakwazi ukuwa-check. Ngijikiswe kayi-3 ngiqala ukuya kungumvulo kodwa ngathola usizo ngolosine ngoba amanesi akwazi ukuthatha igazi abazi ukuthi bazongisiza njani. Kwamele ukuthi ngilinde udoktar ngolosine. Kodwa naye idoktar makafika ngolosine kumele ngimchazele mina ukuthi le simo engikiso sempilo ngesinjani ngifundise yena kodwa angudokotela.
Okay, let me just wrap up. Just recently in October, I have someone who's a friend or a client in the Capricorn who has been accessing gender affirming healthcare at a specific clinic in Polokwane. So in October, she went there to do her blood work since she started 2 years back, right? So she found a new staff healthcare worker who turned her back, who said they don't offer such services. And mind you, she has a file, right, to show that she's been accessing the services for the past 2 years. I was contacted, I had to call admin to now refer me to the OPM because personally, when the gender affirming healthcare services was being given to that specific facility, I was there, I was part of the people who was training the facility there. So I was surprised to say that particular person do not know about the services and saying this client cannot be given such services. So now the OPM with the file went to that specific consultation room. Luckily, there were new doctors from Cuba who now gave the services to that particular client, or let me say patient, to that particular patient. And funny part, they do have this medication that we get from the prescribed prescription from the private doctors. They are there in public health facilities. So what is it that we are not getting for free? We have to go buy them because she was then given, the prescription straight from that facility.
Enye into mhlambe sengiceda ngo-October umngani wami onaye uprocess yokushintsha ubulili bekaye eclinic eCapricorn district la afike khona futhi une 2 years ayihamba le clinic athola leyo nsebenzelo kodwa ngo-October makafika uthola kunonesi omusha unesi omusha uyamjikisa uthi bona abayiphanani ngeservice efana naleyo eclinic. Umngani wami wangazisa ngafonela umanager weclinic ukuthi hayi nanga umngani uthi bayamjikisa eclinic iservice kuthiwa ayikho kanjani aneminyaka emibili ahamba ayithola iservice. Ngenhlanhla leyo bakhiphe ifile u-facility manager khiphe ifile athatha umngani wami baye kubo doctor nabafika kubo doctor abasha nabo kodwa baphume eCuba. Sabona ke lapho ukuthi kahle kahle umuthi medication noma amapilisi lawo esiwafunayo akhona eclinic kodwa siyazibuza thina ukuthi kuza njani ukuthi kumele size siwathenge abe akhona emaclinic wethu wamahala okusho khona ukuthi basiphatha ngendlela enjani sizothi ngeyiphi lento esiyenzile ekuthenini basijikise kumele size siyothenga lamapilisi abe akhona wamahala.
Yeah, so I would love to plead with the Department of Health in Limpopo to sensitize their facilities or staff members to offer the services and welcome us as trans or the gender non-conforming people to give these services, because if you were to look at it, most trans people don't even have educational background to even get that job to buy these hormones. So I would love to plead with the Department of Health in Limpopo to start offering these services because they are there, they're just sitting there. So yeah, thank you so much.
Ngingathanda ukuthi i-Department of Health ngingathanda ukuthi i-Department of Health eLimpopo basincephezelele basiphe lamapilisi ngoba akhona mawakhona angasebenzi kusizana. So siyacela ukuthi basiphe amapilisi sikwazi ukuthi siwathole ngoba siyawadinga and ngobuningi bethu asisebenzi mhlambe asikwazi ukuthi sizithengele lamaphilisi kanti bekuzoba lula nangabe basipha wona mahala ngoba vele akhona and abekelwe thina njengabantu abashintsha ubulili noma ushintsha ufuna ukuba umuntu wesilisa okanye ushintsha ufuna ukuba umuntu wesifazane.
We're going to recommendations, but before we get there, Comrade Monwabis and Comrade Sep, kukusisi lo beqabuthetha une blonde hair. Na ka peqa ngwa Sep. Iskipe semorka swallows. That is a very serious case, comrade. And I will be glad before we leave here, you get contact with Kasisi so that you make an arrangement of visiting the facility, Usisi to assist you in pointing out these people who are ill-treating her and other people in that facility so that we can engage with them. Because us convening meetings with our district chief director without addressing a problem where it happened firstly does not help us. By the time Sisiago district director and about HOD, we must be in a position to say we already engaged with the facility. So please attend to that matter. Comrade Rebecca and Comrade Daniel, there is a comrade next to Usisi. Usisi. And I think now, before we leave here, we need to get our contact details working so that we can understand which are these facilities. And if it means TAC comrades in Limbombo must escalate the matter to the HOD and the MEC, I will die a happy man. Comrades, from where I'm seated, the work that we are doing, we are not doing a research. From where I'm seated, I feel like both TAC and Ritshidze comrades, we should not wait until these reports are presented here before we can attend to the problems that are raised here. When we do this work at community level and we get these problems of the people, we must try by all means to attend to these problems immediately. So that by the time we get here, we are able to say, there was this problem, we were able to do 1, 2, 3, 4 to resolve this problem. Because my worry, these reports are released after 3 months. And what happens from the day we heard about the problem to the day we have this meeting? So, if it was for me, there is no other program that TAC branches must embark on except what is contained in these reports. Making follow-up with facility managers, district chief directors, HODs. Because our call and cause is all about serving the people. And if we are unable to go to clinic, resolve problems of the people, then we can just close shops. Because we are no longer serving the people, we're serving ourselves. So I humbly ask the comrades to say, let's attend to all these issues that are raised here. But I will die a happy person if by the time we come to these meetings, these issues have been attended to before we get here. That is my humble request, comrades. Our recommendations, comrades, are as follows. Recommendation 13. Services at all public health facilities must be safe, friendly, welcoming, and confidential for people who use drugs, sex workers, and LGBTQIA+ communities. Healthcare workers and non-clinical staff who ill-treat people, violate people's privacy, or verbally or physically abuse or harass people must be held accountable and face consequences. If it means, comrades, these security guards who are ill-treating us, we know their companies. If it means we must secure meetings with managers of these security companies to tell them that your people's duty is not to play the role of being a healthcare worker, but is all about safety and security. Tell your people to back off from what is happening in the facility. I will die a happy person, because at some point now, we are forced to hold a bull by its horns in order for things to happen. Services specific to the needs of people who use drugs, sex workers, and LGBTQIA plus communities are made available in our public clinics. In the short term, the Centers of Excellence model must be expanded to at least 2 sites per population group per district as a minimum. A minimum package of services should be made available at these facilities. There must be key population-friendly staff at these facilities and resources to provide comprehensive health services to people who use drugs, sex workers, and LGBTQIA plus communities. Easy referral and adequate resources must be provided for people to be able to take up these services. HIV prevention tools, including lubricants, external and internal condoms, PrEP and PEP, are easily available at all public health facilities. They should be available in a range of spaces across the facility, like the waiting areas, in the toilets, at the gate, at the pharmacy, in consultation rooms, as well as in quiet areas out of sight, so people can freely and easily collect them without fear or judgment. People who use drugs are also able to access harm reduction tools like new needles, methadone, naloxone drug dependence support close to home. National Department of Health guidelines and policies should be amended to ensure that naloxone is not only nurse-initiated but can be initiated by a community members themselves. Methadone programs should be made available in public clinics, not only in a small selection of drop-in centers. All facilities provide gender-affirming services, including using trans people's correct name and pronouns, providing gender-neutral toilets, and maintaining respect, privacy, and confidentiality. National Department of Health guidelines and policies should be amended to ensure that trans people are able to access hormone therapy from doctors in clinics locally.
The next set of issues is going to cover advanced HIV disease and TB. AIDS or advanced HIV disease means that a person's CD4 count has fallen below 200 and they are more at risk of getting other illnesses. In South Africa, almost a third of people living with HIV start treatment with a low CD4 count. The lower the CD4 count, the more at risk people are to get other illnesses and possibly die. Advanced HIV disease is a major challenge restarting treatment after an interruption. A large proportion of people who die from AIDS sought care at our public health care facilities, but healthcare workers failed to make a diagnosis or sent them away because they didn't have a transfer letter or were rude because they had interrupted treatment, making them not want to come back. Positively, most clinics say that they have effective systems for tracing and recalling people with abnormal viral load test results. However, most said that they need support in monitoring people with advanced HIV. Tuberculosis in particular remains the lead cause of illnesses and death among people living with HIV, especially people with advanced HIV disease and those who are not yet taking ART. Although treatable, deaths remain high, partly due to delayed diagnosis and treatment, often because symptoms of TB are regularly overlooked by healthcare workers and the opportunity for early TB diagnosis and treatment is missed. Only 68% of facilities have a TB-LEM test available on site, which are critical to diagnosing TB in people with advanced HIV disease. This varied widely across districts, where 100% of sites in Krisiani, Ogo, Umkongondlovo, Ritshidze, and Kangala have TB-LEM tests, but only 18% of sites in Tambofutsanyane had TB-LEM testing on site and 0% in Lijuluputu. While antiretroviral therapy greatly reduces the risk of developing TB disease, TB preventative therapy can further reduce TB sickness and deaths. Once active TB has been excluded, TPT should be recommended to all people living with HIV who
who have never received TPT and TB contacts of the individual with pulmonary TB. However, this is not the case at all facilities, where 89% of facilities give child contacts TPT and only 65 to adult contacts, and only 34 of people living with HIV who were offered TPT in the last year. When it comes to multi-drug resistant treatment, only 30% of sites offer MDR treatment on site. Decentralizing TB care means taking screening, treatment, and care closer to where people live, something that most experts agree are essential in beating back the MDR TB. The TB infection control must also improve to prevent the spread of TB at our clinics and hospitals by following a simple checklist of good practice, including key measures that were successfully implemented during COVID-19. Facilities can be safer for public healthcare users and staff. With the checklist in mind, Ritshidze has developed a scorecard and a traffic light system to rate clinics on how good their TB infection control is. Clinics that adhere to all the measures are given a green light. Those that are on the right track but still off target get a yellow light, and a red light is given to those who are way off the mark on ticking the checklist for the 6 measures. In October and November 2023, one facility was awarded green status for checking all 6 measures on the scorecard. 128 facilities were awarded yellow status for following about half of the best practice measures for infection control. This leaves 228 facilities surveyed that failed altogether at meeting these 6 best practices to stop the spread of TB. We are going to have recorded stories.
Mina into engangiphathanga kahle ngisebenzisa iSavannah iclinic la suka la ngiyekhona ngafika ngiyolanda i-treatment so mawulanda i-treatment iphuma kwiphela box for that day ayiphumanga kwathiwa ngehlele ngezansi mangehlela ngezansi abesethi lo kufanele ngi-treatment angihambe ngothatha amagazi bese ngithi no amagazi ngiwathatha maku October ngithathe amagazi ami vele athi naye akukho right la kufuneka uphinde uyothatha amanye ngithatha ama-ARVs yes so ngihambe-ke ngiyelapha bese nginokha nginese besethi uthini ngithi mina kuthiwa ngize la kuwena athi uzothini ngithi no uthe unesi angize kuwena ngizothatha amagazi athi ngiqedile ngamagazi I think past 8 nginithathe lapha phezulu ngathi ozothatha amagazi akangilandela so angisayingeni indaba yakho ngithi mina yangazi ukuthi kuthiwa ngize kuwena saba ngaleyo nto ke wavele waphuma la eroomini weza kumina washo nje public wathi kushuthi nje bakuthiwa thatha amagazi nje igciwane amaphilisi awadli kahle igciwane lakho kushuthi liphezulu ngeke kuthiwe phinde uzothatha amagazi amaphilisi wadla kahle into yangiphatha kabi yodwa bonke laba bantu ababelapha eclinic basebebuka into upositive lona engculazi hayi wangena nami wangenza esengiphoxile lokho nje wangiphatha kabi angisho ukuthi ngiyamind ukuthi ngipositive ngiyasazi isimo sami kodwa wonke umuntu olapha usebuka ukuthi lo sisi positive akayidli kahle treatment njengendlela angitshela ngayo ngasuka ngahamba sengiqedile ukungithatha amagazi ngaye kwenziwa kwenye room banginike treatment ngaphuma lapho ngaya kumphathi eroomini yomphathi wabo ngayasho ukuthi ngibe nenkinga ngiphathekanga kahle clinic wathi yini ngathi usisi lo engithatha amagazi kungiphathe yabo thatshele bonke abantu lapho ukuthi ngipositive ngama treatment angidli kahle wathi yena hayi kulungile ngizokhuluma naye.
Oh, okay.
Mina ngangilindele ukuthi uzombiza athi wozala sihlale soba u3 u10 kusisi lo axolise mexolise kodwa azangayenze leyo nto njengomphathi wathi hayi uzokhuluma naye but yakongiphatha kahle ngangoba yazi ngahluna uyibamba inyembezi hayi kwangiphatha kabi shema ngiqamba mama ngoba kumina ngedwa ophathana kabi lapha eclinic okuthiwa ngiphatha kabi nabanye abaphatha kabi
so
ngiyazi ukuthi ufundile ngoba yena wathatha ngalokho athi mina nginandaba kusala ngiyahola mase kuphela inyanga mina ngokwami ukuthi vele ngeke kwenzeke ngendlela yami engabe leyo nesi uyasuswa eSavannah ayisho kwenye indawo ngoba akwazi ukuphatha abantu
Hayi ngaze nyeza kodwa manje ngangicabangela impilo yami ukuthi ngeke ngikwazi ukuphila i-treatment enganayo. Cha ngayinyeza ngumqamba manga.
Bengisebenzisa le clinic yala Newlands West. So experience yami i-TB ngayithola last year is about September if I'm not mistaken. Isifuba sami ngasizwa ngitsho singiphethwe umkhuhlane. Base ngezwe umkhuhlane awupheli isifuba siyasinda. Then mesiyo checka wathatha isikhathi eside kunalokho bese ke-expectini noma ngoba nama results sasitsho sibazo send efoni sayihamba sayoyicheckela thina. Ngoba sasitsho sihlambe ama results asathu 4 days ukuthi efike i-message yemphumela but saze kwaze kwaphela 2 weeks noma
2 weeks, yeah. 2 to 3 weeks.
Banginikeza amaphilisi then lapho ngaqala ngilokho ngiattenda khona. Mina ngilokho ngiattenda but isikhathi lapha ngasho ukuthi abakwazi ukusigcina isikhathi ngoba sometimes bemele ngihambe ngiyolanda treatment mase ngeschooling. Mengiyeschooling sometimes bengize ngifike later ngenxa yakhona ukuthi isikhathi abasigcina bagcina benaka abanye thina bengasinakile bagcina beze bebona ukuthi ngigqoke uniform ukuze kuyima bengi-attend mostly ngoba la i-area ngiba kuyona la ka TB ngoba nambe ngize sometimes ngifike after break esikoleni noma ngifike ngebreak basi la amanye ama-period angisakwazanga ukwakhetha ngenxa yokuthini bekumele ngilande medication. Istaff nje sibahashi too much sometimes abakwazi ukunderstand thina ngoba nathi hayi ukuthi mhlambe nathi sesiba disrespect noma khona la singababoni khona sayibona ivalue yabo kuyikona ukuthi nathi ukuze sibahloniphe nasi sicela besihloniphe.
Currently I'm using Newlands West Clinic. Into eyenzeka kumina it was so painful. We went and tested umntwana for TB ngebhadi watholakala ukuthi u-positive ama-sputums wakhe wayiqala i-treatment on the 2nd month mase ngiyolandela umntwana medication yakhe ngafika around 12 unesi wangitshela ukuthi abantu be-TB bafika ekuseni you can't just come in ngeke akwazi ukungisiza. Into engambuza yona ukuthi how come ukuthi ningasitsheli while sizolanda medication ukuthi kufanele sifike early if sizothatha medication. So angitshela ukuthi yena ngeke akwazi ukungisiza. Luckily bakhona onesi engibaziyo ngahamba ngayofuna usister in charge ukuthi akangi-assist because angikwazi ukuphindela emuva sengifikile kwi-facility. Ngamtshela usister in charge ukuthi ngiyele ku-sister wangitshela ukuthi ngeke akwazi ukungisiza because ngifike ngalesikhathi. So sister in charge waya kuyena bakhuluma ngabu wathi sister in charge okay akangikhiphela ikhadi wathi sister nje ngeke akwazi ukungibhekela ikhadi because lelo khadi akalazi nalokuthi likuphi. Into ebhlungu ukuthi amakhadi ahlala khona kuleyo room leyo. I end up going back to sister in charge ngamtshela ukuthi uthenge akwazi ukungibhekela ikhadi where's sister in charge wang-assista walikhipha ikhadi wanginikeza medication. And it's so painful ukuthi ungafika kwi-facility ugcina uhambile ungalitholanga usizo. I would like them to change attitude towards ama-patients because ekugcineni kosuku usuku ungazile ukuzodlala mawuze eclinic usuku wazi ukuthi uzokwenzani. And into engicela ukuthi kuyenzeke leyo ukuthi ama-patient mayifikile ukuthi alinde eminyango it's so painful kuyabanda manje. And even ngisho ngathiwa kuyanetha bahlala eminyango. I would like them ukuthi kubuyele kulesa simo before ukuthi mabefika bangene ngaphakathi because since kade kuno COVID manje sebehlaliswa ngaphandle abantu ngisho ngathi ufike early as possible but kufanele udliwa amakhaza ngakwenzeki ngebhadi ufika nje ubanikeza ikhadi and uthatha medication yakho uhambe awu screen for anything. It's just that ukuthi bathatha ikhadi lakho bawukhiphela ifile yakho and go inside the clinic uthatha medication phuma uhambe. Itaba effective kuyona ukuvula ama-wind and doors kuyavulwa ke lokho, but in terms of ukuthi umuntu uma ekhwehlela kufanele bam-fast track, no, uyahlala nje ukhwehlele until kuze kube ukuthi kufike egameni lakho bakwenzeke whatever uzokuzela.
We are now going to go into the community stories.
Greetings to everyone. I'm a resident here in Mamelodi East, and then it happened that last year, December, my dad got diagnosed with TB.
Sanmanani, ki moduli wa Mamelodi East, selemo se fedileng ho etsahetse hore ntate wa ka a nne diagnosed ka TB.
And then at stanza 2, they told him that if he has people that he lives with in the house, they should also come and get tested.
Ko stanza 2 clinic ba mo tlhaloseditse hore if ana le batho dulang tlong le bona ba tlamehile hore ba tle ba tlo testiwa for TB.
Okay, so I went there this year. So when I got there, my worry is one, to start with, TB, it's very much infectious and it spreads very fast.
Nang fika lapho neki le worried hobane TB ke ntho e kana lula futhi ngasheshe kokuphathe.
So if maybe there might be a possibility that I might be infected, we were not even isolated, like the patients were with other patients who might have TB.
Neki bona hore ha o hantle hore re kopantse as batho, especially the patients, because no kana wa etsahala hore nna ke na le TB, so ha ke kopantse le batho ba bang, that it's possible hore le bona maybe ba na le TB, ne ke ipotsa hore tlo etsahalang.
So another thing is this, I think maybe because of the shortage of the staff, some of the staff members, the nurses, they get frustrated. And when they do, we don't have a good communication. We as patients also get frustrated.
Ntho engwe ke boneng ke hore ba shota ka di nurse, and ha di nurse di sebetsa di ntse di shota je ba qetella ba fellwa ke pelo, and then le rona as patients a re kgone go khotlella ba re qetella re lwantshana le rona le di nurse.
So it would have been better if you came there for testing for TB, you should have been on a different room, maybe a room that is for people who are there for testing on that particular day, because you are expected to be there.
Ne ke nahana hore no kana ho ba bitere if hona le room e separate for batho ba tlileng ho testa for TB, because kaofela rona ne re tla ba re bitsitswe, so ba tseba hore ra tla for TB testing.
But despite that, they were able to help us. And then for me, for the solutions, I think TB patients should have an isolation ward room. Due to lack of staff, we are all human beings. The staff should just communicate well with patients. Their manner of approach should be positive and professional.
Ke nahana hore ntho tse ba ka di etsang ho lokisa bothata bo re kopanang le bona ko ditleliniking ke hore di nurse di kgone ho bua le rona hantle, because kaofela rona re batho, so ha re ka buisanang hantle re tlo kgona hore re tswele pele hantle kaofela rona.
And another thing, health institutions should allow people to volunteer so that things can be better for all of us, and so that the working space at health clinics should be better.
Ke nahana hore ko ditleliniking ba kana ba dumella batho ba ithaopang hore ba tle ba tlo thusetsa mo ho na le dikepo teng ka tsela eo re tlo kgona hore re pushe hore batho ba kgone ho thuswa ka bonako.
One last thing, when a doctor or a nurse diagnoses a patient with TB, HIV, or whatever the disease might be, they should give you as a patient the relevant information needed so that the patient becomes aware of what they are dealing with in future.
Ntho ya ho qetela ke hore ke nahana hore di doctor kapa di nurse ha ba hlalosetsa hore o na le sick e itseng, ba tlamehile hore ba o fe tsebo kaofela e tlhokahalang hore o be le yona a phelang le kokwanahloko eo ya TB, ya HIV kapa sick engwe le engwe, so that o kgone ho tseba hore di steps tse latelang after diagnosis ya hao ke tse feng. Ka lebo.
Dumelang kaofela.
Good day, everyone.
Lebitso la ka ke nna Tshepo. I'm from Winterveld, Mabopane.
My name is Tebo. I come from Winterveld in Mabopane.
Ko Mabopane re berekisa the clinic e leng hore ke yona e leng the nearest ba re ke Khabo clinic.
The nearest clinic where I'm accessing service is Khabo clinic.
Early this year, it was February. I encountered the symptoms of TB.
Kulonyaka ngoFebruary ngayizithola ngineyinkomba zokuthi kungenzeka ukuthi ngibe nesifo se-TB, isifo sofuba.
I wasn't so sure the symptoms of TB until I went to the internet and started searching based on the symptoms that I have.
Nganganaso isiqiniseko ukuthi ngempela leyizo inkomba zesifo sofuba. Ngaze ngahamba ngaya ku internet noma ku Google ukuthi ngikwazi ukubheka ukuthi ngaba yizo na.
And indeed I found that it's one of the symptoms of TB. So the following day that's when I woke up very early in the morning katamaya ebekiya go khabo clinic.
Ngempela ngathola ukuthi le inkomba enganginazo ize TB kungenzeka ukuthi ngine TB lokho kwenza ukuthi ngosuku olandelayo ngihambe ngiye emtholampilo seduze nami okwakuyiyona iHabo clinic.
Okay, as normal as usual thina vele sijwayele ukuthi iclinic uyama vele noma ufike nje ngesikhathi bani uyama then umela is okay umela isikhathi sokuthi bavule vele ngo-18 ize ningene ngaphakathi.
We are accustomed to the long waiting times at the facility, even though we arrive very early before the facility opens and they will allow us or let us in around 8 a.m.
So yimi lo ngiyangena vele I had to ukuthi ngikethalose horne what's my problem, and then ebe kethlalosetsa one of the nurses or no I think I'm experiencing the symptoms that TB.
I then, when it was my turn, I was given a chance to explain why I was there. I then explained to the attending nurse what my issue was,
Okay.
all the symptoms that I was experiencing.
Okay, then ebe bampolela hore no wait ema mo lining just like batho ba bang because you're not special wena mo like re ka se thusi wena pele like ra tloela batho botle ba ba leng.
They rudely told me to return back to the queue and asked me why do I think I'm special that I should be attended to instead before the other people who came before me who were waiting in the queue.
So I definitely did that. Kaema mo lining, then from there, that's whereby file yaka which leona ki emensis for a very long time mo lining mola with other people.
I indeed went back to the queue and waited like everybody else. I waited for my file to be retrieved, and that took a very long time. We said for prolonged hours.
Okay, then I've decided to give one of the nurses or since well ki nahana hore ke na le TB and in which like is not yet tested. How about I get a face mask at least for now, so that if it's possible ke na le TB is ever can infect some of the people who are lying around it.
Ngiyacela sizame ukwehlisa umsindo kancane njengoba sidla. So I inquired from the attending nurse that since I'm presenting with TB symptoms, or rather I suspect that I have TB, can they not provide me with a mask so that if indeed I have TB, then I cannot spread it to other patients?
Okay, so now that nurse like ke sebe ka mmotsa hore a etse bjang mmereko wa hae.
The nurse responded to say I should not be dictating or telling her how to do her job.
Okay, then I waited until they went to lunch. Then after lunch, this sister attendile. Then ebangisa to some sort of a room whereby I had to give barking my sputum. Kisi kwele kamara this container.
I was, after lunch, they attended to me. I was taken to a consulting room where I was requested to, or rather where they took my sputum to be tested.
Okay, then after that, the sister kere, like, okay, after that, after the sputum, then like, I got one or maybe some sort of a medication. Honey, we are not yet sure I'm TB positive, but since according to my research, keep on the symptoms the same as TB. Don't I get some sort of a medication like in the meantime until you guys confirmed? Then that's when she said no, like I should go and wait for the results.
After I had given the specimen, I was advised to leave the facility. I inquired from the attending sister if they cannot administer anything, even though we don't have the results as yet, but maybe what can assist me in the interim while we wait for the results to come back.
Okay, all in all, what hurts me the most is that I think is that cause ya hore ahane humfa some sort of a medication so that I can prevent it maybe or for that time, because that thing it led hore one of my siblings Lena ebe our TB positive, and as we speak unale asthma, taking that spray.
What was hurtful to me is the fact that she was not able to give me either any prevention or any treatment. And I personally feel that this led to one of my siblings contracting TB, and it's unfortunate it's unfortunate that she's also asthmatic and she's taking the asthma spray.
So now, personally, I think all the nurses that go Cabo Clinic, like they should just be schooled, like specifically got TB, because they think like it's a child's play. So I think like they should just go to school just for TB because they don't take it very seriously. Thank you.
My appeal is for the nursing staff from Gabo CHC to be thoroughly educated about TB, because they don't take it seriously. They don't take it as the natural, as an emergency that it should be. Thank you.
Sanbanan.
Good day.
Sello wakamazbuko. Ngihlala la eSlovo ngisebenzisa iKhabo Clinic nami.
My name is Siloma Zibugo. I reside in Slovo area and I'm accessing services from Gabo Clinic.
Ekhabo ngike ngaba ne-incident nomunye usisi oncedayo laphayana. Wafika a route that day angibuzisa ukuthi namhlanje ilanga lakho lokuzolanda treatment na.
At Gabo Clinic, I experienced an unpleasant incident where an assisting personnel rudely asked me what was I doing there. Was it my treatment collection date?
Ngamtshela ngathi ilanga lami nalikhathi lami lakutshengisa namhlanje ukuthi ilanga lami lokuzolanda treatment. Athi why file yakho manje ingekho la? Ngathi mina ngizayazi njani ifile ukuthi ayikho la ngoba ngisebenzi la.
I confirmed to say this was my treatment collection date, and I showed her my file, which showed clearly that it was my treatment collection date. She further asked, why can she not find my file or locate my file then if it's my date? And I responded to say, how am I supposed to know that? Because I don't work in the clinic.
Ahamba ayangale ngasemuva ayofunana nefile muhambe close to 50 to 1 hour.
She went to the back, probably to the filing room, where she said she was going to search for my file. She was gone for about 15 minutes to an hour.
Umama kabuya lapha ubuzisa mina ukuthi yeah vele nalifile lakho usoyile le entweni egate ukuyotesta ukuyopompa into lena nokuqalisa ngambuzisa ngathi inyoya kanjani ngoba nazi izinto la athi hayi khona manje science la lento le meluyele.
Upon her return with my file, she inquired if I had taken my vitals. I then asked her how was I supposed to take my vitals because I did not have my file. She told me that they no longer take the vitals here and I have to go back near the entrance for my vitals to be taken.
Ngaya laphayana ngama because besokugcwele laphana ngeme close to 15 minutes. Ayaza kimi a route that sisters abuzisa ukuthi kanti uphuselo mazibuko la ngiyamtshela ngathi nangu yimi lo athi wama lapha phakathi kwabantu so uzazi ukuthi uyagula wena uphethwe iTB. abantu bonke basuka babaleka lapha phambi kwami kwamele ukuthi manje mina ngobe wami umsila ngiye phambi kwakhe lapha yana uma mangifika lapha yana nyambuzisa ngathi mara sisi mayo osozukhuluma so kanje kanti yini inkinga athi nina nizwa nina abantu abaphethwe i-TB ngathi
After about 15 minutes, I came back, and when I came back, the same nursing sister was shouting my name, "Where is Silo Mazibuko here?" And then she shouted in the midst of other people saying that, "Why are you here? Why are you standing here with other people while you know very well that you are a TB patient?" And other people started to get scared and they dispersed from where we were standing or waiting.
kusuka lapho angithatha angikalisa lapha kulabo sister labo bebakhona lapha yana sasuka masiloku sila endleleni lokushawuthana nami ngamtshela ngathi sisi yazini ngathi usuzugcina masuthole nempamba kungasikudala ngokuthi yabona manje songibela inhloko ngathi manje ngihlahla sensango.
She fast tracked me to the people that were taking the vitals. And after that, we walked to the consulting room. Along the way, she was busy shouting at me. But this time, I retaliated by saying, "Hey, I think now you're going to get a very hot clap."
Sanmonani. Kamalam Gunompilo Madlala, all the way from KZN, Epitamarisburg. Clinic in Sebenzisayo Impilwe, Beng Sebenzisa Impilwe.
My name is Nompilo Madlala. I come from KZN. And I used to access services from Impilwentle Clinic.
I'm living with HIV and TB. So this year, June, kwenze kukuthi a family relative atholakale ene TB, and then we were called in.
I'm a person living with HIV, and I was also taking TB medication. And this year, around June, it happened that one of my family members, whom we live with, was tested positive for TB.
So when we were called in, we coughed lapha ekliniki la eGrange la akaye khona yena mina ngisebenzisa impilo enhle. Uma siya khona, it was towards the end of the week. Malphela isonto ama results awakafiki angene ngeweekend ama results kimi. Athi angiphuthume to the nearest clinic.
We were summoned to the clinic as TB contacts. And a sputum or specimen were taken from us. After about a few days, it was during the weekend, I think, where I received results on my mobile device, giving me the positive results.
Kade siya ekliniki la relative bebengasitshela ukuthi kuzokwenzekani uma kwenzekalani. So mina I assumed ukuthi kumele ngiphuthume ekliniki leli engilisebenzisayo.
At Grand Clinic, where my relative is accessing services, and that's the clinic where they had requested that we come.
Comrades, we cannot eat and talk, and comrade is on the floor. Kunomsindo ngapha. Can we please eat and not eat and talk? You may proceed, okay.
So at Grand Clinic, they did not properly explain the entire process to us, that upon getting results, I must not go back to the clinic that I usually use, but come back to Grand Clinic.
Kwa lelo kliniki ke mina impilo enhle, it was just a name. Bengingakaze ngiye kulona bengisohloleni lwemoto amaphilisi bebengilethele endlini. I've never experienced ukuthi I-treatment yakhona.
I only know, I knew Impilwentle only by name. I had never gone there personally to access any services because I was currently on a mobile. I was decanted to a mobile service option where my treatment was delivered to me.
Upon arrival at clinic, because vele treatment ngilethelwa, I didn't have my card. And then I immediately went to a clerk khona ngalichazela ukuthi kune message engena kanjena and ikhadi angilitholi. Ngicela ungichazele ukuthi ngenza njani.
Upon my arrival at the facility, I did not have my clinic card at hand because I did not require that for my medication. So I proceeded to the filing desk where I explained to the filing clerk that I do not have my card. Can they please advise how should I proceed?
Angiphathekanga kahle ngoba kwathatha isikhathi eside ukuthi ngisizakala abantu abengemva kwami bangena ngaphambi kwami kwathiwa angilinde thina abantu abemoto sizizofila privileged kakhulu angime la eceleni nangazi ukuthi silanda amaphilisi emoto sibancane kanjena engabe siyeze clinic sizolanda amaphilisi.
I felt really harassed because I was told to stand on the side because as people who get treatment from the mobile service think that we are special, and she's not sure why, as young as we are, you want treatment to be delivered to us instead of us coming into the facility.
After isikhathi esideke nje kunokhilizisana I then managed ukuthi ngingene ngaphakathi ku sister. So uma ngingena ngaphakathi ku sister, she had my file and then she opened my file wayibuka wase wathi ha i-viral load engaka wozongibonela ubiza omunye unesi.
We argued for some time with the nursing sister when I entered the consulting room, and she started to go through my file. After going through my file, she then said in a rude manner, your viral load is very high.
Okay. Afike lo munye unesi and then I told him ukuthi kahle kahle into engiyizele lana ukuthi ningicheckele le message nansi message ephuthumayo engenayo and I'm stressed ngiyabhala at that time and ngifuna ukwazi ukuthi kwenzakalani ngempilo yami.
Another nurse walked into the consulting room and I explained to them the real reason why I was there, and it was because of the SMS that I had received giving me my TB test results.
Emva kwalokho ke bangitshela ukuthi ukhwehlelephi mase ngiyabatshela ukuthi ngikhwehlele Grange, then they said you must go back khona thina asikwazi ukuthola ama results akho la.
They asked me where I was tested for TB, and I informed them that I was tested at Grange Clinic, and they said, why am I coming here for the results instead of going back to Grange Clinic?
I told them ukuthi I thought ukuthi mina kufanele ngize clinic yami. I couldn't be using two clinics at the same time, two I'm unemployed, and ukuya kuona both lama clinic kungikosta imali ngibela 2 times indawo engihlala kuyo ayinayo clinic.
I responded to say it was not explained to me which facility I should go to, and in any case I was not going to be able to go to 2 different facilities because I needed to get to travel using taxis going to both clinics, and I am a person who is unemployed.
We went back and forth arguing about the thing kuze kwafika to the point la khona ngicela khona umphathi wakhona.
Our argument escalated to an extent that I requested to speak to the facility manager.
And myself umphathi wakhona, you could see ukuthi she rather lose a client patient than amanesi. She was siding with them, telling me the same thing. But okungixaka kunakho konke ukuthi if bafundisekile nge-TB, they know ukuthi ispread se-TB senzeka kanjani, ukuthi they can chase me sengifikile instead of adhering medicine to me bangithumele kwelinye clinic futhi lisazophinde lingicost imali and travel.
I was very disappointed by the fact that the facility managers displayed a lot of bias when she came here, because she further confirmed what the nursing sisters were telling me, that they cannot be able to assist me with my results. And I was disappointed at the fact that with so much spread of TB, why did they not assist me and administer treatment while I was there?
And what had me the most ukuthi ngesikhathi sengibona ukuthi akuhambi kahle ngacela i-transfer, and then bebe busy nje bekhuluma bengibiza ngo-viral load. They were referring to me as u-viral load. Sizana u-viral load lapho nge-transfer letter. So nje lokho akungiphathanga kahle.
Because of the harassment that I was subjected to, and remember that this was the clinic that I was usually using, I requested to be transferred to another facility, but they were now referring me to viral load. I called that viral load, and they were not using my name to call me. Thank you.
Molweni.
Good day.
Ndisuka eMthatha, ndisebenzisa eStanford Clinic.
I come from Tata and I access services from Stanford Clinic.
Ndiphila nentsholongwane kagawulayo.
I'm a person living with HIV.
Ndaye ndafumanisa apha ekuhambeni kwexesha ukubana ndinayo ne-TB.
After some time, I was diagnosed with TB.
I-treatment ye-TB ndiyitye about 4 years ndihamba phaa kulaa clinic yaseStanford.
I was on TB treatment for 4 years and getting the treatment from Stanford Clinic.
Xa ndilenza lifutshane ibali ndiqhubekile ne-treatment ndaphuma amaqhuma apha entanyeni ndimane ndisiya kunesi xa ndibona ngathi kukhona into efane ndingayiqhelanga.
To be brief, I continued with my treatment up until a time where I got blisters on my neck, and then I returned to the clinic to inform the nurse of this.
Unesi uthe no umuntu one-TB uba nawo lamaqhuma qhubeka utye treatment mhlawumbe azawuphela nam andiwazi enziwa yintoni.
The nurse ensured me that a person who's on TB treatment usually experiences these blisters. I should continue with my treatment and these will go away.
Ndiqhubekile ke ndisitya le treatment but ndifumanisa inobana the more ndisitya treatment the more ndisiya ndisiba weak emzimbeni.
I continued with my treatment but realized that the more I took my treatment, I became weaker.
Apho ndide ndagula kakhulu ndahamba ndaya esibhedlele nda-admithwa esibhedlele eMthatha General.
I got very ill to the extent that I was admitted to Mthatha General Hospital.
eMthatha General Hospital ndifike ndatsalwa amagazi xa nditsalwa amagazi ndafika ndaxelelwa ukuba i-viral load yam iphezulu kakhulu, it's over than 1 million.
At Mthatha General Hospital, blood work was done on me, and I was told that my viral load was beyond 1 million copies.
Ndabe eclinic ndingazange ndakhe ndanikwa i-results ngendlela efanelekileyo ndijongelwe i-results zamba why i-treatment yam isenza kanjena kum.
At the clinic, I was never given my viral load test result, and I was never told why is the treatment not responding.
Ndincedakele ndakufika esibhedlele ndatshintshelwa i-treatment ndanikwa i-TLD. Ndayeka usebenzisa la treatment ndandiyisebenzisa kwakungona ke ndiya ndiba ngcono ndisiba right up until ndaba right ndaba ngu-U is equal to U xa namhlanje. Enkosi.
At the hospital, they assisted me in that they administered TLD, and I could see a change. I started to become better until I was suppressed. Thank you.
Sanbona.
Good day.
Igama lami nguSisiwe Sibiya. I'm from Etembisa, Ekululeni district.
My name is Busisiwe Sibiya. I come from Etembisa, Eguruleni district.
La ngihlala khona nginenkinga ne-clinic igama layo it's Irene Clinic.
I have an issue with Erin Clinic.
Inkinga engahlangabezana nayo kuleya clinic. That clinic is very small.
The challenge at that clinic is that the clinic is very small.
And ngaphandle akunama shelter la ukuthi abantu mabafika ekseni bame khona.
There is no shelter outside for patients while waiting to be attended to.
And lelo langa lelo bekubanda kakhulu so abantu bebagodola.
On that particular day, it was really cold and people were cold.
So bengaba nesicelo sokuthi ngingasiza kule clinic.
So my request is that we are assisted in that clinic relating to space.
And enye into futhi akuna nabantu laba ababuzana ngama TB and HIV.
There are also no people that are screening you, either testing you for HIV or screening you for TB.
Thank you.
Thank you.
We are going to recommendations. Now I'm going to take off my cap as Ritshidze and wear my cap as the General Secretary of the Treatment Action Campaign and the leader of the PHIV sector. I have attended about 7 provincial community accountability meetings, Mary, and about 11, if not 12 of them. Now, I am calling upon TAC leaders, NAPWA, Sanarela, Positive Action Campaign, and PWN to say, in all the meetings that I attended, majority of the people who attended those meetings are people living with HIV, and they don't belong to any of these organizations of ours. Now I am giving you an instruction, comrades. Starting from today, let's go to all these people and recruit them to our organizations. Because if these comrades are part of a membership of our organizations, they will benefit in terms of treatment literacy education and other information that which they might use not to benefit them but to benefit communities. I think let's agree to TAC, NAPWA, Sanarela, PWN, and everyone to say it must be regarded as a crime for us to have a community meeting where community members, people living with HIV are coming forward and we allow them to go without recruiting them to our organizations. If we want to build our organizations, the people who've got first-hand experience of what happened to them in the facilities are angry. And they know how it feels to be denied health services. And if we can have these people as members of our organizations, they will use their anger to fix the problems on the ground. Because if they become members of our organizations, one thing that they will make sure that no other person goes through what I went through. These are our comrades. These are our members. Our duty is to recruit them to our organizations, involve them in activities, bring them to these meetings with facility managers, bring them to these meetings with communities to address problems that we experience in clinics at community level, but also bring them to the treatment literacy education session so that they can know why it is important to be tested, why it is important to be initiated on treatment, why it is important to adhere on treatment. But above all, people will be able to know what are the standard operating procedures of differentiated model of care. So that when people are going to health facilities, if they miss their appointments and attend back on the queue, people will be empowered and they will be able to say, but according to DMOC SOPs, it says, if I miss an appointment, I must be treated like any other person and not be sent back to the queue. They will be able to say, the guiding principles of DMOC SOPs are saying, you cannot be denied services because you do not have a transfer letter. We need to build a community that is empowered, a community that is able to fight for itself. What is frustrating me here, majority of the people who are giving testimonies, they want to be helped. Comrades, it is only Jesus Christ who was crucified and who died for all our sins. There is no other Jesus Christ who is going to come down to earth and save us. We are our own liberators. You, me, and all of us here, if we are unable to stand up and fight for our rights, no one is going to fight for us. Each one of us here, we must be able to fight for ourselves and the communities that we represent. And we can only do that when we are empowered, when we know our rights, when we know services that are available at facility level, so that when we argue based on facts. So, I hope that leaders from these organizations will heed to the call and make sure that we leave no one from the communities that we engaged with. Because my only worry is only when we go to communities, take the stories of community members and problems and we leave them there. It must not be about stories. It must be about us, asking them to join the struggle. It must be about us, asking them to get inside the wagon, to freedom, because no one is going to give us freedom. If we want freedom, we must be prepared to lay our lives. If it means we must be arrested, if it means we must die for generations that will come after us to get better services, let it be. So, this, I understand, committee members, we will empower each other, and then even if I am alone in a clinic, I will be able to stand up for my rights and fight for others who will come after me. We're going to recommendations, comrades. Number 18, improve diagnostic and treatment for people with AIDS and cryptococcal meningitis. Improve identification and management of people with advanced HIV disease. A CD4 test for every person newly diagnosed with HIV or returning to care, sick, or after interrupting ART for more than 3 months. TBLM testing available at all sites. Effective abnormal result recall system set up and funded at health facilities. Implementation of targeted universal TB testing that gives everyone at high risk of TB a TB test in a public health facility. 3HP, a newer and better TB preventative therapy, is actually rolled out in the country, and rapid adoption of guidelines and policies support this. Enough community health care workers to be hired to work in our communities with the equipment, training, and support they need to find undiagnosed people with TB. Number 20, all public health facilities follow a checklist of basic measures to ensure adequate TB infection control measures in a place. An audit of all public health facilities to assess TB infection control based upon World Health Organization guidelines, and a plan based upon the infrastructural, human resource, or behavioral challenges found in order to improve TB infection control. We're moving to stock outs now. James Bond.
Thank you, GS. The next group of issues is on stockouts and shortages of medicine. Stockouts and shortages of ARVs, TB medicine, contraceptives, and other medicines and health products cause disruption, confusion, cost, and can detrimentally affect long-term treatment adherence. Yet, stockout continues to be a challenge across the country. In this monitoring period, there were 416 reports of different medicines, contraceptives, and vaccines being out of stock, according to the facility staff. And 57% of those stockouts were unresolved at the time of monitoring. Patients report 975 different medicine, contraceptive, and vaccines being out of stock. This varied across districts, with the highest reports of medicine stockouts being in Nkanga, Modiri, Molema, Nkangala, and Dr. Kenneth Kaunda, and no reports in Utukela, Ugu, Zululand, and King Tetwayo. Of public health care use.
Let's use that.
4% of public healthcare users, or 999 people, were sent home empty-handed because of the stockout or shortage. And 14% of facilities reported sending people home without the medicine they needed due to the stockout or shortage. We now move to recorded stories.
ko Tshwerefelo clinic ke kgona go ya goseng ke ilo tlhola fao motshegare otlhe ka tlala so ga ke tshwere ke tlalano ke tlo tswa ka 4 ga ba chaisa bo myself after all ga ke etsa go tsena ba etsa go nthusa treatment ya bone ya shorta and ke ya ka gona yaanong ke tlhotse teng la bone ka di-4 gape ke ya ka di-4 yaanong mo gare ga beke mo gape tshwanetse ke nne ke ye ke go tlhoko ke go sheba gore a treatment eo e tlile or ya nna ka e fumana e feletse so ke ka tlhakatlhakana nako nngwe ke a painelwa bosigo le kgwao pilisi di fedile ka mo ke boleletse gore ne ke kgona go reka nako nngwe a tšheletenyana le teng ke ya chemist ke go reka gore net go kokobele la ka one ha dio mosase di ke high blood ke damage of lungs e be nna selo epilepsy le go ruruga ga maoto go a diragala nako nngwe and then nako nngwe a ba sa kry treatment e feletseng ke lala ke fupelwa bosigo ke fofulela ke sa robale ke phethoga yana dilo tse di tshwanang le tseo ntho nngwe ne ke shebile ya dilase yaanong ga re kena mo ga re kene mo jareteng so ga pula ena ga re itse gore re ye kae mme mongwe a ba salentse a botsa gore kante a re tlile mo strateng or re tlile mo tleliniking na ga ba re arabe ba shutha ba tswa mo go rona ba re bitsa di-55 mole mare ba stara ba nraela ba re treatment ya shorta e nngwe ga e setle ke sa itse yang yaanong
ngithi ngizothatha amagazi ngifike ekuseni ngo-5 alright vele clinic ivula u7 ke sifika nje ekuseni size sihambe ngabo4 ntambama ngaloyo 4 suke sihamba ngawo nakhona futhi abakuphenduli kahle kuthiwe nje ufika ngalesikhathi okubona kushuthi isona sikhathi suke sebesibona ukuthi okushuthi ufike ngaso kade ufikile ekuseni nokunye futhi amaphilisi sekuze inyanga yesibili le amaphilisi ngawatholi ngodate yamaphilisi kodwa idate isuke bona beyibhale bona ekhadini lokuthi ubuya nini for treatment amaphilisi ama-HIV mengabe ngifika ngithi ngizothatha amaphilisi ngifike kuthiwa iphaseli lami alikho nakhona futhi ngisuke sengihlalile kulayini ngalinda mase ngingena ngaphakathi kuthiwe amaphilisi awekho so angibuye ngaleyo date uma ngibuya futhi ngaleyo date kuthiwa amaphilisi futhi nakhona awekho inkinga bathi ayikho kubona inkinga iphambili into eyenzakalayo sesize sazakhela igroup kuya group of 3 abantu sesibolekana nabo ngamaphilisi because nabo engazi usibaba nenkinga ifanayo neyami so sengiyaphuma ngihamba ngocela mhlambe ngicele komunye lokuqala amaphilisi a5 days ngokulandelayo wesibili ngiphinda amaphilisi a5 days mase buya futhi amaphilisi kushuthi mina afana ukuthi awasaphelele ngoba sekufanele ngikhokhele nabe engithathe kubona futhi amaphilisi and futhi bakhuluma kabuhlungu kwaye ukuthi bakhuluma kahle mhlambe bachazisele nje nawe njengomuntu ukuthi mhlambe isizathu kube u1 no2 no3 bekuyiphasika 2023 April 2023 sasibuya ephasikeni ngine date yokulanda amaphilisi ngaya kwathiwa iphasela yami ayikho so ngihlalile during lapho uApril ngiphila ngako ukuboleka kanjalo ke kwazi kwa May ngawathola kwaphindeka futhi ngoJuly ngaze ngawathola manje ngoAugust so ngiyasaba ngazi mengiphindela ekupheleni kaAugust ukuthi mhlawumbe ngizobhekana nenkinga efanayo yini because kusho sekudlulisa inyanga bengicela mhlawumbe benze njani kunikezwe onompilo siwa at least siwa collect konompilo because iclinic engazi ukuthi ithatha ngenye indlela iyalekha lapha nje nalapha ya
Comment stories in the room.
Ngiqhamuka ePietermaritzburg ngisebenzisa isnathing clinic.
I'm from Pietermaritzburg and access snatting clinic for services.
Clinic ngisuke ngiyolanda i-treatment yami ngidla amaphilisi esifo sokuwa.
I collect epileptic treatment from the clinic.
Amaphilisi kade ngiwalanda nje iphasela kuqale last year ngabo September ukuthi ngingabe ngisalithola iphasela.
I used to get my treatment in the form of a parcel from the clinic. It was last year where the parcel stopped.
Kwadingeka ukuthi ke amaphasela njengoba ngingasalitholi ngingene ngaphakathi ngikhiphe ifile ukuze ngizokwazi ukuthi ngithole khona amaphilisi ami.
I then had to go back to the facility dispensing, which means I should retrieve my file before I treatment collection.
Amaphilisi ami ngiwathole inyanga ezimbili kahle ngaphakathi ephelele.
For 2 consecutive months, I was able to get my full treatment from the facility.
Emva kwalokho uma ngiyolanda treatment yami njalo sekuba khona amaphilisi angabi khona kwi-treatment yami.
After the 2 months, I started to receive incomplete treatment. Sometimes some medication would be missing from my administering.
Ngimbuza unesi ukuthi hawu yindaba manje njengoba sengilanda la amaphilisi esengishodela kade iphasela abengashodi. Athini athi hayi ucabanga ukuthi i-track ayifikile ukuzodeliver.
I asked the nurse, why is it that when I used to collect a treatment from the parcel, my treatment would be full all the time or complete all the time, but now I'm getting incomplete treatment. She would say that maybe it's the truck delivery having issues.
Hayi ngele eshoda amaphilisi ami ngaze decide ukuthi ke angivele ngiyeke ngingabe ngisayi ukwalanda ekliniki. Angisayidli treatment yami bese ngithi ngizoqala kahle next year mhlambe ke sengizowathola esephelele.
I have enjoyed collecting this incomplete treatment to a point where I just decided to stop going to the clinic to collect the treatment. I will go back in January to start again properly. Thank you.
Molweni. Igama lami ngingufezeka Ndongeni, ngiklinika eHoly Cross.
Greetings, my name is Fezeka Ndongeni and I use the Holy Cross Clinic.
Ngomay bekufanele ba ndiye ekliniki. Ndiyile ekliniki ndiyothatha i-treatment esakho kuhle apho bandireferela khona.
In May, it was my treatment collection date and I had gone to Sakhokuhle Clinic to collect treatment.
Ndifikile esakho kuhle. Xa ndifika esakho kuhle ndakhupha ikhadi. Umfana osebenza pha uye wathi i-treatment ayikafiki.
I arrived at the clinic and I produced my card and the attending personnel informed me that they still have not received treatment.
Ndimbuze kutheni ingakafiki because i-date yami namhlanje athi naye akazi.
I further inquired why don't they have medication, or why rather the medication was not delivered since today it was my treatment collection date.
Athi umfana akaze ucela ndihambe ndiye ekliniki eHoly Cross kuba ke kuwokhwa ndingalinto nam ndiye.
He said he doesn't know why, but I should rather go to Holy Cross Clinic instead of going home empty-handed.
Xa ndifika eHoly Cross ndifikele kunesi obephaya ngaphambili. Ndafika ndamxelela bana ndisuka esakho kuhle ndizolanda i-treatment. Athi mandilandele iline.
When I got to Holy Cross Clinic, I told the nurse that I come from Sakhokuhle Clinic and I'm here to collect treatment, and she told me to join the queue.
Ndihlalile elayinini ndayilandela iline. Lafika ixesha lami emveni kwa 2:30.
I indeed followed the queue and my turn, it was my turn to collect treatment, I think around 2:30.
Buya unesi ubuye nekhadi lami esithi ayikho ifile yami.
The nurse returned with my card to let me know that they could not, I don't have my file there.
abe sele sendibuza bana kutheni ndizothatha i-treatment apha ndibe ndingayithathi lapha ndiyithathe sakokuhle abana-treatment abazundinika.
She asked why was I there to collect treatment instead of going to Sakho Kuhle, and said that they don't have treatment and they will not administer any treatment to me.
Kulapho ke kwenyuka imimoya khona ndamxelela bana i-treatment yiyona nto ndizoyifumana. Ndicela uvele undibizele umanager xa ngaba usithi wena uzokwazi ukundinika.
It escalated very quickly to the point where I requested to speak to the facility manager if she's refusing to give me the treatment.
Waye wathi umanager akekho ndahamba ndaya kuba ndiyazi office kamanager ndafika ndanokha ndafika ekhona.
She told me that the facility manager was not there, but fortunately because I know the facility manager's office, I went there and I found the facility manager.
Ndifikile ku-facility manager ndamcacisela uba kwenzeka ntoni.
I informed her of what happened.
Wabe sele buza uba kutheni benganiki treatment azange abe nampendulo unesi.
She asked the nurse why they were denying to give me the treatment, and she did not respond.
Yes. Ndaye ndayifumana ki-treatment yam ndabe sendigoduka kwakhona ngomeyi bekufanele uba nditsale amagazi ngenxa ye-load shedding khange watsala amagazi xa ndisiya ekliniki bekuthiwa akho mbane.
I then took my treatment, left the facility. In May, I was due to take my viral load test, but because of load shedding, I could not, and I had to go home.
Enkosi.
Thank you.
Sabong, yabona comrade wase Holy Cross. That is the kind of spirit that we want. That is the kind of spirit that we want. When a nurse is saying to you, I'm not going to give you a treatment, we must ask the nurse, who is your boss? Then, if they don't tell us who is their boss, we must go to the office of the boss, report them to the bosses, so that we can be able to get a treatment. Thumbs up, comrade, and not give up. Continue to show others what advocacy means. And if it means you must assist them and lead them, you have my support. Amandla. That's all that we want. So we're going to recommendations. All public health facilities have medicines. All public health facilities must have medicines. All public health facilities must have medicines, vaccines, contraceptives, diagnostic tests, and dry stock. They need to provide quality health services. No one is turned away empty-handed due to stock out or shortage of medicines. Improve supply chain management across provinces, which adequately report stock availability. Training and employment of more pharmacist assistants in order to ensure improved stocks. Improve tender processes and transport services, particularly in rural areas, in order to improve delivery of medicines. We're going to patent laws now.
Thank you, GS. The next group of issues are around affordability of medicine. Today, new generation antiretrovirals and long-acting injectables, as well as new medicine to treat cryptococcal meningitis, hepatitis C, drug-resistant TB, and many cancers are unaffordable and out of reach for a large number of people. We can't rely on these cases of individual cases of litigation to ensure access to newer medicine. Instead, we need a more systematic use of legal safeguards known as TRIPS flexibilities available in international laws to improve access to medicine more broadly. While many other countries have used these pro-public health measures, South Africa has yet to amend its patent law to incorporate them. After 9 years of policy development, 2 different draft policies, and various rounds of public consultation, in 2018, Cabinet approved a policy that could guide much-needed law reform. However, while the finalization and adoption of a policy was an important milestone, The hard work of developing and passing legislative amendment is still outstanding.
Thank you, Comrade Daniel. James. Comrades, before I go to this one recommendation, we've got a problem, not only in South Africa, but across the world, where these companies that are manufacturing medicines are putting profit before the lives of the people. We must ask ourselves, why majority of people, more especially women who are suffering from cancer, are dying? We must ask ourselves, why majority of the people with cystic fibrosis are dying without getting treatment? You know why? It is because treatment for cancer, cystic fibrosis, TB, and many others is too expensive. And for a poor person to access it, it's a dream that will never come true. Like, for instance, if you are suffering from a breast cancer, in order for you to get an effective medicine, you must have 500,000 rands per year. If you are suffering from cystic fibrosis, you must have 5 million rands per year to buy medicines. The people living with HIV and other progressive forces managed to force pharmaceutical companies to lower the prices of medicines. But also in South Africa, we've got a problem where our government is supposed to enact a policy around patent laws in order for our government to be able to apply TRIPS flexibilities like your compulsory licensing in order for generic medicines to be accessible in order for our people to be saved. But our Department of Trade and Industry is delaying the process. And I think it is important for us, the PLHIV sector and other progressive forces, to continue or to double our efforts of putting more pressure to the Department of Trade and Industry, because we want this to be passed the same way the NHI bill was passed, in order for us as poor people to be able to access effective medicines. We must ask ourselves, how did it happen that TB is older than all of us in this room, but even to this day, there are no affordable and effective TB drugs? Yet COVID is less than 5 years. It was like a blink of an eye, there were vaccines for COVID. You know why? It is because tuberculosis is affecting most of the times poor people who stays in impoverished communities. Therefore, they don't care, even if we die. Then you look on the other side, COVID didn't ask about class, gender, race, or whatever. It killed everyone. That's why the capitalists, it was quick and easy for them to come up with vaccines to prevent us from contracting COVID. And if they were able to come up with vaccines, it must be easy for them to make sure that medicines are available and are affordable. And if we think that there is God or Jesus Christ who is going to come from heaven and put pressure to these companies to reduce the prices of medicines, we are late. We need to use our anger. We need to double our efforts, occupy their offices, and tell them to hell with your nonsense of putting profit before the lives of the people. If health is a fundamental human right, if we're talking about universal health coverage, we must talk about access to effective and affordable treatment as well. And it is up to us as poor people from South Africa, Brazil, China, India, and everywhere in the world to unite and fight against the World Trade Organization as well as the TRIPS. Because if we do not do that, we will all die without getting any help. So we need to use 2024 as the year of the people's power, to put pressure to pharmaceutical companies, Department of Trade and Industry, whilst we continue to engage on the challenges that we are experiencing in our clinic. So on this one, we are saying urgent development and passing of legislation to reform our patent laws to ensure medicines are made more affordable. We're moving to, yes.
Thank you, GS. As the GS was saying, we're moving to the next issue that covers corruption and negligence. The crisis in many of our public facilities does not come from nowhere. Over the last 15 years, corruption has flourished in South Africa and the public service has been systematically hollowed out. This has directly impacted the healthcare systems and the HIV and TB response. Corruption and theft of public funds has been rampant even within the Department of Health, taking away much needed resources for hiring doctors and nurses, paying for ambulances, or fixing our clinics. Negligence is also pervasive. Medical negligence is a worrying trend that we witness in clinics and hospitals across the country. Much of this negligence is avoidable, yet it can only lead to disability, recurrent or new medical issues, extended hospital stays, or readmission, loss of income, at times, avoidable death. Many incidents have translated to malpractice claims which continue to cost the health department billions of rands, money that could be used to improve the quality of healthcare services. We are now going to have the recommendations.
Thank you, Mary. We're talking about corruption, theft, and negligence. And we know when we're talking about corruption is broad, starting from hiring staff members using nepotism and not appoint people according to qualifications and merits. But because Mary is a comrade, Mary is a child of a comrade who was in Lusaka or in Brazil. We are not about that here. That is one of the problems that we have. But also, we know in our communities, there are those nurses who steal medicines from our clinics and keep them in their houses. And then when we are sick, it's easy for us to go to their homes to get medicines. That is theft. No nurse is supposed to have state-owned medicines in their houses, because these medicines are meant for us for free. You must know, immediately when a nurse or someone working in a clinic is having medicines in their house, you must know that those medicines were meant for someone. By this person having these medicines in their house, it means someone is not going to get their treatment. Including people who are stealing ARVs in our clinics. We know, comrades from Free State, 2020, between the 4th of January 2020 to 20th of January, there were 5 cases of ARV thefts in Free State. And in some of these cases, there were officials from the Department of Health who were arrested by the hawks stealing ARVs from our clinics. That is part of corruption. And if we, as the community, we watch these things happening in front of us and we're not saying anything, we must know that we are depriving millions and millions of people. That's why it is important for us. When we know about these people stealing medicines from clinics and sell them in our communities, we've got a right to go to the police station and open a case, because all state-owned medicines are returned outside, not for sale. How do they sell these medicines to us? We know some of the general practitioners who are conniving with some individuals within the department. They steal medicines from the public and give them to these private doctors. Then when you go to these private doctors, you pay for medicines that are meant for free. And we are not saying anything about that. If we want to fix the broken public healthcare system, anything that seeks to deprive us our rights It is our duty to stand up and fight for that, as well as negligence. Our state, the government of South Africa, more especially the Department of Health, is spending billions and billions of rands, not to build clinics, to buy medicines and medical equipment, to hire more nurses. This majority of this money goes to these medical legal claims. You go to a clinic, you are wrongly diagnosed, you take the matter to court, and then the court rules in your favor, and then the state is being sued, and then they have to pay money. Billions and billions of rands in all provinces are not going to services. They are going to pay for these cases of negligence. How do we make sure that we work with our government and push our government to hire more nurses in order for us to be able, as the country, to reduce these cases of negligence, in order for our country to have more money to provide services to us? It therefore means we've got a lot of work to do as community and as all these different organizations and progressive forces. What do we want? The National Department of Health to establish an anti-corruption unit, to work with a special investigation unit to fight against and root out all corruption within the healthcare system. An end to corruption more broadly, that it steals from the poor, denying quality service delivery in health, education, housing, and all other forms of service delivery. When we fight for our rights, we must not only focus on issues of health, water, housing. There is a lot of corruption in South Africa. It is upon us to name and shame these officials who are corrupt, so that we can be able to see services being delivered to our doorsteps. But if we keep on smiling with these officials who are stealing from the poor, we are not doing any good for the people. We are just like those people who are stealing from the poor. The removal and prosecution of those who are responsible for corruption and gross negligence. People like Brian Hlongwa, Qedani Mahlangu met at people in Gauteng. She is still walking the streets of Gauteng as a free person. Brian Hlongwa, when he was the MEC of Health, he looted billions and billions of rands in Gauteng, and he is still walking the streets of Gauteng as a free man. What are we doing about that? We went to the Gauteng legislature, we met with the premier, we met with the speaker, but these people are still free. That's why we need to put more pressure to politicians in order for them to remove these people who are corrupt. That's why Comrade Mavuso Msimang, who was the Treasurer General of the ANC Veterans League, yesterday he resigned, because he believes that the governing party is not honest by its mission of rooting out corruption. We need millions and millions of people who are like Comrade Mavuso Msimang, who are able to fight corruption even when it is happening inside their own organizations. That is the kind of citizens that we want in this country. Not citizens who are going to protect politicians who are looting and stealing from the poor. And you keep on coming here and say you represent the poor, yet you are rubbing shoulders with those who are corrupt and trying to protect them. You are equal to those who are stealing from the people. The hiring of sufficient numbers of healthcare workers so that negligence at clinic and hospital levels as a result of staff shortages is ended and malpractice medical claims are reduced. We're going to the gender-based violence. It's Mary.
Thank you, GS. Nearly 30 years after the onset of democracy, women and the LGBTQIA+ community members in South Africa continue to face disturbing levels of oppression, violence, and injustices, be it in the streets, in the workplace, traveling in taxis, or in our homes. The South African Constitution guarantees equality and freedom for all, regardless of sex, gender, or sexual orientation. However, these guarantees remain only on paper. Obstetric violence is another form of gender-based violence perpetrated against people capable of pregnancy. Ambulances can take hours to come or never arrive to take people with pregnancy complications to hospital. There have been reports of people giving birth on the side of the road. When people arrive at the hospital, They can face other forms of abuse or humiliation. People can be left for hours unattended or have to give birth on the floors of hospitals when no beds have been available. Invasive medical procedures take place without consent that can leave people in pain for long after they've given birth. There have even been reports of people being unknowingly sterilized. Obstetric violence is a violence of people's constitutionally mandated reproductive health rights. We are going to have a community story from a person that has joined us physically today.
Bengifika eLithabo ngahlangana neproblem yokuthi bafuna ukungithatha itest le yasemunweni, but manje bafuna ngize nepartner yami, and ngabatshela ukuthi angisazi istatus separtner yami, and ngiyayisaba isikhathini esiningi azange bafuna ukunginceda, and next time bengibuyela azange bafuna ukunginceda because angizanga nepartner, so nga-end up angatholanga usizo until now. Okay, so lesikhathi bangithatha le test yasemunweni since ngikuma ARVs from March until manje, ngaphambi kokuthi bengidefaultile angakaphuza treatment namanje. Ngizizwa ngingaphathekanga kahle.
Sanibonani.
Good day.
Igama lami nguYonela wakamabasa. Ngiphuma eOrange Farm.
My name is Yonela Mabasa from Orange Farm.
Mina ikliniki ukuthi ngeke ngaya kuyo ngafacana nenkinga. Ikliniki Stratford Clinic Extension 2.
I have faced a challenge from Stanford Clinic in Extension 2.
Ngaya lapho bekuyi 12 February this year bengiyothola umntwana. Ngafika lapho eclinic ngabo 10 ebusuku.
I went there in February to give birth. I arrived at night at 12 midnight.
Abo nesibakhona zanye banginaka mangifika kuphela, then after lapho bangibeka embedeni bona since balele masufeni.
The nurses, they never attended to me. They just said, put me aside, and they were sleeping.
Tema baloko babhizi banyizwa ngiloko ngikhala ngibatshela ukuthi amapeni angiphethe bangitshela ukuthi bona ngingabarasela angithunywanga yibo ukuthi ngiyenze umntwana.
When I was screaming from the pain that I was experiencing, they said I must not make noise for them because they are not the one who sent me to make a baby.
Tema senguzwa amanzi aphuma. Yilapho engithuke khona cause vele first time yami ngithola umntwana, so ngabamemeza.
When I started, when my water broke, I began to have more pains, and when I called out to them, they said I must stop making noise for them.
Theater room.
They took me to the theater.
Masifika lapho bangitshela ukuthi bazongichecka, then bangichecka, after that bathumntana usasekude.
Where they checked me and told me that I was not sufficiently dilated.
Bathi kimi bayabuya basazothi kimi ngihambe ngiyochama etoilet ngihlale ngingaphushi ngingayenzi nix until bona baze bangitshela.
They informed me that they will be returning back, and at that time when they return they'll tell me to give them a urine sample, but I must remain on the bed.
Babuya bangitshela ukuthi ngiyochama, then ngahamba endleleni ye toilet ngawuza ukuthi no angisakhoni ngajika ngabuyela emuva.
They came back and told me to go to the toilet for the urine sample. On my way there, I felt that I could not proceed anymore. I felt the baby coming.
Mangifika lapho ngiye ngazilahlela phezu kombhede. Yilapho ngibakwatise khona kakhulu. Baloko bangitsipha amathanga bangitshela ukuthi ngivule bafuna ukubona lento engikhalisayo.
I returned to the bed where I just jumped on the bed, and that is what aggravated them and made them angry. And they started to pinch my thighs, continuously saying that they are not the ones who sent me to get pregnant.
Ngibatshela ngithi mina ngiyamuzwa umntana ukuthi uyeza mara nani ngitshela ukuthi ngingaphushi. But hayi ungaphusha ngithi ithabo doctor la unless ukuthi ufuna ukuzizalisa.
I kept on telling them that I can feel the baby is on the way, and they kept on pinching my thighs, saying that I must not push because they are the professionals, or I should tell them if I want to give birth by myself.
Yilapho nami ngeke ngibaphendule khona ngabatshela ukuthi ngoba wami vele umntana angifuni kwenzakale nix ngizoloko nyenza the way ngibona ngakhona.
I ended up also responding to them to say, since this is my baby, then I will do as I see fit.
Ngaphusha then babona umntana ikhanda selivelile after lapho kuyilapho khane khona batatazela bazakini.
I proceeded to push, and they saw the baby's head coming, and then that is when they started to pay attention to see that it was the baby was really on the way.
Umuntu wakhona futhi makafika akasayenza into right ngimuvele wangikhatha ngesikero wangikhatha until la ku anal area.
So when they arrived, because now they were in a hurry, what they did to me was they had cut me up until my anal area.
After lapho thema ngicela ukuthola umntana bengingakhona ukuma straight for 2 weeks.
After childbirth, I could not stand up straight for 2 weeks.
Yabo.
Thank you.
Sanibona.
Good day.
Igama lami nguDimakato from Efosloras. I experienced last year nge 17 October bengiyoteta nami.
My name is Dimakato from Fosloras. Last year in 17 October, I went to give birth at Telemohorane Hospital.
Yes. So I gave birth naturally, and the baby was okay. So Dr. Lo ongkhathile ngesikhathi ngimzwile mekangikhatha. So ungikhatha kwakho ungivule umgodi la esedini la next to my anus, you know.
So the doctor that was assisting with my birth had made an incision from my vaginal area up to my anal area. There was something like a hole there.
So when I discharged, I think bangithungena la endulo because angikhona ukuhlala ngihlala ngabhlungu. Ayusiswa mathayi vele the way vele bathunga ngakhona mengabe vele bakhathe ngesikero.
When I got home, I informed my sister that I could not sit still. I'm suspecting that they had stitched up my anus. And she had assured me that it should be like that because that is how they stitch you.
I getting tobe for days, then now this thing continue and ipain akhona ipheli. So I was like, I was thinking spilling born and papa nkusukuyenzakalani. Ngitheme ngibheka. Yo, it was a big wound.
I treated the wound for several days up until I decided to take a mirror to have a view of what was going on. I was dismayed. I was surprised because there was a big hole.
Then my sister, when she comes back from work, ngambonisa bese ahamba ayobonisa imanager yakhe, then abiza usiSphindile from TAC. Then usiSphindile athi ngibuyele esibhedlela. Mingibuyele esibhedlela, I think ngihambe endlini ngabo 3:00 ukuya eThelle.
When my sister came back from work, I showed her, and she also requested assistance from her manager, who then further called usiSphindile from TAC, who advised me to go back to Telemohorane. I went there, it was around 3 p.m.
Then when I got there, ngihleli laphayana imini yonke ubusuku bonke until ekuseni uDr. Mekangichecka athi okay ngiyabona ukuthi kuyenzakalani, then hambi epharmacy bazokunikeza iPrufen neDettol.
I stayed there from 3 p.m. Even during the night up until the doctor attended to me, and they then sent me to the pharmacy where they administered ibuprofen and Dettol disinfectant.
And then when I get home, ngibona bakujwayela kabi basile, so uzabuyela futhi noma yinini. Then after 3 days ngabuyela esibhedlela, then bangisa kugayini. Mengifika ngale bathi bangikhipha ama-stitch cause it's been 2 weeks now ama-stitch asasekhona. Ngabatshela ukuthi nokuhlala ngikhoni, nokuncelisa umntwana ngikhoni. Like mengidla futhi nakhona ngikhoni ngiyaguqa, ngikhona ukuhlala phansi, ngikhona ukuyenza next. Mengincelisa nyalala noma ngimile.
My sister was not satisfied, and fortunately, I went back again to the hospital, and they now referred me to a gynecologist who advised to remove the stitches because they had not been removed for 2 weeks. I was not able to sit properly to breastfeed my child. If I wanted to breastfeed my child, I had to lay on my side.
Yeah, so that day, before I go to gyne, besingale so ngale udoctor bekangekho almost ubusuku bonke uze ngabu 3:00. Then before azoza futhi ngibhalela imene bengifuna imene nje ukuthi ngimbuze ukuthi kahle kahle hlelela ubusuku bonke akupha ama doctor because sina abanye sifuna ukuhamba siyancelisa. So ukuthi manager ayikho, so ngibona I plug ibhalwe lapha chef manager wadwati in ngambhalela I WhatsApp sort of I paragraph. Since from that day azange ayiview kodwa iyenza ama TK2.
At the gyne visit, we had stayed there. We sat there from 3 p.m. and there was no one who assisted us. I requested to speak to the facility manager. I was not assisted, but I was able to spot the details of the facility manager, and I sent a WhatsApp text. The WhatsApp text was viewed, but there was no response from the facility manager to this day.
Yeah, so they removed ama stitch na so iyahlangana I wound yaba kahle, but namanje ngisasaba like ukulala nomuntu wami because ngisafeel ama pain lapha nalapha.
They were able to remove my stitches, and the wound then began to heal properly. But now the issue is I am scared to become intimate with my partner because when we do, I experience a lot of pain. Thank you.
Sanibonani.
Greetings.
Igama lami ngubongekile Shabangu. Ngiphuma Orange Farm. Ngisebenzisa i-Straightforward Clinic Extension 2.
My name is Bongegile Shabangu from Orange Farm. I access services from Stratford Clinic.
So last year being pregnant, December ngaphathwa ama labor pain, it was the 23. Ngaya e-Stratford Clinic ngafika ngo-11 ebusuku. Ufike wami ngo-11 ebusuku bangicheke kahle then bangitshela ukuthi ngihambe ngewodini.
December, I was in labor on the 23rd. I proceeded to go to Stanford Clinic where I told them that I was in labor pain. I was experiencing labor pains, and they referred me to the labor ward.
So since ngo-11 loyo bangishiya kanjalo until 2:00 ekuseni bangeza uzongichecka bangeza uzongibheka ukuthi kwenzakalani ngami. Mangifile ngiye-toilet ngiyochama ngiyababona abantu bahlele esofeni babukela iTV.
Since from 11 p.m. to 2 a.m., I was not attended to. No one attended to me, but I could hear that they were sitting in the nursing station and they were watching television.
So after isikhathinyana unesi aze kimi. Makaza kimi ufika unginikeza ikomishi. Ungitshela ukuthi ngihambe ufuna umchamo.
After some time, the nurse then finally came to the ward, and they had instructed me to go and urinate.
Ngithi ngiyam-explainela ukuthi angeke ngisakhona ukufika e-toilet because ngiyazwa ukuthi umntana ufuna ukuphuma. Umuntu angirasela athi ngiyenze njani manje mina? Ngithathe lento ngihambe ngiyokhipha umchamo because umchamo ufuna kayi owakho.
I explained to her that I could not move from the bed because I can feel the baby coming between my legs, and she rudely asked me if she should be the one to go and produce the urinary sample on my behalf.
So ngahamba ngaye e-toilet. Ufika kwami e-toilet angizange ngisforce ukuthi ngihlale phansi e-toilet because if ngihlalile umntana bekazowela lapha e-toilet because bese ngifila ukuthi umntana uyaphuma vele. Ngavele ngazichamela mina ngathatha wona lama drops lawo ngahambisela wona.
When I got to the restroom, I was not able to sit on the toilet seat, but I had to urinate while standing. But unfortunately, it could not go into the container, so I had to take a few droplets that were rolling down my legs.
ngahamba ngamnikeza lo mchamo loyo umuntu wangitsho ukuthi ngigibele embhedeni ngihlale.
I then went back to give the urinary sample, and she told me to get back onto the bed.
Mangihlele embhedeni ngiyawuzwa ukuthi umntwana uyaphuma ngiyamtshela ngithi umntwana uyaphuma umuntu wavele wangibheka ngathi ngiyahlanya wangishiya kanjalo.
I felt the baby coming and informed her of this, and when I did, just gave me a look and never responded.
So bengana choice ngasala ngaziphushela mina ngazididisa umntwana.
I had no choice but to push, and I gave birth unassisted on my own.
Ngazibambela umntwana ami bona baziki mase bazokuthi umntwana uyakhala.
When I finally had the baby on my hands, that's when they came rushing because they could hear the baby crying.
Bafike bayangichika bayenza ngathi fault yami but mina ngichilo ukuthi umntwana uyaphuma umuntu wangibheka ngathi ngiyahlanya.
They scolded at me, making it seem as if it's my fault, whereas I had said this to her that the baby is coming, but she looked at me as if I'm mad or unstable.
Bangibuza ukuthi warifu umntwana bekachayise ensimbini leyo mbhede because umbhede bengilele kuyilo umbhede lo oneinsimbi la phambili warifu umntwana ufike wachayisa lapho mina bekuzoba ifault yami kanjani because ngichilo ukuthi umntwana uyaphuma.
They asked me what if the baby had sustained injuries on her head since the bed I was on had some still frame.
So ayiphelelanga lapho umuntu weza kimi uza nenaliti kuphela akezini injection uzongistitcha akangijovanga kayenzanga nithi unje ukuthi ngiqinisele uzoqinisela kanjani naliti.
After that, the nurse came to stitch me, but surprisingly, she did not administer the local anesthetic, but she just told me to just bear with the pain.
So makalebela ngistitcha lapho angikhona ukuhlala still because inaliti yangilimaza ngilibele nyanyakazi ungitshela ukuthi uzongibizela omunye ubaba onesandla esikhulu kuzoba uye uzongistitcha lapho if angifuni ukustitcha ngimtshela uzangiyekela kanjalo.
I was not able to sit still while she was stitching me from the excruciating pain that I was experiencing. And she threatened that she will call another gentleman who has very big hands, and they will be the one to stitch me.
So ever since that day, senginenkinga ye-spinal cord angisakhona ukuhamba ama-long distance because angazi ukuthi ukuphusha kwami umntana ngiphushe rough or ngenze njani angikhona ukuwasha ngimile sengihlala phansi mangiwasha ngathi angazi ngumuntu ogugile.
Since then, I have been experiencing back pain, and I'm not sure whether it's from the fact that I had delivered the baby on my own. I'm not able to stand for longer periods, either laundry or washing, doing errands at home.
So nje empilweni yami mina angicabangi nje ukuthi ngisazoba nomunye umntana angiyiboni le because mangicala ngicabanga ngizokhupha kanjani what if ngisabuyela ku the very same experience engiyithole khona lapho.
Very traumatized to the point that I don't think I will have a child anytime, because I ask myself if I am going to experience the same or worse.
Mina angifuni ukukhuluma manga siyahlukumezeka emakliniki especially masiyoteta siyahlukumezeka. Ngiyabonga.
I don't want to lie. The nurses in the clinics really abuse. They really do abuse us. Thank you.
Yeah. You know, comrades, if we want to fix our clinics, we must use our anger and our experiences to address these issues at facility level. If we do not do that, all of us are going to die in the hands of the nurses, not all of them, of the few nurses who've got a bad attitude towards the users of healthcare services and all other frustrations that we have explained here. That's why I felt a bit worried when the deputy minister was saying these reports are all about the negatives, not about the positive, which I disagree with him. But the deputy minister and all other people who are online, the deputy minister and many other comrades are freedom fighters like myself. When we committed ourselves to the struggle, we said we represent our people. I cannot accept it when the deputy minister is going to come here and defend the system on the expense of the people. I cannot. That's why I think it's important for us to convene this meeting so that we can be clear as to say, which side are we on? Are we on the side of the people or on the side of the system? Because I cannot sit here and listen to all these stories, and then when I come, I brush things off. We are a wounded nation. We are angry here in this room. And I cannot come here and tell you how you must feel about the frustrations that you went through. Or try to say to you, your problem is not serious than this problem. All these problems are serious problems, and they need urgent attention. What do we want? Women and LGBTQIA plus community members are treated with equality, dignity, and respect as outlined in the Constitution. As men, cisgender, and heterosexual people, we will constantly interrogate our own actions and privileges to understand how we contribute to the oppression of women and LGBTQIA community people. We will not remain silent when we see sexism, homophobia, and transphobia. We refuse to hide behind our cultures and traditions. Our clinics and hospitals must treat people capable of pregnancy with respect and dignity. Sexual and reproductive health services provision is safe, friendly, and confidential. No obstetric violence takes place, including abuse, physical, sexual, or verbal, bullying, coercive practice, humiliation, and or assault towards laboring and birthing people. This brings us to the last item of our meeting. But also, colleagues, we heard the Deputy Minister responding, we heard people from PEPFAR responding, and we thought that we were going to make them respond towards the end of this session so that these comrades from different provinces can be able to hand over some testimonials to these health officials from different provinces. However, we are not going to be able to do that, but we are going to send all this information to Dr. Sandile Buthelezi, Director General of Health, and Dr. Muwerane, the DDG at Health, and Minister of Health, Joe Pasha, and Deputy Minister, in order for them to be able to share these testimonials from different provinces to the relevant MECs and the DGs. Now we are left with 9 minutes before we close. And I'm gonna call the provincial colleagues from TAC to come. 1 minute, you tell us what you want to tell us. 1 minute, 1 minute, 1 minute. So I will start, I will use my own discretion, not because I'm from Eastern Cape. I will start by KwaZulu-Natal and call the chairperson of the District AIDS Council of Ilembe, Utatu Shandu. 1 minute, Vadla Vadla. You can come forward, Bab. Comrade Shandu, the Deputy Mayor of Ilembe.
Amanda. Amanda. Viva PLHIV sector, viva. Viva. Thank you very much, GS. Greetings to programs directors, our distinguished guest, our PLHIV sectors, our partners, community. Mine is it's too little, as the GS said. I must say we acknowledge the working relationship that we have established with the Department of Health through CLM, because we have seen, we know that before we were like an enemy to the Department of Health. But today, I think even the Department of Health is now realizing that the TAC is not an enemy actually, but the TAC assisted a lot to the Department of Health. In order to reach the second 95, the retention to care in the NSP, we need to work together with the Department of Health. Because if we talk about the laws to follow, it's a high number of laws to follow. But if the department come and work with us, that will be reduced. The other thing that also need to be addressed is the issue of the counseling. The counseling process is very poor in our facilities. We may propose that if the counseling process might be outsourced to EPLHIV sector, maybe the system might be better. Maybe this high number of laws to follow might be reduced. So I'm referring to the one case that we have picked up from KwaZulu-Natal during the CLM meetings. So what happened, one gentleman, Mr. Ronald, when we arrived in his house, actually he was come from Joburg without referral letter, and he was about to finish his treatment. And then he went to one of the clinic, and the general workers from the clinic, they said, no, you can't get the treatment. You need the referral letter. You need to go back to Joburg and get the referral letter so that you can access to treatment. And then what we did, we went to Sundumbili CHC and spoke to Umetron Tuli. And Umetron said, no. What is the number of Ronald? We gave to her. Same time, she phoned him and said, Ronald, come to the clinic. And she asked to him, who said you can't access the treatment? Same time, she initiated him to e-treatment. As I'm speaking, he's on treatment, and then she said the referral letter will be followed. So that's what we did. So if we work together with the Department of Health, working like that, so the retention to care will be successful. The second 95 in 2030 will be reached. So thank you.
Sabonga Tatu Shandu. Yabona ke comrades. I could not stop Tatu Shandu because of age, umdala. But two other comrades who are coming, please, 1 minute. 1 minute, comrades. Tatu Shandu is old. He's old, Tatu Shandu. So I had to respect that. So now I am going to call Free State. After Free State, it will be Western Cape. Siqala nge-Free State. Free State. UJodi ukhona lapha? Nangu ekoneni, ukhona uJodi, sibana mara. Sizawuqala nge-Free State, and then after Free State, it will be Western Cape. Mary, tell uJodi 1 minute.
The GS said 1 minute. Matla. Thank you very much, yes. 1 minute. Partners, colleagues, I don't have much to say, but I had a lot to say. But in 1 minute, I would say, Free State is in crisis. And please, the DOH, we are not enemies. We are here and we are there to assist. Please open your doors so that we can all win the battle against AIDS and HIV. Let us fight the discrimination. Amandla!
Comrade Jody is very disciplined, comrade. Over to you, Western Cape. The Republic of Western Cape. I do not know whether I'm West Pogas or Kanyangban, but we're calling someone from the Republic of Western Cape. Or Over to you, Kaiser Chiefs.
Amandla. Viva TAC, viva. Viva Napwa, viva. From the Western Cape, I will speak, but I didn't know. As the Western Cape, yes, we did have the working relationship with the Department of Health, but we still have a lot to do with them. So by hearing the stories, not only the stories that are here as well, there are stories that affect Western Cape as well. So we are saying, if we can try to have the working relationship, because as the Western Cape, we are not doing well on the second 95. We are on 56. It means we have a lot of work, and we've heard the stories why people, they don't go back to the facilities. So if you can have the working relationship, not looking like we are enemies, we can build the working relationship and go forward. Thank you.
How? Kaiser Chiefs, my God. I'm disappointed because that was too quick. So it will be Eastern Cape, and then after Eastern Cape, it will be the province of Limpopo. Kon Usloyi. Usloyi is the provincial manager of Eastern Cape. Myself and herself, we were shot at Frontier Hospital in 2005, fighting for treatment.
Mandla! Mandla! Thank you very much, good comrades, for giving Eastern Cape this opportunity. By saying that of report we have 83 stories in Eastern Cape, and then thank you with Department of Health for those districts ezingenzi district beimizi yazo. For an example, I've mentioned the Buffalo City Metro, which is mentioned about Dr. Ngotla. They invite us on their quarterly review, but there are those districts, the attitude only to the nurses. Also, there are district managers as the attitudes within our province. So if we are going to have one-on-one with the facility manager or the nurses that have the attitude in our facilities, let's have a meeting also with the district managers and in our district that have the attitudes. Secondly, the issue of NHI, Office of Health Standard, we will visit the facilities so that the facilities can be accredited. In Eastern Cape, we've said in the quarterly reviews of the Department of Health, of BCM district, away with borrowing Kakuzao Anele, Office of Health Standards, uboleka resources from clinic to when you clinic. Just ubama babone and accreditwe facility. Uhambago Anele, we are back to square one. So we are saying that as treatment action campaign, we are going to monitor that. Lastly, we have a district in the Eastern Cape, Esoloko kuko break-ins ezikoyo within the district, Nelson Mandela districts. We have a district whereby some of the district and local municipality get their treatment in Nelson Mandela Metro. If you are not getting joy in Nelson Mandela Metro, if we are getting attitude in Nelson Mandela Metro, it will be a problem for us in Eastern Cape to work with the district managers of Nelson Mandela Metro, whereas we are working closely with other districts. Lastly, the issue of mobile clinics. The mobile clinics in the Eastern Cape, siyacela bandla ukuthi the mobile clinics that say Eastern Cape, because we have rural and urban, mazize ne-ARVs to the community members. In mobile clinics, mazingazinje zodwa, mazize kunye ne-ARVs. Mandla!
Thank you, comrades. Sloyi, Eastern Cape. We're going to the province of Limpopo. After Limpopo, it will be Gauteng. 1 minute, Makabane. Bona kunganikhathi manje usithi lastly vele ukhulume when knowing that you've got 1 minute. Ungafani noSloyi.
Mandla Matimba Yaina. Greetings to the leaders, the partners in the house and online. My name is Raranzo from Limpopo. As Limpopo province, there's no data in the report because we have some challenges in accessing the facilities. But however, we have challenges, we have stories from people in the ground that are so touching. So as the province, we are so much ready to work at the ground just to see that our people in the ground get access to quality healthcare services. As much as we have the good working relationship with the MEC in the province, we are very much aware that we still have challenges in accessing some of the information in the local facilities because of the facility managers. So, comrades online from Limpopo, just make sure that we have access in the local facilities because our people are not accessing the services at the provincial level, but they're accessing the services at the local level. So, lastly, we are so much ready as Limpopo just to make 2024 the year of people's power. Mandla!
Mandla! Mandla! We've got a cooperative agreement with Ilimbombo, and myself and the MEC were good comrades. And I thought that by now we will be having access to facilities. Comrade Ranzo, if you are experiencing any challenges, let me know so that myself and the MEC, we can sort out anyone who's giving you problems. Comrade, Chairperson of Gauteng.
Mandla! Mandla! Long live TAC, long live! Long live Ritshidze, long live! Forward with the struggle for social justice, forward! Mandla! All power! All power! Siyabulele, 1 minute ingxaki comrades, man. Oh, okay, no, comrades, thank you very much for this opportunity as well. We are going to take this data and ensure that we use it to address all the issues that have been raised in this meeting and all other meetings that we've had last week. So we will use it as an algorithm to address all these issues with precision, Comrade GS. Comrade GS, I want to address you now. Before Christmas, leadership, we have a meeting with the MEC. We have scheduled a meeting to address all these issues, and I can tell you now that this particular report is going to guide us and will give you a report leadership. I want to give another feedback based on issue of diesel. We've agreed on this matter. Between August and November, comrades, we had 26 clinics that were complaining about shortage of diesel here in the province of Gauteng. And now I can report to you with pleasure that we have now 22 facilities that have diesel, and used to have a problem of generators, and all those generators have been serviced. So now when there's a load shedding, services are no longer being suspended. So siyaqhubeka eGauteng. On the matter of Stanza Bupape 1 and 2, with the pleasure and also the privilege that I'm given by this organization and an honor to lead this province, we have addressed these issues, and now I can tell you that our structures in this district are hard at work addressing these issues. By Tuesday, you must receive a report, leadership. Then I want to also take this meeting with confidence that as Gauteng, we are monitoring the Welcome Back and Save with a Smile strategies. And we want to ensure that at least by next day, there must be a fundamental strides with regard to that. And then I want to also emphasize the point that as much as we have these plethora of dead woods, the ones that are causing us problems, the ones that are giving our people stresses and sleepless nights, we want to say those ones are our targets. But at the same time, I want to tell you that there are very good nurses and non-clinical staff, and we want to give credit to those and to continue to go to do the good work and provide healthcare services. And then, lastly, now we'll get Comrade GS, which is very important. Comrades, here in Gauteng, we have a problem which is called Gamora. It's there on social media. We have unscrupulous and rascals that are misleading our people, claiming that they have a cure for HIV. When you take it, you'll take it for 21 days and the HIV will be cured. So I want to say to you, let us all unite and expose those criminals and ensure that they don't find space to breathe, especially in this province, and ensure that those who can be identified must go to jail because they are taking chances and they want to further kill people. So we're saying nonsense. Actually, we don't take, we're not kind to that particular nonsense, and all of them will ensure that at least we expose their faces. With that, thank you very much. Manta!
Chairperson, I had to allow you to take another 30 seconds because you were giving updates. I will call Comrade Ludik from Northwest, and then after Comrade Ludik is Abangosel from Mpumalanga. Ludik, don't be like Umonwa Basin. Be disciplined and show him what Northwest is disciplined.
I hold a TAC, I hold a. I hold a TAC, I hold a. Thank you, GS. Let me first start by commending the Department of Health in Northwest for allowing us access. But despite that, we can't continue to see notable patients lost up from care because of staff attitude. That one, as TAC, we are really saying, GS, we are ready to fight until these challenges are solved. One other thing GS has taken in the province that we are busy with, that we engage the MEC of Health with, is the issue of the clinic committees that were raised by the Deputy Minister. To say that as TAC in the province, we are waiting, we are ready to second names of comrades who will sit on behalf of the TAC in those accountability structures. Lastly, one of the things that I want to raise with you, GS, is to say we also commend Bujanala District Department of Health for engaging with us when we are addressing the issue of comrades and communities who are around the mining areas in informal settlements. To say that those communities over years, they've been struggling with mobile clinics. And I do believe that, GS, before the 15th of this month, we will be getting a report of saying that the district health in Bujanala is resolving the matter. Asbonge.
Thank you, Chairperson. Where is Comrade Sihle, comrades? Oh, how's the Comrade Sihle? I'm not going to say that thing.
Viva TAC, viva. From Mpumalanga province, I just want to tell the Department of Health that we have been presenting reports, sharing data, but we have not received commitment from them. So from now moving forward, we need commitment with time frames. Thank you.
Thank you, Comrade Sihle. So, as we are closing now, Lutik, Sihle, and all other comrades, I would like to know when are you having meetings with health MECs, because I want to be part of those meetings, so that if maybe some of us are scared to ask hard questions, I'm not scared, I'm only scared of God. So on that note, comrades, let me take this opportunity to thank you for your patience, and also I want to acknowledge that in our midst, we've got an official from the Global Fund who has been patiently listening to all the stories. We appreciate your presence. We appreciate the presence of PEPFAR. We appreciate the presence of UNAIDS. We appreciate the presence of USAID, CDC. We appreciate the presence of Department of Health, National MECs, and everyone who has joined online. We hope that these reports and testimonies that are given by people is what is going to make us to pull up our socks and work with communities so that we can improve the lives of the people. We do not want to fight with anyone, but all what we want is to fix the problems our people are faced with. But if it means that we are going to be pushed to a corner where we are left with no choice but to do what we do best, we are more than prepared to do that. But we are not there yet. So I will ask us to rise and sing one song, and then we'll close the meeting. Senzeni na Senzeni na Senzeni na Senzeni na Sono seto ingula sono seto ingula sono seto ingula sono seto engola. Amandla. Thank you, comrades. Drive safely, travel safely, and God will bless all of us here, including those who are online. Amen.